Yes, we can start, right?
Okay.
Thank you, sir.
Good morning.
Ma'am, can I start, ma'am?
Yeah, you can start.
Yes, ma'am. It's a new day, fresh start, fresh energy, new opportunities. Get your mind right. Be thankful, be positive, and start your day right. Honorable Dean and respected Vice Principal, SRM College of Nursing, adorable heads of the departments, distinguished delegates of the today's session, my dear students and fellow colleagues. On behalf of the organizing committee, I'm extremely delighted to welcome you all to the second successful day of the 8th National Nursing Virtual Conference in association with Society for Nursing Practice at SRM Institute of Science and Technology. Before we start with the plenary session, I humbly request all the participants to mute your phone and speaker during the conference. We would like to inform the delegates your queries with regards to the plenary topics can be shared in the chat box to attend to the same. It is with your cooperation we are making this conference a grand success. Now, we are starting with the first plenary session. Now I call upon Mrs. Deena Jyoti, Associate Professor, SRM College of Nursing, to introduce our speaker of the first plenary session. Mrs. Deena, ma'am, over to you, please.
Yes, ma'am. Very good morning to all. First, I thank Dean ma'am to giving me this opportunity to introduce today's speaker. I am very much privileged to introduce Sister Dr. Alfonsa Prasad KK, Professor cum Vice Principal, St. John's College of Nursing, Bangalore, for today's morning presentation. Ma'am completed GNM in the year 1997, St. John's College of Nursing, Bangalore, and post-basic BSc Nursing in the year 2003, Government College of Nursing, Kanpur, and MBA in Healthcare Services, Manipal University in the year 2010 to 2012. Master of Science specialties Mental Health and Psychiatric Nursing, the College Father Muller Medical College, Mangalore. Then doctorate in nursing in the year 2019 under Savita University, Chennai. Ma'am started her career as tutor, lecturer, assistant professor, and professor. Now, ma'am hold a position of Professor cum Vice Principal, St. John's College of Nursing, Bangalore. Ma'am has got 19 years of teaching experience. Ma'am organized many state-level workshops, and also ma'am attended many national and international conferences and published 8 papers in various journals. Ma'am presented 5 papers in various conferences also. Ma'am guided many UG and PG projects and has the panel member of Kerala University and also the Rajiv Gandhi University of Health Science. Under a professional affiliation, ma'am as the nodal officer of anti-ragging committee at St. John's College of Nursing and member in ISPN 2008, member of Trained Nurses Association of India in the year 1998 to till date, and Nursing Research Society of India 2012. With this introduction, I welcome you, ma'am, for your presentation on translational research, aligning knowledge to practice. It's over to you, ma'am. Thank you.
Thank you. Thank you very much, Sugandhi, ma'am, for introducing me. Am I audible?
Yes.
Yeah, you are audible.
So thank you very much for the given me this opportunity to do this presentation. I would like to congratulate the SRM, the organizing team, SRM College of Nursing and Society for Nursing Practices, especially calling us St. John's, one of the resource person, Dean, ma'am, Vice Deans and all the members. Wholeheartedly, I just give a thanks. So let me come.
You are welcome. Yeah.
Thank you, ma'am. Let me come to my topic, translational research, aligning knowledge.
Can we check audio?
Am I audible?
Yeah, we are audible, ma'am. Yes, ma'am.
Next slide to me. Going to the introduction part, the concept of translation research has emerged as is fast gaining attention around the globe. The urgency to practice an evidence-based practice in the health promotion and healthcare delivery system to become the need for the present time and age. And the apt topic you are selected for your SRM National Conference. Translation research, which aims to bridge the gap between the basic research and clinical research, has emerged at most solution to generate evidence and implementing scientific findings. We need to understand the phases. The difficult part is the phases. What are the T spectrum of translation research, and what are the benefits we get when we do a translation research, and from that to draw maximum benefits finding. There is also an urgent need to create a new translationally oriented academy post, particularly in the field of nursing, where lack of awareness of this evolution is obvious. This presentation will look at the importance of translation research evidence to clinical practice for safe, transparent, effective, and efficient health care, and in meeting the expectation of patient, families, society at large. Despite its importance, translation research is in our practice has become increasingly challenging one. There are more nurses in the front line of healthcare comparing to other healthcare profession, because we are the people with the patient 24 hours. So we are in the front line in the research one, but as such, nurse-led research is increasingly recognized as a critical or crucial to practical and effective way of improving the research outcome. So therefore, the focus will be on the role nurses to play in spearheading translation research. That means she needs to lead the translation research. However, we are established so much, but still we have a lot of barriers to conduct the translational research evidence into practice. So my aim is to be like to thorough about that. What is translation research and how nurses can move into a translation research. Translation refers to the application of the result of basic biomedical research. That means basic research we all are doing. And then it into practice into the nursing practice level. How, when it comes to the outcome level, then only it will be a translation research. It is a process of converting discoveries, whatever the discoveries we are doing in our laboratory or in our field, that it has to come into the clinical interest, provide a direct benefit to human health. So, like we can think about that when from these definitions, translation can now occur from the bench to bedside. So much we are teaching in the bench or the pencil to, but it has to reach into the bedside level. Or vice versa, bench to the bedside and bedside to the bench. So often with many journeys in both the way it is going on. So the concept to be very clear that from the translation research mean it has to go from the bench side to the bedside and from the bedside to the bench. Is it clear to you? Hope you understood. So the basic concept, again, the concept is basic research we all are doing. So much researches we are doing in our UG program also, PG program also, in our hospital settings also. But that basic research, it has to come in a clinical touch, clinical level. And then finally, it has to come to the improved health care, health of the person or the human general public health has to be improved. Then we can say that research is become translational research. See, in 2019, coronavirus had come. So from that, when that time, the laboratory basic researchers, people are thinking about what research to do, how to find out a vaccination for that. Then the clinical research in the laboratory lab, we have done a lot of clinical trials. Finally, we concluded with that in the 1 year, almost 1 year it was taken to find out a vaccine. Then it was useful for the people. Then again, from the bench to bedside, it is reached, but from bedside, we are taken a vaccine 1, vaccine 2, then the booster dose also, but still, many of them got it again. So we need to think of from the bedside to again, we have to go back to the pencil or bench side. What are the demerits? What are the problems are there? So that way it has to go. Then only we can call that is a translational research. Hope it is clear to you. So we will see what is the purpose. I already mentioned that it is a two-way process. It has to be from the bench to the bedside. Or it has to from the basic science to a clinical laboratory. Then only it has to come. So it is two-way process. And then what's the purpose of we are doing the translational research? To translate discoveries into clinical application. Whatever the research we are doing, it has to be in a clinical application level. So translation of clinical finding into molecular mechanism. Then it has to come. Translate remarkable scientific innovations has to be taken place. Then accelerate and shorten the process of translate preclinical things to the clinical application. Play a role in monitoring and managing the misalignment between growth in research spending. A lot of research, National Institute of Research is giving a lot of money funded to the research spending, and whether it is going or translational productivity is coming or not, or whether it is decreasing or not. That's the purpose of conducting the purpose of translational research. Aims of translational research to produce new, something to be new. Novelty should be there. We all like the novelty. So the novelty should be there. In novelty in therapeutic area, to find out some medical devices or to use for tools for diagnosing the disease, and avenue for the community engagement. That means finally it has to reach there. So producing some novelty or new things in therapeutic level, medical devices level, tool for diagnosing disease, and finally it has to an avenue for the community engagement thing. Then these are the 4 main aims of translational research. Going to the phases of translational research. We should understand very clearly, it's a difficult picture. That is from usually we used to say T spectrum, translational T spectrum. In that when T0 comes, basic science research. Science level, what are the researches we are doing it? That is the research, basic science research only. One who is searching and finding out new thing or novelty. This in connection with that one, we can say define the mechanisms, target and lead the molecular thing. So preclinical studies and animal studies only we do in T0 basic science or basic research. Going to the T1 translation to human, we should understand basic research to human one, that is the T1. In human, it has to go to the translation 2, that is a patient one. We do phase 1 clinical trials in translational 1, T1, and then when it reach into the T2, translation to patient, phase 2 and 3 clinical trials we do. And then we move into the translation T2 to T3. T3, when it goes, we already translation to practice. Going to the T4 level, that is to the community or for the improve the health. So with one example, we can say the coronavirus, when it had come to 2019, after that the basic research, basic science research in the animal studies we are done. After that one to human, that we just implemented to the Pfizer and then Covaxin, Covishield, all the vaccines level in clinical laboratory it has done. After that when we are applied to these vaccines given to the patient, then it has to come into the practices for everyone, and then now the general public is accepted that, and the outcome research has reached the T4 level. Going to the detail, the basic research, that is again the preclinical studies are there with animal research, basic health science, services research, epidemiology we do, And then T1, case studies, phase 1 and phase 2 clinical trial, human clinical research we do. From there, some policies and procedure, we have to make some policies from there. If the policy before making that one guideline to development, so many meta-analysis and the systematic reviews to be done, then only whether it is applicable or not. Then also acceptance will not be there 100%. Translation to the patient's policy making. So practice-based research we do in the phase 3 and 4 trial, there only the observational studies are going on. Then finally only we reach into the policy. The government is making some policy regarding this. Example, this vaccine to be taken. Then also 100% result is not there, mean it has to go back from the bench to the bedside and from the bedside to the bench. Two-way process is going on. Phases of translation in detail, that is the T1 we are taking it of developing the treatment and intervention, testing the efficacy and effectiveness of the treatment, and then T3 dissemination and implementation of the research system wide. The developing treatment and intervention, mainly we do the laboratory research, epidemiology, psychometric and social science. That is translation to human. In detail, I just, next slide. The interface between the basic research and the clinical research, striving to find how new knowledge of disease mechanism can be developed into clinically relevant understanding, diagnosis and treatment regime to be trialed in human. That means here we do type of studies, observational studies, case studies, and phase 1 and phase 2 clinical trials. Coming to the T2 translation to patient level, testing the efficacy and effectiveness of this treatment. The translation of new clinical science and knowledge into the clinical practice, and from there we make some health decision making. Application of information and insights derived from the basic research and population health research to the provision of health services we do. So we translate it to the patient level. Here the main studies are phase 3 clinical trials, observational studies, evidence synthesis and guideline we develop. Coming to T3 translation to practice level, dissemination and implementation of research and moving evidence-based guidelines. So we can tell that one, like maybe all the clinical trials are not the translational research. All the clinical trials are not the translational research. Then we can say that clinical trials are part of translational research. And then our like evidence-based also practice also. We used to do nurses, we used to do evidence-based practice studies. That also part of translational research, but it is not, it's above. That means from the evidence-based researchers or practices, from there we have to take a step more. Then only we will reach into the translational research. The dissemination studies, implemental research and diffusion researches are and clinical trials we'll do in the translation. So as a whole, we can say the base is basic research. That's a science. From there only we will go to the T1, T2, T3 and T4, outcome research. So as a concept of translational health research has evolved with the practice and time, 4 phases. Hope the 4 phases of translation is clear. T spectrum. T1 is phase 1 and phase 2 clinical trials only. And then phase 2 is T3 is phase 3 clinical trials, value of the application of healthcare practices and develop evidence-based practices or guideline for using the application. Then coming to T3, phase 4 clinical trials. Here we movement of evidence-based guidelines into the health practice through delivery, dissemination and diffusion research. Coming to the last stage, that is T4, outcome research. Evaluate the outcome of the research with the health outcomes of the population, health practices in a larger population. Whether the larger population, whether they are practicing it, whatever the clinical laboratory, we found out whether after the clinical trial, whether it is reached into the practice level, and then the society accepted, and then there. Now see, we have a confusion whether some people are against for the Covaxin, Covishield or Pfizer to take. The efficacy when it is take 70, 80 and 90. That one still confusion that because whoever is taken also getting the coronavirus again. So it has to go from the bench to the bedside. Again from the bedside, it has to come to the, again some more studies to be done to reach the pencil or bench side. This is about the, hope it is clear to you, the T spectrum of how the translational research move. Going to the benefits of the translational research. It encourages and promotes multidisciplinary collaboration. We cannot do like maybe so many like a PhD, our studies, PG studies of nursing practice level, like if we are collaborative with the multidisciplinary and then like a multi-centric study, if it will be more useful if you want to go for a translational research way. In different state, different country, that studies has to be done, and then collaboration with the many people. If you do, and then it is acceptance is there, and then in the controlled lab, it should be done. Here, I feel that one, like maybe we all have done a lot of studies. I have done a study with the biophysiological, biopsychological, and then biochemical variables with the elderly people with the relaxation therapy. But I did not like the control and experimental group was there. And then the hypertension, diabetic, or the lifestyle modification diseases, I just assessed in that study. A lot of biochemical variable difference was there from the time 1, time 2, time 3, time 4, time 5. Within a 2-year period of how much of the different type of relaxation therapy we are given for morning 1 hour, afternoon 1 hour, evening 1 hour, but still it was not in under the control of the controlled clinical laboratories. And then after that one, it has not reached into that much to the public. So I cannot say that study is a translational research is reached. But like now we need to think about that one, how much of when we are doing this type of study, it's supposed to be ICMR recognized one, and then then we need to implement in the multi-centric level. Different centers has to do same study, and then acceptance, and then clinical laboratory level, controlled and accepted laboratory if we do, and then we are translating, we are giving that findings to the governmental level, and then dissemination is occurred, we can think about that studies are become translational research level. Not in 100% level, but still. So as a whole, the benefits are encourage and promote multidisciplinary collaboration among laboratory and the researchers. Second one, incorporates the desire of the general public with the communities being engaged to the needs for health innovation. Something novelty or innovation has to take place when we do a translational research. And the third one is identify and support the adoption and the medical and the health practice level. Going to the one example, just what one translational research is going on in our institution, because you asked me to connect aligning knowledge to practice in our own institution. Being like maybe we are selected as a St. John's level, I just wanted to say our own institution, the translation research level, when we wanted to do that one, what will be the procedure? So one of the studies evaluation of the role of N-acetylcysteine that we call NAC. That's a drug. N-acetylcysteine in novel coronavirus infection, a proof of concept study. This is the one study is going on. that study, like maybe the coronavirus is affected so many people, then that somebody's head it has to come. Some idea has to come. That means we need to evaluate, we need to think. So that from idea how to function mean, we have a St. John's Medical College, we have St. John's Research Institute, and we have St. John's Hospital and the Nursing College, 4 together. So like maybe the whatever the thoughts is coming to the any person, if nursing side also, or the medical side, doctor side, medical college level also, and then we collaborate with the Nursing Research Institute, both the people, mentors will be there, concept will be there. From there, maybe our own PhD students or our own PG student or our doctors, DM or whoever may be, we will ask for a collaborative study, we will ask for a funding, and we'll make a protocol and we'll submission to the ICMR or direct benefit transfer level, and then patent accuracy will check it out, whether this study can be a translational research. Then only the manuscript will be submitting. This is the way we to be done if you want to go for a translational research study. Going to the next, after that, like maybe the research institute will provide relevant infrastructure for us. Then we will prepare the budget, protocols, review and monitoring committee is there. And IRB grant application this is done by a research institute. But we, hospital side, like what we do, provide supportive staffs. Any studies like these clinical trials, or we want to make us a translation research level, we the nurse coordinators will go. One of the professor is the nurse coordinator is helping for this study, evaluation of the role of a concept study. They say like maybe how the N-acetyl cysteine, that drug when we give, how the coronavirus, that infection we can prevent. So then all the other areas also the hospital will support for that. Whether we are getting the fund, if not getting the fund also, but we'll try for the fund. Then the procedure, how to follow that means whether it can come to the RGHS study, our own university level, or it can be become the ICMR funding will be, or from the other institution. Next slide. Other extramural funding, whether we are getting or not, we'll check it off. And then Department of Science and Technology, whether they are giving direct benefit transfer is there from their funding, whether we are getting or not. Then institution level, some funding we kept ready for the translation study. These from the funding agencies. Going to the next one. Next slide. So this is the application we give. Further, we need to do a research, translation research. For that one, some funding agency we have to tie up with that. Next. Then we will approach the how to preempt potential roadblocks we'll find out. And then we do clearly the methodology we will write in that one. And then what the environment we are creating, whether scientific environment, which lab we are chosen for this, whether under the control of, then only they will give us the approval will be getting. What happens after submission means they assign the application to the relevant reviewers. Your grant submission may be passed into SDA, like our own research institution. Then the NDA process normally takes at least 9 to 10 months. That is why our PG students are not able to do this type of translational research. But the PhD students, we can try for it. Then it will go into the, see, in this evaluation, our own study, this study, role of N-acetyl cysteine, that's a one drug. In novel coronavirus infection, in that one, first our efficacy objective is to assess the efficacy of N-acetyl cysteine to limit progression to severe diseases in COVID-19 patient. COVID-19 patients, like maybe the severe level the patients are getting. For that one, like maybe we are trying to that patient, the efficacy, how much efficacy is there. For that one, the secondary objective is to measure the changes in RNA level. For that one, we do the RT-PCR day 1, 2, day 1, and 3 and 5, and we'll see that what are the biomarkers, the C-creative protein, and then interleukin 6 and 13 level, we'll check it up. And in the days of 1, first day, third day, and the 7th day, after giving the drug. So no specific drug exists for the COVID-19. We wanted to find out one new drug. For that, when this translational research we do. So treatment is symptomatic and supportive level. The receptor binding motive of SARS is spike is responsible for its virulence. It has a lot of disulfide bond is there. That is why people are getting pneumonia. So plan is to reduce the virulence by N-acetylcysteine by breaking the disulfide bond and eliminate its entry into the cell. So enter the lungs, the binding thing. So NAC is known to break that means that particular drug N-acetylcysteine, not to break the disulfide bridges, mucoprotein, and it is decrease the viscosity. This property has been used as a antiviral agent, mucolytic. So in that when the drug is given by our nurse coordinator only, and then next slide. See, we are exclusion criteria and inclusion criteria will keep, that is screening the patient doing by a nurse coordinator, and then group 1 and group 2, control group and experimental group. There the N-acetylcysteine will be given 10 mg per kg for the IV for the mild patient. So we will give for them, and then those who are on ventilator we are not choosing, but other patients we give the standard care. Then viral load will be checking with the first day and third day and seventh day, and then biomarkers also will be checked. That is CRP, IL-6 and ferritin level will check these days, and then we'll see that one. How many days they are taken for the admission, how many days they had the fever, and then how much breathing difficulty, like maybe the standard group, and then the control group and experimental group, we will compare how much difference was there. With that one, like maybe we will move into the length of hospital, they also will be checking. Then finally, the final conclusion will read, and then drug will be implementing to the society, so to the human, to the practice, and to the outcome research. So in different level, the forest, trees, and root, understanding translation research at different level. See, the politicians, government, and general public need to understand the scope of the problem. That means this much problem is in the coronavirus. They understood. So some people, like maybe our government expert committee, judges, policy makers need to more detailed to go conduct the translation researchers clinical trial studies. Then what kind of that mean? What type of disease this is, and how can we prevent it, which are the drug can be applied, then all these things they have to do in the laboratory, clinical laboratory, then it has to be molecular laboratory, then only it has to come into the translational outcome research level. So the community level, the people root cause analysis we do. We are the people. Here all the members of who are implementing this one, we will analyze that how many people, all these survey studies are going on connect to the this COVID vaccine. Going to the conclusion level, the translational research is like maybe the evolution of biomedical research and practice in our 21st century. We need to come up with so many translational researchers and collaborative work. It's a multidisciplinary collaboration, we need it. And the key problem that we have a lot of emergence relatively to discover the new thing. So many discoveries to be done, and then still I can say this is very challenging one. Like so many universities or the reputed institutions together can take a decision that how we need to move into the outcome research level or the translational research level. So we need to a joint venture is needed for the translational research. It's a multicentric studies to be conducted. Evaluation will be essential for managing the translational research effectively, learning works and what does not, and being what are the new investment to be done. So the time has come for our country to lead, or we have to get up from the slumber and enter wholeheartedly to conducting translational researches to the general public. So till now we are reached with the evidence-based practice studies or applied research. We are all are doing. St. John's also, almost all the institutions also. And then from there, so we are not reached up to the mark of translational research. And the hope we need to get up from this one, and wholeheartedly we had to conduct a lot of translational researches, and then only we can make a new policy. See, example, like maybe some of the devices, nurses are there with the patient 24 hours. So some medical devices to find out, or some therapeutic diet or something to find out. For that one also we need to go. We can do a lot of translational researches, but multi-center studies to be done, multidisciplinary collaboration we need it, and then like maybe the new or some novelty things we all together we can make, and then that will come as a outcome research. Then that will be useful comparing to the drug level anyway, doctor's level when it using more than that when a nurse do some therapeutic level, some medical device level, and then some tools level to assess for the diagnostic. See, I feel that when one of the study what we are done in Father Muller's, that is workbook for the Mendes examination to do. That one also like maybe we did not do in as like maybe as a clinical laboratory level, and then but that detail, that workbook when it's done in 2006, I think that is still it is using, but we are not undergone all the procedure level T1, T2, T3 and T4. We need to that some evidence based above that. So as a whole I can say translation research is very good, but we need to go ahead from the evidence-based practice to the translational research level. Hope it is clear to you. Do you have any doubts?
Yeah, it's very, very nice and thought-provoking, excellent presentation. So really, I congratulate the Prasada Varghese. You have given a lot of justice. Clearly you narrated what is translational research. So here you very rightly told. So that's why it makes us to provoke our mind to what it is to understand first. So because we are not doing any clinical trials, only with medical personnel and then the pharmacist. So those people, they are more keen in developing a new novelty in the drug or maybe the diagnostic procedures. For example, take it in a microbiology lab. So a lot of people in the medical and then particularly in pharmacy, they used to do this kind of studies. But what is the role of nurses they are involving there? So that's why. So the immediate involvement for the nurses. So all the time, so since we are a caring professionals, then automatically the people used to think, why this is not your job and why you are coming and you are like this kind of disputes will be there. So that and all, it is a barrier actually. And we need to come up. So this time I would like to bring one of our own PG studies. So when I was in Ramachandra, we have guided one student. So that student have some paralytic limb patient, neuro patient. So we devised one Ramba, right angle manipulation of that one shoe type of device we have device for those patients, and very that is a small sample size, and for that and all they are asking for the pattern. So if you ask for some novelty or introducing even within the care aspect, so they are expecting for the pattern. So the pattern, right, it is very, very difficult to obtain from. So it is also another issue for the nursing professionals. So caring within the caring stream, what we are going to give. If you are so if you take a Lydia Hall model, so the care, core and cure.
Yes.
So the cure aspect is taken by the medical professional. The
Yes.
care is by the nursing professional. And core is the patient.
Yes.
So we need to incorporate everyone. So
Yes,
with collaboration, with
Yes.
inter-collaboration of the medical or maybe that other related microbiologist and then mainly the pharmacist, with that contributions only we can able to derive into. So
Yes.
that only it came into my nowadays the collaborative role and multi-centric. So these are some of the output it is giving support for us how to go into the translational research. Primarily as being a nursing, you very rightly told at the master level, their study time is very less. But for example, if we take MBS, even dental college, and for the medicine, in pharmacy, they are 2 years, 3 years at a stretch, they are taking up all the course. Our syllabus and regulations are in masters, it is not highly suited. Maybe the PhD scholars. And for example, if you take a PhD scholars in nursing also, the true full-time PhD scholars are very minimal. So the people are
Yes.
not opting for to coming for the PhD straight away and leaving the job. So it is another issue. And then
Yes.
people are not coming. But for that outbreak only, our university, they are promoting the full-time research. So they are expecting the full-time research. The full-time research, equally they are paying for that tutor level of salary. Now more than that, I appreciate and we are fortunate. So that 25,000 per month as a stipend. So it was there for 15,000 earlier. But now they improved the stipend status to attract the full-time scholars in nursing. How many people are coming for to take up?
Very
So
good.
that is the question. If you take
Yes.
this full-time, and I am encouraging, and I am whoever maybe the people who are coming as youngsters, I encourage them to put into the full-time research. And then really they know what is the methodology, what are the new novelties we can bring into. So those things, it is our idea. And I encouraged, and 2 students already have joined here as under me as a full-time research scholar over here. So these are some of the good note where we can take up this translational research with the help of a collaborative. So these are some of the things we are improving.
Yes,
And
ma'am.
really you brought everything in a nutshell and in a clear manner to understand by everyone. So really I congratulate.
Thank you.
Sister,
Thank you.
Prada, very nice presentation. Thank you so much.
Thank you, ma'am.
God bless you.
Thank you. Thank you so much.
All your team convey my wishes to all your team of St. John's. We will get any help from your side later on. If necessary, we will include yourself also to be as any of the multi-centric. If we want to have also,
Yes.
we will have collaboration with you. Thank you so
Okay.
much.
Thank you, ma'am.
Thank you. Thank you.
Ma'am. Thank you.
Thank you, madam. Thank you, madam, for
Thank-
sharing your expertise on
Thank you.
translation research. It really put us in lively session. And to be very frank with you, I have an experience of doing clinical trial, which pushed me to the bedside and bench. And that you brought me into my screen. Thank you very much for that.
Thank
Wonderful
you.
session, ma'am. Wonderful
Thank-
session. And we have a query from the chat box. Would
So
like to
here
share
I
that,
would
ma'am?
add one thing. Dr. Kavita, she did her full-time PhD in Ramachandra.
Yes,
So
ma'am.
that's
Good.
why I have recruited here, and she is helping me to develop the research in our SRM College of Nursing under my guidance. So it is our
Very good.
vision. Yeah,
Very
we
good.
are having a good vision, and we have 2 PhD scholars now for the full time. Even for the next year also, anyone who is willing to please kindly refer to us also as a full time. We will support and let them also get benefit out of from our university. Thank you so much. Thank you.
Very good. Very good. Congratulations, ma'am.
Thank you.
Like we also have a co-guide we will be taking from our medical college doctors only. That's why we are getting a lot of collaboration.
Yeah, that
For
is
the PG study and PhD studies.
yes.
So
Yeah.
like whatever we, our idea, they are encouraging us to do that area. So they
one
also
thing,
nurse coordinators are
one
going.
thing I would like to know about in this study, what is the nursing college or the nursing personnel role in this study? So that I would like to find out from you. Yeah.
Screening the patient mainly done by the nurse coordinator. One of the
Okay.
like almost we all are the staff, sir. One or another. Like maybe the clinical trial or translational research studies coordinators. So we
Okay.
are the nurse coordinator. So we are giving the injection. We are the one we are giving the injection.
Okay.
And then we are the one like maybe with the doctor we are assessing all the like how much whether we prevented, how much evaluation is done by the nursing side also, doctor side also. How many days fever is reduced, all the things. So all the aspect we are helping them, and our finding we are giving, and we are getting the funding also. If it is that study with 1 crore amount is government is given, mean that fund will be getting equally to the pharmacist, the doctor, concerned doctor, PG doctor, and nurse coordinator.
Very nice.
We are receiving it.
Very nice.
Yeah.
Okay. We will also have a good idea how to have this here also. Even in microbiology, we have tried with the HOD madam, now the vice principal of medical college. She is also very highly cooperative. And then from pharmacy also we can try. And we are fortunate, we are having an even the engineering field to develop some electronics and any app and other thing. They also will extend. They are ready now to have a collaboration with us. So these are some of the forum. Our SRM is like a banyan tree. So it engulf even their logo says. So we have a lot of discipline. We have to use it effectively. So that's what we are keep trying now. We are just a budding in nursing, and we are trying now. So to the most possible, we will try.
We also, ma'am.
Yeah, we will do. So definitely.
Thank you, ma'am.
Thank you so much.
Thank you,
Okay.
ma'am. Ma'am, there is
Thank you, ma'am.
one query
Thank
in the chat box.
Ah,
Can I share, ma'am?
Yes.
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 Ma'am, there is a query from a student asking for the duration of completion of translational research. Approximately how much it would take.
It's supposed to be minimum 1 year. Minimum 1 year. It can proceed into till 2 year, 3 year, 4 year, 5 year.
Yeah,
some of the studies still. Like with our studies is minimum 1 year we put.
So that is longitudinal, no. So it will be like that only. Yeah.
Yes. Yes.
Thank you, ma'am. Thank
Yes,
you for.
Is it clear?
Yeah,
Yes, ma'am.
it's
It's very clear. It's
Thank
very
you.
clear.
Thank you.
Thank you. Thank you so much.
Thank you.
Yes, ma'am. We shall move to the next session. We don't grow when things are easy. We grow when we face challenges. So welcome the challenges. Look for the opportunities in every situation to grow in wisdom. Now I call upon Mrs. Selva Mary, Assistant Professor, SRM College of Nursing, to introduce our eminent speaker for the second plenary session.
Thank you, ma'am.
Sudha, good morning. Has joined, no, Sudha madam?
Yes, good morning,
Good
Kani ma'am. I'm
morning.
here.
Good morning. Good morning, ma'am.
Good morning.
Yeah, good morning.
Excellent session by Sister Alfonso. I was just.
Yes, madam. Yes.
Yes, yes.
It's start with a very good note.
Yes, ma'am.
Yeah, yes, ma'am. Thank you.
A warm good morning to everyone. I'm very delighted to introduce Professor Dr. Sudha Reddy, madam. Madam has graduated BS Nursing from College of Nursing, Armed Force Medical College, Pune in 1992, MS Nursing from KLE Society College of Nursing, Karnataka in 2000, MPhil in Nursing, Manipal University in 2006, and secured first rank in the course. Madam completed PhD Nursing in National Conservatorium, Rajiv Gandhi University of Health Sciences, Bangalore, and Indian Nursing Council. Madam worked as commissioned as a lieutenant in the Army Military Nursing Service as a permanent commissioned officer in 1992 and got voluntary retirement from Military Nursing Services in 1995. Madam has 18 years of teaching experiences. Madam received Best Research Award, Best Teacher Award, honored with Gurukula Chakravarti Award, honored with Teachers of Teachers Award. Madam had authored 2 books. Madam holds membership in Standing Regulation Committee of International Confederation of Midwife for Southeast Asia, adjunct professor at Thompson Jefferson University, Philadelphia, USA. former Vice President, Elect Society of Midwives India, founder, Principal, Kells Institute of Nursing Sciences. Part-time project coordinator and academic counselor for Indira Gandhi National Open University for BS nursing students. Visited to Norwich, UK as a part of UKRI project. Participated as SOMI leader in exposure visit to Sweden. Indian Nursing Council ad hoc inspector for College of Nursing. Inspection review committee member of Karnataka State Nursing Education Board, Bangalore. Expert member of UGC inspection. Principal investigator for funded project on mental health for postpartum mothers with Thompson Jefferson University, Philadelphia, USA. Madam has been editorial board member for various journals. Madam received research grants for various projects. Madam guided PhD students in various universities. Madam published 39 international publications and 70 national publications. Madam has been resource person, organizing chairperson, presented paper in international, national and state and local conferences. Madam has having membership in various professional bodies. Currently, Madam is working as a Dean, Faculty of Nursing, Principal and Professor, Institute of Nursing Sciences, KLE, Academy of Higher Education and Research, Balgavi, Karnataka. We welcome you, Madam, to deliver keynote on current and future education challenges on nurse educators. Over to you, ma'am.
Hello, ma'am.
Excuse me, ma'am.
Yes.
Before we could start the session, one request. We would like to take this opportunity to share the memento of certificate to the previous speaker.
Okay. For previous speaker, Madam.
Yes.
Sister has left.
We request,
okay.
Madam,
And she is
Dr.
on mute
to
now.
receive the certificate. Thank you, ma'am. Ma'am, now we invite the speaker to start with the session.
Thank you, Sugandhi ma'am, for introducing me. Good morning, Kanimal ma'am, to you and your whole excellent team of faculty here. And my greetings to your Honorable Chancellor, Sir, Pro-Chancellor, and the other university officials too. And it's a very excellent topic which you have selected for the 8th National Conference of yours. And before I start, will you be sharing the slides for me, Sugandhi ma'am?
Yes, ma'am.
Sure. So I'll keep telling next, and next. Fine. Yeah. And then you know what, like I just wanted to add up that this in translation research, interdisciplinary research is the new norm now. Like, so we have 2 full-time PhD scholars. We have 2 girls who are doing on vaginal microbiome. So they collect the vaginal swab and go to the basic science research lab with that kit and they do the cultures there. So that is one example where it's happening. And then we have a lot of collaboration with the engineering college where we are developing patents, you know, a simple ampule cutter or a Covishield mask where, you know, you have a Bluetooth. So the doctors and nurses do not have to, you know, even touch the patient. So a lot of respiratory conditions, the lung conditions can be made out. So that has been published and patented, waiting for commercialization. And so these are small little things like Sister Alfonso said, clinical side, we work, so we know what we need. So if we tell them to the engineering college, whether it is the mechanical division or the CS or the, you know, they're very intelligent. They will just take up your ideas and they will do it.
Yes, yes.
Like, yes. So that's one good thing which is happening. Like I thought, like in our OBG lab, we want some episiotomy suturing models which are cheap and easy to make. So we have told them, if you can give 100 of them to us, 100 IM injection ka small little things, spongy things, which, you know, so those things we can really innovate and update our labs and also the clinical. Now coming to this topic, which has been given to me.
Yeah. Thank you, ma'am, for sharing.
Yes.
Thank
Yes.
you. Yeah.
The challenges are more in nursing education today, because you know what has happened is we have a real wealth of methodologies with us, curricula, different models, simulators, as well as other current technical breakthroughs that allow the nursing teachers to teach a class and impart clinical information from thousands of miles away. That's what is happening now in the COVID era. We have learned how to digitally be there with everyone. These developments bring with them new issues, you know, some of which are unique to the online realm and were unimaginable 2 decades ago. Next, please. So now what is the current online education scenario? Like, how does one teach from a distance? And how can the nurse educator ensure that the student on the other side of the computer is in fact who they say they are? And what about the cost of this kind of education? We start from these basic things. So current challenges globally, I will talk about progression of matriculation, or graduating from a traditional classroom based to web-based educational programs. Lot of academic preparation of adequate number of RNs to meet the growing healthcare demands. You see a lot of statistics. You need so many nurses, this, that. In this COVID admissions, how to educate, they come for 15 days, they go back. So then this kind of preparation is a challenge. And this rapid pace of healthcare changes, which demand almost constant reassessment of the nursing curriculum. That is why INC has come up with the competency-based syllabus, and it has given excellent way how you can teach each and every module, each and every topic. And then recruitment and retention of qualified nursing faculty is a big challenge because of the salary issues and other issues. And in India, if you look, socio-demographic, cultural diversity, economic and political changes and global issues. The nursing draft is still pending. We are waiting for the National Nursing and Midwifery Commission to come out. But a lot of political, upper house, lower house, we don't know where it is stuck now. We have increased aging population. So do we cater to them in our curriculum? What is the impact of globalization on healthcare? Are we teaching our students the diplomas, the BScs? Like already we are 3 years into it now. Client care has become an industry. Hospital is an industry now. It is not like you have a patient and you're a nurse. It is a money generating industry catering to a wide diversity of patients. And clinical teaching strategies in India, we are stuck with the whole bedside thing. If you look at some softwares which have come up now, like ProQuest, it has clinical nursing videos, teaching material, journal clubs. So we need to update ourselves with that, isn't it? Next slide, please. We have increased shortage of nurses and faculty, because if you don't have the proper ratio, neither the nurses can work in the ward and handhold your students. They'll be running around doing their work where they have time to mentor, sign the logbooks for your students. And faculty are ever, we don't have like medical college, preclinical, clinical, and paraclinical faculty who are always there in the college. Only the clinical is 24 hours in the hospital. We only are pre-para and post, and everywhere we are running around ward, college. It's very difficult. Disasters, violence and terrorism, do we ever think of this in our curriculum? Like how to manage, the Mumbai attack, how the sister was there, how she managed the people from labor room, that antenatal mother delivered a baby. So all these things, like by experience, because she was an elderly nurse, she was trained in government. But now, do you think any of our children can do that? They'll run away. Like that kind of training. Rapid knowledge expansion, which is this increased use of technology and informatics. Today is the era of AI, artificial intelligence, big data, cloud computing, storing in cloud, buying cloud because your Gmail is over. So all these things as nurses becomes a challenge for many of us, and especially elders and elderly like me and others. Like we are not very techno-savvy, but still we are trying to cope up. Then practice-based competency, that is outcomes and evidence-based content, is a big challenge, because half of the nursing colleges in India are like without a supporting parent hospital or medical college. So they are all running different kinds of courses. Nurses are not getting trained, on hands-on skills. And we are the only ones who force our students go to clinicals, force our teachers go to clinicals. They don't go happily because it is not a universal norm in INC that, whereas doctors have their own way, like they have OT days, OPD days, round days. They are equipped with the newest clinical things. We just stick on to some downloaded PPT, some old books in our library. So we are very much distant from the real world, the nursing teachers in India. Performance-based competencies, another challenge, isn't it? Learning and objective assessment methods. Like we really need to know how the teacher is assessing, not only having a checklist to assess the student. So now in the new NPM curriculum in INC, like we were going through the e-mentor module for these nurse practitioners. Excellently, they have said how will the mentor assess, and there is a checklist for that also, which is going to come. Then community focused interdisciplinary approaches. Where are we? We go in bus, go to community, do some house visits with one old community back, come back. Are we there in the PHCs, participating in the National Health Mission programs? Do we know what is adolescent sexual health and reproductive needs? Do we participate in the menstrual hygiene schemes? Have you ever seen how they distribute pads? Have you ever intervened that why the supply and indent is not coming? Can we help them in some way? the iron and folic acid distribution in the schools. Do you know who are the peer educators or Satya? So we only stick on to our things. I'm glad INC has introduced all this in the curriculum now. And patient-centered care, like engagement, safety, privacy. Do we know what are WHO patient safety guidelines? Do we know NABH? Only few hospitals where our students get to will participate. So these are the things, the huge thing about ethics and bioethical concerns. Wherever nurses practice, they educate, they do research, they teach. You should have these bioethical concerns. Do we? Luckily, we have a collaboration with one university in Ethiopia where we teach this value-added course on bioethics. We are going to put it in a platform where everybody can use it. Increasing professional and personal responsibility, isn't it? How much to do? How much should each and every person do? The principal, the teachers, the tutors, and the responsibility we have over our own family. Can we find a balance? Lack of promotion and opportunities for teachers. In government, they are frustrated. Like in AIMS and all, you become senior and retire. You don't get to be the principal. And I don't want to talk about the private sector in this platform. It's not right. But these are all the challenges. Poor physical, educational infrastructure and resources for clinical skills teaching. You all agree with me. Many nursing colleges open the skill labs only during inspections and try to brush up, dusting, cleaning, and all that. And very few colleges who are quality driver have lab teaching classes in their timetable. They have budget for buying mannequins, high, middle fidelity mannequins, and having this kind of training. The new competency-based syllabus forces us that we need to update our labs, have a huge common clinical lab in the medical college campus where we all can also get trained. And of course, lack of proper clinical skills, teaching and training. All our teachers pass, they join us. Nobody goes to go and trade, work in the clinical and then come to us. So that is a very big challenge. Next, the regulatory body for nursing education and services. Are they fair? Are they catering to these challenges? Are they helping us out? Because we don't know whom to look at, who is there for us. We have INC and state nursing councils. Their responsibilities are regulation. And other than that, providing us with guidance and services. Is there any other organization? TNI is there for combined, advocacy, bargaining and all that. But then we need some specialized branch in the state nursing council which would help us, guide us with this, be vigilant, stringent with the rules. Separate university for nursing profession is a big question. Every minister talks in your graduation platform. Everyone says, but it is not happening. And monitoring the quality of nursing institutions regularly, nursing students' participation in medical research projects. Medical students do ICMR projects in groups and they get at least 5,000 for a group. Do we do that with our nursing students? Do we allow them to fund? There are BIRAC funding, there is ICMR funding. There's a lot of internal funding and external funding. Do we even know about it and allow our students to access that? And the link between, the nursing department and digital media is so important. We need social media now in every way to brand us, advertise us, project our webinars. We are doing this in Facebook. All this is there. And what is the future of nursing now, which is going to happen is the changing demographics and increasing diversity. One very confidential thing which is happening is I read it somewhere in Daily Hunt Telegraph news that because of the nurses attrition, nurses going away from India, because now OET and NHS recruitment is free, they're training and they're getting away. Now India needs nurses. So we are tying up with Japan. We are tying up with Singapore, we are tying up with Fiji, Philippines. We want them to come and work in India. So they say that in northern east state of India, they are tied up with some colleges where people from Japan and other places will come get trained. And this is happening. So look at the irony. Our nurses are going out. We are trying to get into it. But I'm very happy because if this happens, some standard will come to nursing education. And, salaries may increase slowly. That we presume as a nurse leader that if this happens, some changes may happen. So this is what is a new in nursing today. Globalization of the world's economy and society, era of educated consumer. All our students are very smart. They have mobiles, they know how to operate computers, they know mobile app learning, alternative therapies and palliative care is going to be the new and shift to population-based care and the increasing complexity of patient care. You know now, COVID, Omicron, COVID rehabilitation, all this is a challenge which is not there in the INC syllabus. So you wait for the INC to change the syllabus, or you, some of the deemed university, because they have the academic flexibility, immediately put it in their syllabus. So these are the new things which are going to happen. Next, please. And the cost of healthcare, the budget you saw now, how much they have allotted to healthcare, and that is a big challenge. Impact of health policy and regulation on nursing education and practice, the growing need for interdisciplinary education for collaborative practice. Sister Lanfosa said so much about it, because it is not in the scope of my slide. I won't talk much about it, but we all know this is the new which has to happen. Otherwise, we will be at the bedside, others will take over us. Significant advances in nursing science and research, like AI in nursing. Why there is AI in nursing happening? There are the invent of robotics, how to operate them, paperless hospitals, paperless wards. I've seen in my visits to US, everywhere. The nursing sisters are like, they are also from the old realm, but they all are practicing this paperless cases there. There's no case paper in the bedside. The other future trends which are going to come, and which is a challenge for us in India, is increased collaboration between nursing practice and nursing education. Here we need a bridge. We need to step on that and reach the hospital. We have to push the teachers out of their offices and rooms and tell them, Papa, let's go to the hospital. It is just 100 meters across your college. Please go there, be with the students. You learn yourself. It is a big challenge. I remember when I had been the principal newly year 2009, I had faced a lot of challenge, because there were 7-8 seniors, and they surpassed them and made me the principal. Some months went only in doing INC, increase of seats, UGC. We had come newly under the university. We had to undergo UGC. I was just a teacher and a HOD of a small OBG department. Suddenly all these on me, getting that done. Once that got over, I used to tell the teachers, please go to the clinicals. So when I want to share this experience, because this happens in nursing. And then when I came to know some seniors are sitting up and gossiping early morning in their departments, I called them and I said, don't you think we should all start going back to the clinical now? Because UGC is over, INC seat increase is over. We have come under the deemed to be university, things are over. Then they came, 2 of them came to my room. They locked my room from inside and they told me, what the bloody hell do you think of yourself? We know that by hook and crook you have become the principal, and why should we listen to you? And they created a lot of problems for me. But I am from an army background. I have worked in the clinical side and come, and I had to do what job was given to me. Thank God, because of that dedication, honesty, I'm surviving today. But now you go and tell any of your teachers in your college, you will get the same response. They say, where is it written in INC that we have to go? We are working in a medical college, affiliated hospital. So you're telling us to go. What about those many colleges in Bangalore, Andhra, TN, where this distance education goes on? Do those teachers go? They go only for flying squad, paper valuation, observer duty, and they make so much of money. Why we are only forced to do everything? This is a real truth, and I talk this on a platform. It's a challenge for the administrators, but this is the need for the hour today. Increasing the collaboration between nursing practice and education, increase emphasis on collaboration between the different healthcare disciplines, along with physiotherapy, along with Ayurveda. We can have a midwifery-led labor room. The Ayurveda will teach the Garbha Sanskara, and they put some nice powders and all on the, this has been happening since ages. Different kinds of massages, different kind of positions. If you have a physiotherapy friend with you, and the Ayurveda and the nursing, we can tell the medical colleagues of ours, if we are strong, we are 3 of us, you please come and be there. We will do, if there's anything wrong, you just help us out with a low risk mother. This is the thing which is going to happen now. That is how PM Modi has started the, normal birth campaign, and this NPM has come up, the nurse practitioner in midwifery, which is a huge thing. Now the national level training is going on. And dear friends, after some time, when it starts at state level, in another 3 years, we need 88,000 midwives in the sub-centers, PHCs, and all. Now they go only for CHO posts. Tomorrow they will all leave you for the midwifery posts in government sector. So it's a huge challenge now. increased development of educational products for faculty and students. It is a time when with the fees we collect, we pay, give them all iPads or, some kind of tabs, so that, that is a new normal now. Like blackboard and chalk is going to go away, and increase student and nurse mobility. Students need to move from one place to other, have a lot of elective placements, go to the prisons, go to the different care communities which are there, blind schools, not all the time be in the college and in the hospital. Next, please. The next slide, please. Yeah. And then there's going to be increased distance online learning. It is welcome. Our friends outside, they all do masters online only there. All their nurse practitioner, other courses, mentor course, they do online working as staff. We think, oh, being in college, doing regular learning is only normal. No. Now online has come up. We have Coursera, we have the national platforms, we have Moodle. We are trying to tie up with some other learning management system and trying to do this. So this is a new, everyone except we all did NPTEL online. We went to some engineering college and gave the exam, basic fundamental research, which is a compulsory thing nowadays for the research scholars, faculty. So online is accepted now, and schools of nursing providing ongoing professional development. I remember a team had come to me from Malaysia for some, we have a Malaysian medical college. So they came to look at the nursing school, and the person was going on asking me, do you have online courses for the hospital nurses? I was wondering, what online courses? Hospital nurses are getting only 10,000 or less, where they will have computers, mobiles. Where do they have the time to, get into and learn? And we are not taught how to do online. This is 10 years back, I was thinking, but it happens everywhere. Yesterday, I was in a meeting with Royal College of Nursing and Thomas Jefferson University, London and US, and us, because we are partnering on the first ever postdoctoral courses in India. So we have 10 fellowships which we have tied up, and we are going to start that with RCN. So she was introducing us to the RCN website. And you know why I'm telling you the challenges? I was traveling from my mama's house in the evening in the car. I just wore a shabby churidar and all. And then I had to connect because my Google Calendar told me your meeting is due. I had forgotten about it. So in mobile, when I tried to connect, I didn't have Microsoft Teams downloaded in my mobile, because I always have a laptop and computer in the college. There are people to assist me. On the way, airport is in a rural area, so my parents stay there. So on the way, I downloaded the Microsoft Team app. I connected to them. I said, yay, this old lady can do something. Like I connected to the conference, and then I continued. Then it continued in my house. And we know how the modules are. They taught us how it is. So, this is what is required now. And increased teaching of evidence-based practice. We have so many conferences happening, but where do we teach it actually, evidence-based practices to our students? This is the latest thing. Till we incorporate it, India will never rise. We need another 100 years to match our partners in UK and Australia and US. Next slide, please. Clinical education in nursing, what happens here? All the teachers are very fearful. They tell, what will we do? This principal is mad. She's forcing us. You go sign a register there, go to the ward and stand. What should we do? Students are making bed. The ward sisters are taking round. I'm a teacher in an apron, in a sari. Why should I go and attend the rounds? And even if the sister is busy in a room, you shout and call her, but you don't want to go for because you don't have the knowledge and experience. You have never worked in the ward. So you have that fear. And the students are not ready because they don't have teachers with them. No, they don't know what to do in the ward. They will hide and stand here and there. The ward in charge will yell at them, do this, do that. They don't know how to do it. Incompetency of the clinical educator, I told you. When I was a student in the army and I was a cadet, and when the phone used to ring, we were so scared to even go and pick up the phone. They taught us everything, like they taught us process recording, but they didn't tell us how to pick up a phone and say hello. So all those things, now it is in a different level, like incompetency of the clinical educator, unpleasant atmosphere of the clinical environment. You are a young student of 16, 17, 18 years. You see a patient in casualty, alcoholic who is violent, he's tearing his clothes, trying to show off his private parts, he's drunk. You yourself get scared and run away from there. So these are the challenges if you don't have mentors with you in the clinical side. Next, please. Some strategies, I know they may not work, but let us not lose hope. We can still try to do some nursing education model and methods, improve the communication between faculty and the practice nurses. hold orientation stage at the beginning of training. We have finishing school in the 4th year. That is an innovative practice for us. Internship, 100 students in the hospital, impossible. So what we do is we try to put some of them in finishing school in the all labs. They get oriented to the fundamental lab, IM, IV, Rice tube, catheterization, dressing, simple things. I said, reskill them. We have orientation program in the hospital. I'll tell you some of the best practices which we have practically. We are not experts. I face challenges. I'm the only one who has a dual role in a real sense. I'm all the time in the hospital struggling with things. I can't force my faculty to go there. They go and they come. I'm thankful for that. But still, it needs to be done more. So this is my college. Next slide, please. We have a competency-based PG residency program called NPCC. Why I'm focusing on it, this is because this is an example where students are 24 hours hands-on, excellently doing what they're supposed to do. But big challenge here is nobody wants to join such a competency-based program because they don't know how they will be placed, how much salary they will get. You think if I tell them give these students 75,000, they are giving to the Ayush doctors only 15,000 and trying to put them in ICUs where there is lack of staff, then where will they give 75,000 to my staff? Still, they give them better than the staff nurses. They are working and they do all this. Today, I have a COVID webinar going on. It starts at 11:15. I have to give a keynote address. I have 2 intensivists of mine there, and I have people from a Ethiopia University with whom we have collaborated. My medical surgical faculty, we are trying to do that. But then this is happening, there are challenges. People don't get admissions. I don't allow them to wear nursing uniforms. You look at all of them. They are my NP students. They have a different this. They have their set all the time around their neck. When I go for rounds, they are in rounds with the intensivists. I wait for them. I said, don't, please you do, because what you're doing, I don't even know to do. I'll come show off and say, oh, I've come for rounds. I will hardly know what to ask for the patient. So that is where I have reached now because of my administrative things. But it's happening. They do all this. So this is one way where, the new competency-based syllabus for the UG program is going to be a huge hit if we really practice all these competency-based things. Next slide, please. Skill labs are updated. We have a lot of mannequins. We have a separate budget where we get high and mid-level fidelity simulators. In every 4, we have in every quarter, we can have purchase committee meetings. College level, we have management representative up to 50,000. We can buy it college level. After that, it goes to the university purchase committee. So we buy the mannequins. No one says why you're buying, why is it required? They are allowing us. You need to tell your management, if you can't equip your skill labs, then that is the biggest challenge which you can have to update the skills of the students and teachers. Next, please. So this is the clinical training area, which you also have better 2,400 beds, 270 ICUs. All the deemed to be universities across India have these facilities, and some of the good nursing colleges who are not deemed to be universities have a training center. But think about many others who do not have, who just run it like that. So they are the biggest challenge because their students get 90 out of 100, 88 out of 100. We give our students only 60, 65 because we are very stringent, So then next, please. Next, please. So some of the clinical posting photos, some of the bedside teaching which happens, we have to do it. This has to happen. And we have this involvement of teachers in the COVID pandemic training for nurses and the supportive staff, because this is the least we can do during that time. We can't go and work with PPE in the ward, but we can at least see. And this helped because after this training, nobody was infected in the first wave. 2 got infected before this, but then it really helped. These basic things we can help them with. Mental health challenge. This is what we teachers can do very well. We can teach very well. So if we do this and help them, because they are busy, short staff, they can't do all this. So if we do this, definitely it made a lot of difference. Security, lift, peons, them also we train. Next, please. You need to have a huge library with good number of resources. You need to have comfortable hostels which are near to the hospitals where they can go, change, rest, eat food, come back. During COVID, we had a library in the hostel because students were not coming to the college, shifted some 825 books to the hostel. One teacher was made responsible. So these are the background things. This is an important slide because we started, see, practically telling you what we have done, and you reflect when I talk what you're doing, you feel, at least we are all together somewhere. That is why I'm showing these slides. So we started this because, buying a learning management platform by our universities is a costly affair. So we tried Moodle. You have to pay for Moodle? There's no space. So we linked up with this Janvi Nilikani Foundation. They have Astrika and Astrika Sphere, which is an e-learning platform. So it's a free platform. You can upload your videos, your value-added courses. So we are in the process of doing that. So we will add our value-added courses in that with a Keli logo and Astika logo, which will be available free of cost to anyone across India who accesses them. One. Second, they already have some courses, so our students take them. So this is what we have been doing. And then this new challenge, innovative teaching, learning, evaluation methods, we need to teach problem-based learning. Our teachers need to know. We have been learning it from the Medical College of USM because they have a Harvard-based training, the Malaysian Medical College. It's still a challenge till now, successfully, except some units here and there, creating triggers and all that. PBLO is a new thing. App-based learning, now all of us know the INC has launched it. The Maternity Foundation is doing it, Dr. Tarun and Bright Mary and others. So we need to have it compulsory in the 4th-year course now. One batch of our students have done it, but it is the Safe Delivery app. OSCE stations, you need to teach your teachers, you need to have Viva cards and questions there. Then what to each student. DOPES is the new assessment and evaluation, that is the direct observation of procedural skills, the mini CX examination. They have a format, you just can't do it and say we are doing it. So what we do, we can't tell the whole syllabus. You do one unit in one topic, specialty wise. We say this will be done in this way, by this method. So we learn and then implement. You have to train your faculty. If you don't do FDPs, how will your faculty learn? So INC has this reference simulation center at SGT University in Gurgaon. So we have sent 5 faculty there for training, and universities sponsored half of it. Some universities will be kind enough to sponsor the whole training, but our university said, okay, we will give only this much, half of this and half of travel. Still they happily went. So this kind of things have to happen round the clock. You look at the INC website, this training and midwifery training is going on. One faculty, 25,000 free INC pays. 4 faculty, you tell your university to pay half, travel. So all these things are required behind the challenges. So I just thought if some experiences I will share, then it is interesting also, and people will think we are also. So we have to do different kinds of FDPs. We need to strengthen our Department of Nursing Education. How our MCI DAMES, Department of Medical Education, are regionally recognized by MCI or NMC now, and where is done in different colleges. So some of us can have a very, very strong Department of Nursing Education. We established in 2010. We do a lot of lectures, hands-on skills. We have very good people who come. It's not that you call someone across the hospital and some staff from here. We have people from Sultan Qaboos, Sri Devi or SRM, Rajni Baga from National Health and Family Institute. Like, we learn from them really. And this is about the finishing school, which we do for the final years. Reskilling of procedures has helped up to some extent. And it really helps because we have to do the mid-level healthcare provider course then and also do this. In the end, just a very humble conclusion, nursing education is definitely experiencing changes continuously, and we educators must identify, find the remedy from enabling, encouraging, and coaching the students to succeed. Nursing education continues to be a dynamic field. That is why we all survive. We are excellent nurse educators, no doubt about it. But it is incumbent upon us to inspire our charges of the students while challenging them to deliver competent, culturally aware, and evidence-based nursing practice. Thank you. Next slide, please. I hope it's some of the references. Next, please. Next, please. And a thank you from my students, both all my students and my nurse practitioner students, my faculty, all of us. Anything to be done collaboratively, we are with you. Thank you so much.
Thank you, madam. Ma'am, can you kindly unmute, madam?
So very vivid and very excellent presentation, ma'am. It is a feast for the morning session. So previous one and now the second session also, it is a really eye-opening sessions. We all the nurses and then the faculty, we need to equip first. So that is the one we need to understand. And I feel that difference, ma'am, after becoming an administrator. So due to lot of work, we are away from the bedside. So that's why we are losing. Actually, when I was as a teacher in Ramachandra, 10 years, I used to be most of 90% of the time in the clinical area. So only for hardly 1 or 2 hours, I will take up the theories in every day. The rest of full hours, I was in Ramachandra for 10 years. So it was a very good time. And I had the experience as like you, the armed force training. I was in a government for 15 years. So that is an added advantage for me. And 10 years in Ramachandra. So that clinical backup only, it makes me to become very confident in dealing things. And I can able to direct, I can able to sense, I can able to assume things or analyze things. For all these will come only from the clinical area. So all the challenges which you have faced, I too also faced here. So I was so a bit enjoying your very nice presentation. You share, you are as like me. So even the selection of your PPT, I used to have this kind of a PPT, color choosing and everything. So usually I do like that, ma'am. So really, you are very great and you are a very good leader and administrator. But the institution is blessed. So the institution is blessed. And you are bringing a lot of laurels to that institution. Definitely, our nursing professional who is going to get benefit from your side, it is marvelous, ma'am. They are fortunate to have a good leader. And here also, we are trying, ma'am. We are trying. And we have a very good simulation lab. Our teachers are going now. And they are taking up the, already they trained people, 6 people were there. And the rest of the people also now going in turn, and now they are developing our simulation from medical college. They are extending a good support for us. And now our teachers are slowly, they are emerging into that. And definitely we will also gain through all the skill learning. And for the INC, at least 1 or 2 people, I visited that lab during that workshop. And we want to check through that, whether identifying the people, and we need to send. So that is another point you have given clue for us, really. And LMS. So with regard to LMS, already the medical college, they have included in their curriculum. And they have also, and our management, our pro-chancellor academic is much interested in developing the quality. So definitely they will help for nursing as well. And they are telling about to introduce slowly for all the discipline. So we also will grow in such a nice way. And one more thing, last year during that COVID lockdown time, so itself, the LMS was oriented by one of our speaker from Sultan Kabu. I think some quite one of our student from Ramachandra, but she was a faculty in Meenakshi, Dr. Vidya, and she was my PhD part-time scholar in Meenakshi as well. She is highly motivated and belong to medical surgical nursing. I'm very proud of her, and she introduced that about all theory component of LMS, and she narrated about a lot about LMS. So it is a eye-opening. So last year itself we had that thought, and she was telling about it is a very good, excellent platform, ma'am. So you too also can have for your university like that. She was also telling, and you are also implementing now. So it is a real boost for us, and our we can also approach our university. We will get it done, ma'am. Thank you so much, ma'am. With all your lively examples, with your college, with your team. So we enjoyed. I thought the feeling I have visited your institution. Now I want to have an idea to
Yes,
come
ma'am.
to your institution
Please,
to
ma'am, I'll
visit
invite
you.
you.
So this
I'll
is
invite.
what I had within my mind to come and visit to your institution, ma'am. Thank you
You're
so
most
much,
welcome.
ma'am.
Thank you, ma'am.
so much. May God bless you. Do well, and many things you have to bring such like a vivid, committed person. You are a committed person for the nursing. Definitely you will do, and we all will have a collaboration all that time. We will discuss with you, ma'am. We have a lot of ideas in research and implementing some innovative technologies and everything. It is in mind. Only thing, the barriers, now the COVID 2 years, a lot many things, but we have to cross it. So we will do it, and we will keep in touch with you, ma'am.
Yes, ma'am.
A very, very nice presentation. Thank you so much, ma'am.
Thank you, ma'am. Thank you.
Thank you, madam. Thank you, madam, for such an interesting session on educational challenges of nurse educators. And again, I express my sincere gratitude for such a beautiful orientation of your college, and you were able to show us the solutions for the challenges. Of course, madam, we assure you that we will follow those solutions to change the challenges in our life, and we will make it as an opportunity to prove excellence in nursing. Thank you very much, ma'am.
Thank you,
And we take this
Thank you, Dr.
opportunity.
Kavita.
Most welcome, ma'am. We take this opportunity to share our memento of certificate to the respectable speaker, ma'am, at this moment.
Thank you so much.
Ma'am, we request your good office kindly extend any of your research focus or collaborative areas of interest. We too also work through, and we will have inter collaborations as well.
We can have a MOU. I have a format
Yes,
for MOU.
definitely. We will take up a MOU, and we will do some inter collaborative researches as well, ma'am.
Yes.
So
actually, we were having a big project with Southern Cross University, Australia, on a learning app for students. We pilot tested it. That is the leadership and communication skills in management of chronic diseases among the undergraduate students. We piloted it on our 3rd years. And then we had a big DFAT grant from Australian government, where we wanted to cover it for a cohort of 800 students across different universities of India. But because of the COVID and all, that opportunity went. But now under the New Columbia plan, they are sponsoring their students to come and stay with us for 2 years. Let us see where it leads to. Then I will try to include you.
Yes, ma'am. Please, ma'am. Please help us. And we too also have another alliance with Sweden. University of West. I think you also told about some Sweden projects and other thing.
Yeah, so it was a midwifery thing. Yes.
Yeah, but now we have one project. They have got a grant for students, Linus Palme grant for our students and their faculty. They are contributing for something towards that MOU through MOU, and we are having one collaborations, ma'am, and they are very active in discussing with us. So as like that, you too also try to help us.
Yes, ma'am. Sure, ma'am.
Thank you, ma'am.
Thank you so much.
Thank you. Good
Thank
day.
you, ma'am. Thank you.
Thank you. Thank you.
Information technology has been one of the leading drivers of globalization, and healthcare is becoming part of such information technology. To know more about how technology meets healthcare, let us listen to our next speaker. Now, I request Mrs. Ramya Radidevi, Associate Professor of SRM College of Nursing, to introduce our next eminent speaker of this session. Over to you, Mrs. Ramya.
Happy morning to one and all joined here. Moving right along, it is now my pleasure to introduce our eminent and charming resource person, Dr. Vasanta Kalyani C., Principal, Palliative Care Nurse, College of Nursing, AIMS, Bioleagues, Jharkhand. Madam has 22 years of experience in the fields of nursing education, nursing service, and research. Madam has been examiner for the national and international level UG, PG, and PhD nursing programs. To flourish evidence-based nursing practice at higher level, Madam is conducting research in adult nursing and palliative care as intramural and extramural in collaboration with national and international agencies. Madam has authored many books and contributed chapters in nursing books. About our research findings and communication, Madam has published 52 review and research articles in Index Journal. Madam also organized many national and international workshops and conferences as an organizing committee chairman and secretary. Adding to her credentials as an expertise, Madam is an editorial and reviewer for various national and international journals. Madam is also executive board member for various universities. With this brief introduction, with you all, I welcome Madam to share an energetic and refreshing perspective on telehealth nursing, technology meets healthcare, to embrace a mindset of progress and creativity. I welcome you, ma'am.
I think she's there.
Yes, good morning, all of you.
Very good
Good
morning.
morning, ma'am.
Good morning.
Hope to meet you again. Thank you, ma'am.
Yeah, thank you. Nice to
Yes.
see you.
Yes, ma'am. Thank you. Good morning, other dignitaries and participants. I just apologize myself that in Jharkhand, the weather is not good. So there is some internet instability is there. That's why I am not able to open the video.
No problem, ma'am. No problem. You proceed. Yeah.
Yes, ma'am. Thank you, ma'am. Thank you. Just shall I start the topic?
Yes, you can start, ma'am.
Yes, 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 yes.
Yes, ma'am.
I am very thankful to organizers, SRM, Dean Madam and other dignitaries and the association, SFNP Association, for giving me this opportunity to talk on this very, that is a catchy topic. That is, I don't think so, this type of headings, that is resilience and reinvention, that is bouncing back. We are bouncing back whatever the problem arises. We the nurses, usually if we see nurses community, anybody you can hear, it is in which level, they are in which level also. We have our own inbuilt adjustment personality, or otherwise it cannot be the adjustment personality, which is the adaptive personality we have as a nurses. Maybe I feel so many people, that is in human beings, who are all having the adaptive personalities, I will feel becoming a nurses. That is in that, the topic is very apt for this time. That is, the situation is now for human beings, it is like that. In that, I have got the topic of telehealth, how it is coming up. Even then the medium we are choosing, and then we are not stuck in one place. Even that 2020, which is a year of nurses, that year only we have got our challenges, but we have gained our, that is name worldwide also. So we have bounced back. What are all the challenges have come also, we have bounced back. In that, one of the medium we have taken is a telehealth. So today I'm going to talk about regarding the, just an introduction, this only. In my talk, I'm briefing what is telehealth and then how we are going to do this telehealth. If we see telehealth, we cannot totally alone. We are having a, that is a multi-speciality approach only, or multi-sectoral approach only in telehealth. So telehealth nursing means the information what we are using to share to our patient and then improve the patient care, we are using a telecommunication mediums. So telecommunication mediums which integrate years before become a, some of the.
Ma'am, sorry, we couldn't hear you, ma'am.
Having bouncing back, and then we are using, that is telehealth everywhere it is using. Previously inside the hospitals, the communication is to the phone to phone, just we have referenced the cases and other things. Now we are doing all the medium of patient care, as well as nursing, as well as in research. Next, please. So objectives of telehealth nursing means the use of information and communication. So that will be useful for the specialized healthcare in the remote location. First and foremost, if we see, India is becoming one of the big constitution with a rural population. There we are not able to achieve, the health sectors can reach till the area of remote locations, urban areas, hilly areas, because where I have been in Uttarakhand as well as in Jharkhand, many areas still they have the health, people are not available, the issues are there. But the telehealth, which is a very good aspect, where all the places we are not able to reach, we are reaching that locations, and then from that locations we are giving a very good care. That is patient health care is a quality one, because we are connecting with specialized health centers and then specialized even the physicians or surgeons or nurses. And then video conferencing. We are doing with video conferencing. What is happening in the video conferencing? We are understanding the patient's feelings, emotions, and their attitude towards the treatment. So this is also, because only through the phone, if we are talking, maybe we don't know their situation. Due to the video conference, the telehealth which has improved, we are doing this. And then not only for treatment, for learning. The previous speaker has told there are various online channels are available, apps are available to continue the health personals, that is daily updating knowledge from basic to today what has happened can happen in the globally related with healthcare. So this will be, because this is the main objective of telehealth. And then if we see the research, we are doing the research nowadays with the Google Forms, and then through the video conferencing, even the focus group discussions are happening through video conferencing. There also this is helpful. But when we can do the telehealth, that should be that is where it is not possible, if it should have an adequate infrastructure. Otherwise, it will be little difficult. And then large number of indoor and outdoor patients requiring referral for specialized care. So many people are waiting. It will be difficult. And then health experts. That is why this is happening. And then the adequate opportunities for training. And because we have to make the health personnel to be adequately trained to, that is, do the telehealth. Next slide, please. And then benefits. That is, it will be used for unserved rural, semi-urban, and then where the medical specialist nurses are not available, and then reduced visit to the specialty hospitals. Terminally ill patients who are not able to visit to the specialized hospitals every alternate days or week. So that time this telehealth will be useful. Please next. And then if it is health professionals, which will be very much useful. What we can have the diagnosis, better treatment and manage. Maybe the patients will be in first hand, they no need to come to the hospital. They can do the assessment through video conferencing. We can understand, we can do with that is, maybe the doctors and nurses will be in video conferencing. On the another hand, another same doctor and nurses may be specialized. And then here, the person who is a medical officer and a registered nurse, they can do the first hand thing, and then they will ask the patient to come for with the other specialized report. So what will happen? This will be useful for the patient as well as the doctors to take them the prior appointment to the particular patient, and then they can do the treatment, and the follow-up will be very much useful. After that also, follow-up also useful for the patient when they will do with the telehealth. Next slide, please. Next. So hospital and insurance benefits also will be available. It's not a thing that telehealth somebody will be talking. That is only through the videos. No, it will be a very much accepted, which will be for helpful for the patients who are all having the insurance scheme. Our government also adopted many insurance schemes for the patient. So because of telehealth, that is not less. They will be available, they will be availing all the insurance benefits in the hospitals. So specialized care also will be available. The amount which they are having, the patients will be benefited.
I'm sorry, ma'am. We couldn't hear you, ma'am. Sorry, ma'am. I think there is some network instability. Ma'am, we couldn't hear you, ma'am. Madam, madam, we couldn't hear you. Madam, can you hear us? Dear participants, kindly bear with us. Sorry for the inconvenience.
Through Kavita,
Yes, ma'am.
ask Vicky at least call through phone.
We are calling, ma'am. We are calling. We're trying to contact. Dear participants, sorry for the inconvenience due to some network issues. In the meantime, I would like to share few informations to the participants. For us to know what we are doing, how we are doing, and where to next. To get answers for the above, we need your feedback. A feedback link will be shared into a given email ID at the end of the plenary session, the next plenary session. Kindly give your feedback, and that will give space for us to learn where we are and to strengthen our deliberations of such kind in near future. We also take this opportunity to emphasize that the feedback link is digitally connected to keep an account for the conference certificates. So kindly take few minutes to give your respective feedback and suggestions about this conference. We also would like to highlight to you that post-test link will also be shared to the same email ID. Dear delegates, please take your time to answer the post-test link. Thank you very much.
Raki? Raki?
Dear delegates, sorry for the inconvenience. We are back with our session now.
Yes, yes. Raki madam को बुलाए.
Madam, ma'am, you can start now, ma'am.
Yes, yes. I'm
Is it
starting.
visible, ma'am?
Ah, yes, yes. It's visible. Yes,
Yes.
yes. Okay. Thank you. Thank you. Thank you.
Yes.
And so we are talking about because of telehealth, the patients are, they are having the consultation, they are getting the insurance benefits also. It's not a thing that due to the telehealth, the insurance won't be available. They can be avail their insurance because it's a government approved project which has been given to the patients as well as for the instructions have given to the hospitals also. And then increase in the scope of services without creating physical infrastructure in remote hospitals. Because the government, they can start many clinics in the remote areas. They can have the minimal infrastructure for a small X-ray, some scan machine, ultrasound machines, and then a minimal human resource available. That is medical officer, nursing person, and pharmacology, and for the other ambulance drivers. These are all some minimal infrastructures they can start, or otherwise, if the doctor and nurse and the other helpers are available, that it will also benefit to the patients. Next slide, please. So this is one of the systematic review. That is before going into that, it's a evidence. Because we are talking about how we are bouncing back and then what about the evidence for this. So here in the review, it has been at the time of the COVID. There are some 8 studies are giving a strength, evidence to the telehealth, which is potential to prevent any sort of physical contact, continuous care and to the community, and finally reduce the morbidity and mortality of the COVID-19. This all hospitals, they have been started to have the COVID, especially in the second and third wave, the patients have been taken care through the telehealth only. So that's why we have been in, it is a our evidence, direct evidence. In this era, this millennium, who are all living now, we are having the direct evidence that telehealth, which is very much beneficial, which is not having any potential harmness, except the patients who are need a immediate care or emergency care, they have been rushed to the hospital. Remaining, we have taken care at their home or near to the clinics with the use of telehealth team. Next slide. What is the telehealth? What is the model? If we see, there should be a total 2 end. One is the nodal hospital, another one will be the referral hospital. These are all the lines, the internet connections, whichever the line, what is the technical terms, the information technology team, they will create for us. Every internet resource will have its own benefits and drawbacks. Some internet connections have their own server backup for video conferencing, for their record keeping, or otherwise only for telecalling or only for video conferencing, they have their connections. So from the nodal hospital where the patient is under the treatment, the physician treating is also available with a nursing team, and the remote telemedicine team will be with a referral hospital where the expert or specialized team will be available. So they can have their audio and visual conferencing, and data can be shared to understand the problem of the patient as well as to the hospital, which sort of healthcare they have, or otherwise where they have to refer. This is one model, simple model. Second, next. So this is a system schematic, how the doctor, nurses and patients, and then how they are doing their care. So this is, which will be useful, which are all the items we are seeing nowadays. Everywhere these items are available at a time, that will be visible on their screen. From there, a specialized person will be sitting, and then they will be understanding what is the problem of the patient, and then accordingly the treatment have been given. Next slide, please. The sequence, how the sequence will go. How the sequence will go in teleconsultation. If the patient is coming to the OPD, they will have the checkup, and then they will receive the treatment. If they are not, that's all. They will be having the minimal, and then they'll go out from the hospital. If the patient has been referred with some specialized investigation, which is just suggested for them, they have to do the process. Then they have to do again, no need to come to the hospital. They have to go for the entry, telemedicine department. There will be the entry. So they have to enter and then do the sequences, and then they have to have their online telemedicine session with the appointment. So they can go and do the things, or otherwise they have to transfer this data from where they have started their treatment. They have to go enter their treatment in their nodal hospital. So in that step 2, next slide, please. In step 2, there are various patients will be available. So one by one, they have their own appointments, and then they will start to do their department, and then they will start to get their treatment modalities. Again, they will be needed. They will go for the specialized referral hospitals if further treatment is needed. So where they are doing all these things, these are all the areas we can already started. If it is needed, we can start our telehealth departments. So telehealth departments, in that every hospital or where the infrastructure and specialist nurses also available, they have started with the telehealth nursing. I feel every hospital for the COVID, they have separately started along with the physician or other surgeons. They have started telehealth nursing, especially for the patients who are all not having any serious illnesses. Only the nurses, specialized person only taken care of them. Even our hospital also, for all the healthcare workers who are all sick at the time of COVID, and then they were isolated in their own home quarantine or home treatment. Nursing team only have done the telehealth sector. Next slide, please. So telehealth software, if we see, it's a IT departmental activities. So there we have to have our infrastructure, which is we need the same infrastructure between two ends. It's not a thing that in referral hospital there will be a some facility and nodal hospital they can have. No, related with the infrastructure and software, both the area should have a same kind of software we need. But sometimes nodal hospital, where the patient load will be there, they can have multiple referral team, and then multiple, they will have the referral systems. So the IT departments will be there. So from one number or one connection, they will have some medical. Another one will be the surgical. Another one will be the orthopedics. they can have their own channels and then they can start it, because one line also it will become, it won't be appropriate. So it will become server problem, and then there won't be the space for the data to store. So there will be the multiple channels, and then which will be with the internet facility. Next. And then store and forward technical. Second we need will be the each and every, because only the verbal recording will be one thing. The verbal recording, what the patient is talking. Another one will be the what the consultation will be giving the order. That will be the verbal recordings will be there. Anytime the patient can see their verbal recordings, or the end, another end, referral end, they can have their own recordings. But nowadays, which has been upgraded, all the images of the patient are stored in the software only. Whenever the patient will be coming with the, nowadays telehealth is coming through app. They can have the app. All the things will be already fixed over there. The patient will be having a problem. The doctors or the nurses can give them the treatment with that app already created. Because of this, all the data will be in the server. If we know the patient's ID number and other things, this will come like a file. From the file, they will have their problems, means automatically the treatment will come to them. Apart from that, the treatment is for 2 to 3 days. Again, if it is not needed anything, they have to go for higher, that is end with the other specialty diagnostic test. So this will come with a voice recording or with a department people. So automatically they will have the consultation with separate departments. Next. So public and private partnership in telehealth. Government also the partnership with NGOs, which is running in our country. Even if we are sitting in any corner of India, and then we can start to connect to their other hospital wherever they like. And then for upgraded, that is, which is AIMS Deoghar, very new. We are having anywhere from India, we have a doctors, specialized doctors are available. We have our telehealth team. That is maximum, if we see, our nurses are the first hand people who are doing the telehealth, and then they will be referring to the particular department doctors whom the patient has to see with their first hand informations. Then from there it is needed, further references are needed. That time, if there is a need of X-ray, history, ECG, and then whatever is needed, immediately they can give it to given to the particular patient. If it is needed, for example, the patient with a myocardial infarction, they are contacting immediately. So they have been referred from any corner of the country, immediate the other center where they will be available. Nowadays, it will be available with a Google search. The particular area where the patient is talking will be on the map, and then which are all the other specialized hospital will be identified, and then the patient will be referred within next 15 minutes, maybe on the call or otherwise through the video conferencing. The patient has been transferred to the particular hospital for a, I have given one example of thrombolysis, like this, maybe the myocardial or CAV, stroke, thrombolysis, or accidents or any fractures. This type of facilities will be available nowadays through this telehealth. Next. Live sessions. Some live sessions are there. How the scan from one end, because they are not able to reach to the particular things, through the scan or to the patient, to the baby's picture, which will be visualized to the another end. So they will come to know what is the problem with the babies. It's like this, the images of CT scan and the X-ray will be viewed. This is what is the procedures they are doing. Another specialized will be somewhere, because we are connected with internationally now, because the patients who are all here, and then we are getting treatment from US. Your doctor has gone to US. Somebody, a known person, have got some through the video conferencing, which doctor you are preferring from there, they are giving you the treatment. So this type of live sessions will be immediately shared. In that condition, the hospital should have a high-end internet availability and the system. That is infrastructure which carries a 75% of the account. And then the expert comes. Next. So these are all live things. What has happened? The child is having the problem. What has happened? And then how the images. Next, CT scan images. They will identify. That is what else I have which is for the stroke patients from AIMS Delhi. Madam has created a stroke institute at Himachal. From Himachal, they will take the CT scan. HOD of the neurology department will be available in Delhi, and then the treatment will be taken from her to the Himachal Pradesh. If we see the northern India, it's are totally a hilly based. 80% of the people will be in northern side. It will be with a hilly, because it for 10 minutes if you feel to go, it takes more than 2 hours. And then taking the patient to the plain place, it takes more than a day or 12 hours. So till that, the patient condition will be immediately referred to somebody, and then the primary treatment will be available in the hilly areas. So the telehealth will be very much specially for the hilly as well as the rural, where the transport facility or otherwise road facilities is not available, but we have to create a minimal structure for the telehealth. So we can immediately approach the patient, and then the mortality as well as morbidity will be reduced, and then it's evidence. Next slide, please. So we can see the various, how the things, even ECG. So if you see, please, maybe the patients who are all registered, this is a hospital. We have taken that, what is the telehealth, and then how the patients have been benefited. Everybody, there is no difference between the ratio, the gender or nothing. All are taking telehealth services. If you see, already I am talking about the challenges in that preparation of the telehealth facility. And then not only with internet, it should be have a civil, how this area you are having, electrical equipment, all the engineering also will be necessary. And a human person, that is a nurse or a doctor, should have taken the responsibility to coordinate with the telehealth services of the hospital, and then another end of that is civil work services. So then only it will be successful. Not only the internet facility available, and then there is a need of electricity, all civil activities, it is necessary. How to focus the camera, many things it will be needed. Maybe all of you have experienced from your hospital how the telehealth department, if you go inside itself, everywhere there will be the camera, and then the hospital setup will be there. From that we can, how much they have given inputs for the telehealth. Next. It is a field that is coming up. Next, please. So sensitization for the hands, because it is not very easy. We can tell, but when we are seeing the patient in front of you, because we have practiced that manner, but when we have the implementing through the things, maybe 1 or 2 points, there is a chance for us to miss. So immediately we have to retrieve those patients and then give some other things. So there will be the sensitization and repeated hands. For this also nowadays simulations have started. That is how to handle the telehealth video conferencing, and what is the treatment, how you are observing the patient. Maybe the person who will be sitting on that another side, they have to give the physical examination. Those physical examination to be trained to the person who is in the nodal center as well as to the referral person, because both should be educated. And then convenient teleconsultation session. We should fix, a person should sit, and then they have to fix that is appointment. Nothing it's that, but appointment with all the facilities will be available. Both should have a mutually consent for the particular thing, and then they have to, and then the internet facility. Because that is, now we have evidence, because of poor internet facility, I am not able to handle for a few minutes. I have become panic only if I tell. So this is a main one challenge. Next. Next, please. Then how we can take a way forward means that is support from the hospital administration. Previous slide, please. Previous slide. We have to have a stabilization 3 to 4 years. We should have a hospital administration, and then we should at least develop for a certain period of time. Then we will have the regular, and then we can have the memorandum or understanding or some between the internet resource companies and hospital services. We have to keep a regular update for them. There will be the link between the institution and the other internet service resource persons. And we should not feel that they are doing only the telehealth, they will do better. There also there will be the appraisal. Every institution, it's also like you are doing the duty only. So we should have a performance appraisal from the patient satisfaction side. Are they understanding? Then the individual and the institutions will be developed in the telehealth field. And then concept to the everybody. That is each and every one of the institution to be understand and then have the updated knowledge about the telehealth. Then only they will communicate and then disseminate to the vast public, and then they will come and take the services. Otherwise, still, where if you see maybe in that is developed countries, the OPD of the particular day for the particular will be very minimal. If the specialized, maximum they will take 10 patients only, because they have to go with a thorough examination by the specialized consultancies, either a doctor or a nurse, or it's a teamwork actually. Nobody can do their thing without anyone. So it's a multidisciplinary. So here we should focus through the telehealth thing. The personal visit of the patient may be reduced, and then we will give a quality care. We should not think that telemedicine or telenursing or telehealth only the consultation of prescribing some simple medicine and then they can. No, we can improve this telehealth to for the specialized health settings where the patient no need to wait for the doctors unnecessarily. They have to come, have a thorough checkup, all the things. So they have to have a tele advice before they reach to the hospital. So this type of education to be needed and upgraded to the healthcare personals. Next slide, please. And then if we see this era where we are living, we are having applications for this we have used in COVID-19. Here it will be with the contact tracing. First, the digital world used as contact tracing, and then quarantine and self-isolation, screening for infection, then clinical management. We have that is planned and then track the care when they have to reach to the hospital. All have we witnessed this. And then which are all the medical supplies are needed, maybe at the home end or at the hospital. So this is a proven for this telehealth, which is very much necessary, and then which is
Thank. Ma'am, sorry, ma'am, we couldn't hear you. I think there is some instability of network, ma'am. Ma'am, can you hear us? She's not there. She's not. Madam?
You can call her through phone, ma.
Yes, ma'am, we are doing, ma'am.
phone
We are
and
doing.
anyhow she has come up to the take home
Yes,
message.
ma'am.
So you just
We will-
tell her through phone whether we can wind up, because already she has completed, no?
Yes, ma'am. Yes,
With
ma'am.
many obstacles, but however, it is a new concept. All of us created everywhere. The telehealth is there, but however it is functioning and everything she brought into in a nutshell. So it is a good presentation. You just convey it to her through phone. The next presenter we can call.
Yes, ma'am.
It's okay means, because I'm waiting for her for
Okay.
taking time. Yeah.
We'll do that, ma'am.
Okay.
Thank you,
yes,
ma'am.
But convey her. This is a very good presentation, new area, and how she share her full experiences and other thing.
Yes, ma'am. Yes, ma'am. We will convey that to her,
Yeah,
ma'am.
yeah, yes, ma'am. Thank you.
Now, we take this opportunity to share our memento of certificate to the honorable speaker. Now, we are to the end of the morning session. The biggest part of our digital transformation is changing the way you think. Our digital
Kavita?
Yes, ma'am. We are starting, ma'am.
You just speak to her, then conclude.
Yes, ma'am.
And shall we call the next presenter like that? You get a consent from previous speaker.
Yes, ma'am. We are getting it, ma'am.
Kavita? 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 Kalavali?
Ma'am, can you hear me, ma'am?
Ma'am,
Yeah.
ma'am, I spoke to Vasanta Kalyani, ma'am.
Okay.
She said to continue with other next presenter, ma'am. Next
Okay,
presenter
then
is joining, ma'am.
don't waste the time. Then you start for the next.
Ma'am, we are waiting for the next speaker only, ma'am. Now we are trying
Yeah.
to contact her, ma'am. We are waiting for her, ma'am.
Yeah.
We are trying to contact ma'am, Malarkudi, ma'am. Ma'am, can you hear me, ma'am?
She came in the line earlier.
Yes, ma'am. She was here all this while, ma'am. Suddenly got cut. Now we couldn't contact her.
She joined and they made us as a co-host, ma'am. In between, she got disconnected, ma'am.
Okay, or otherwise, Vijayalakshmi present பண்ண சொல்லுங்க அவங்க அப்புறம் வரட்டும் அவ்வளவுதான். டைம் வேஸ்ட் பண்ணாதீங்க. ஈவினிங் ரொம்ப லேட் ஆயிடுதுல.
Yes, ma'am.
You can proceed with the next presenter.
Yes, ma'am. Yes, ma'am.
If we could not able to call her, means ask our vice principal to present the title instead of Manju Dandabani. Yes.
Which ma'am is coming? Okay.
Vijay ma'am, Vijay ma'am.
Yes,
Yes.
ma'am.
Ma'am is doing.
Ma'am is here. Dear delegates, sorry for the inconvenience caused. Now we shall start with the next session, the session 5. I would like to cordially invite our.
Excuse me, Kavita.
Yes, ma'am.
I think she has joined Malarkudi now. It was
Yes, ma'am.
projected, no? You just find out.
Yes, ma'am. Yes, ma'am. We are doing that, ma'am.
Yeah, if she is there, permit her to do it, and then following by our vice principal will do.
Yes, ma'am. Yes, ma'am.
If it is not so, you do this, okay?
Yes, ma'am.
Excuse me, ma'am.
Confirm
Ma'am,
it.
we just spoke to ma'am. Ma'am told to continue with the Vijay ma'am presentation, ma'am.
Okay then, okay, no problem. Yeah.
Okay, ma'am.
Then proceed, yeah.
So now I cordially invite our Professor Vijayalakshmi, Vice Principal, College of Nursing, to introduce, to start with the session. Madam, over to you, ma'am.
Good morning to all. Good morning, respected Dean, ma'am. Thank you for the opportunity. Am I audible to all?
Yes, yes, yeah.
Centralized command centers, advanced nursing technology that will be transforming patient care. So this concept of command centers is not new. Way back in history, we can see the pictures over here. This is controlling sea traffic in the sea. And the second picture is controlling air traffic. And the third one is war control room. So the concept of command centers is not new to us. And what is this command center? A command center is any place that is used to provide centralized command for some purpose. It is usually in earlier times considered only in the military facility, but it can be used in other cases by the governments or in case of businesses. Usually the term war room is used in place of command center, and it is used in politics to refer to teams of communications where people who monitor and listen to the media and public respond to the inquiries and synthesize opinions to determine the best course of action. If all the functions of a command center is placed in a single room, it is referred to as a control room. This is to understand the concept of command center. And now, what is command centers in hospitals? A central command center in a hospital mimics an air traffic control system for patients. What actually it does, it collects real-time data using wearable sensors to identify patients at risk for complications. And this helps clinicians make quicker decisions because the data is available real-time, sitting in one place, and using artificial intelligence and data analytics, this technology will suggest interventions to the caregivers. It also supports the caregivers, the doctors and nurses to take the action immediately. The purposes of this command centers, the new breed uses advanced technology featuring predictive analytics. This is a specialty of this command centers with the use of artificial intelligence. One key advantage, as I said, is real-time data with information about incoming patients, the emergency department, OR capacity, bed availability, and discharges. This is done through software applications such as dashboards that provide real-time updates of whatever is happening around the hospital. One of the newest ideas for hospitals, centralized command centers promise improved patient experiences and better ways for nurses and doctors to manage supplies, clinical technology, and capacity. With shorter or non-existent delays, that is a prominent feature here. There is no delay between transitions of care. The nurses and doctors can actively be aware of room availability, the operation room schedules, and what individual patients still need before getting discharged. So this allows everyone to do their job more efficiently and effectively, and also helps the patients. These command centers give health systems a leading edge to manage capacity and improve patient experience. This is not going to be a dream or not happening now. In the incoming 10 years, hospitals will be outfitted with a centralized clinical command center that collects real-time data, wearable sensors, and yes, even interoperable medical records. This is the comment given by a group of 33 experts from around the globe that unveil their vision for digitalized hospitals in the next decade based on specific use cases. Their input was outlined in a report released by Deloitte Multinational Professional Services Network, USA. And whether it started and what is happening. Opening in 2016, the command center at Johns Hopkins Hospital is generally acknowledged. This is considered as the first hospital to launch a concept of this magnitude in the healthcare arena. And this is a capacity command center. Through machine learning and hospital management at Johns Hopkins. A top US hospital is taking the substantial steps in the use of machine learning to transfer healthcare delivery. A comment given by NGEM. Machine learning will become an indispensable tool for clinicians seeking to truly understand their patients. As patients' conditions and medical technologies become more complex in today's world, its role will continue to grow. That is the role of machine learning. And clinical medicine will be challenged to grow with it, with the machine learning. As in other industries, this challenge will create winners and losers in medicine. But we are optimistic that our patients, they will emerge as the biggest winners as machine learning transforms clinical medicine. So this is regarding the establishment of the command centers at Johns Hopkins Hospital, teamed up with GE Healthcare, partnering with the GE Healthcare. The Johns Hopkins Hospital launched a capacity command center, a dedicated space, staff, and set of tools aimed at transforming how the hospital delivered the care. The command center leverages prescriptive and predictive analytics, machine learning, natural learning processing, and computer vision to convey key information to the decision makers in real time, as and when it is happening. How it works. The system translates about 500 messages per minute from 14 different IT systems to provide these decision makers with actionable information, empowering them to coordinate the services within the hospital and to reduce bottlenecks, reducing the patient wait times and reducing the risk for the patients. The introduction of the command center was as much about people and process as it was about technology. This new process fosters a completely new approach to collaboration by collocating 24 staff who would previously have been distributed. This is a model. And the types of command centers in the hospital are Incident Response Command Center, Security Command Center, Building Operation Centers, Capacity Management Command Centers. And what is this Incident Response Command Center? This is activated when they are needed in case of emergencies, maybe in case of extreme weather conditions or major disasters, and in case of mass casualty events, and now in case of pandemics. And the second one is Security Command Center. This is otherwise known as Security Operations Centers. This performs surveillance, and this integrates services around threat detection and alarm management response. This Security Operations Center is able to dispatch officers and staff to help manage any type of safety concern, mainly concerned with the data security and security in the hospital environment. Building Operation Centers, building management, fire, medical gas, and the nurse call systems are integrated into the Facility Command Center or the Building Operation Centers. They even dispatch code blue alerts and alert everyone in case of any clinical emergencies. This center also includes the assist management system, real-time allocation or real-time location of systems, and automated guided vehicles to deliver medications, linen, and even meals to the patients. The fourth one is Capacity Management Command Centers. The Capacity Management Command Centers, this is actually focusing on the bed management, making sure that the beds are available for patients and nobody is waiting, no patients are waiting for the beds, and the beds are not wasted without being used. And in case of the beds, free beds are available, they should be cleaned on time, and making sure patients are transported from OR or ED on time, and making sure the care is coordinated between the teams that would handle bed management, environmental services, transport, and discharge. And how this is working in Hopkins, and what were the results? Patient transfers from other hospitals, 60% improvement in ability to accept complex patients from other hospitals. the utilization of the command centers have enabled 60% improvement in ability to accept complex patients from other hospitals, and critical care team dispatched 60 minutes soon as to pick up patients from outside hospitals, ambulance pickup, and emergency room patients admitted to the hospital are assigned a bed 30% faster in emergency department, and transfer delays from the operating room after a procedure reduced by 70%. So these are the positive results that took place in John Hopkins, the hospital John Hopkins. The other hospitals using the command centers, a few to mention: Florida Hospital in Orlando and Tampa General Hospital. Again, this is in Florida. And the other countries, a few to mention, which are using the hospital command centers: Canada, Dubai, UK, Netherlands, Saudi Arabia, UAE. And now what is happening in India? The National Health Policy 2017, with the following goal: the attainment of the highest possible level of health and well-being for all at all ages through a preventive and promotive healthcare orientation in all developmental policies, with the main focus: universal access to good quality healthcare services without anyone having to face financial hardship as a consequence. With this goal, the National Digital Health Mission is launched to make India a digital health nation, enabling digital healthcare for all. This is initiated in the year 2020, July, by the National Health Authority. And what is the mission of National Digital Health Mission India? To create a national digital health ecosystem that supports universal health coverage in an efficient, accessible, inclusive, affordable, timely, and safe manner. And this actually provides wide range of data, information, and infrastructure services to coordinate services, duly leveraging open, interoperable, standards-based digital systems. And it is also ensures security, confidentiality, and privacy of health-related personal information. This is the vision of National Digital Health Mission, India. And what are the underlying business principles of National Digital Health Mission of India? To establish wellness centers and mobile screening teams and strengthen them through real-time access to personal health records and mass awareness and education to be promoted through the use of appropriate platforms and a portfolio of health apps and the systems specialized to that will be designed to reach out to the unconnected, the people who are digitally illiterate, who reside in remote, hilly, and tribal areas, and real-time monitoring of performance of all healthcare institutions and professionals. These are few business principles underlying National Digital Health Mission of India. And what other initiatives are already taken to manage health information in India? India is moving fast towards adoption of software systems in healthcare. The following software are used to manage health information: electronic medical records, electronic health records, personal health records. Electronic medical records refers to systems that are used within a hospital or a clinic to support patient diagnosis and treatment and are transaction focused. The National Digital Health Mission requires these systems to be updated. They are following them to support standards and provide access to the data to patients. Electronic health records contain records for a patient across multiple doctors and providers, and this is used within a healthcare system, like you can say across a state government, to provide better care for patients. Personal health records, this helps the patients to compile, update, and keep a copy of their own records that help them better manage their care. and are person-focused. This is all managed by National Health Authority and implemented by the National Health Authority. So the NHA is leading the implementation of the National Digital Health Mission by coordinating with different ministries, departments of the Government of India, state governments, and private sectors, civil society organizations. Apart from this, the private sectors also working towards excellence are quoted as islands of excellence in an ocean of inadequacy. Care is shifting from the hospital to the clinic, from the clinic to the home, and from home to a 24/7 ubiquitous access to care driven by a mobile phone. Quote given by Sangeeta Reddy at the 2020 Wharton India Economic Forum. This is what is happening in India now. And this is the National Digital Health Mission initiatives, and it is under process. Phase 1, unique ID for doctors, DigiDoctor, and the phase 2 verification with MCI, NMC, and so on, updating of qualification and employment, integrated state council and registrars. In phase 3, real-time feedback and rating of the doctors. It is done through DigiDoctor. And healthcare facility registry, unique ID for hospitals and labs, e-forms and e-sign for facilities, validation through NHRR, provisional verification by NHA, and in phase 2, audit by statutory health facility auditor, attestation, updating of data, and so on. And phase 3, automatic benefits is enablement, unified application forums, and so on. And with relate to health ID, in phase 1, health account for everyone, option of linking with Aadhaar is already in happening, our health ID. This is happening in India. And phase 2, linking of accounts, family and relationships, convergence of different schemes, and so on. And phase 3, all health benefits and policies. And the personal health records in phase 1, PDF and scanned health records, power of consent with individual, prescription and reports in PHR. In phase 2, metadata and e-reports with analytics. In phase 3, health biomarkers based preventive healthcare, personal health analytics for individual and family. We are in phase 1, progressing towards phase 2, and will definitely will have successful phase 3. This is about National Digital Health Mission. And how the Tamil Nadu government is getting involved with the command centers, digital healthcare. Tamil Nadu government launched Unified Command Center for COVID-19 management in the year May 2021. The command center focused on helping sick patients get beds in Chennai and other districts. This is facilitated actionable intelligence for pandemic management through integration of the facilities managed with civic bodies like the Greater Chennai Corporation. Here, the officials, they get real-time information to make decisions on bed allocation in case of emergencies, overpouring of patients. Over 60% worked at the center with support from 4 trainee IAS officers, insurance officers, and officials of the 108 ambulance service. The center will manage all calls made to helpline numbers 104 and 108, mainly focusing on the bed management and oxygen support. To facilitate this, the government also launched Twitter handle at 104GoTN for the benefit of people seeking beds for COVID-19 patients. Those seeking beds may also use the hashtag beds for TN to maximize the reach and filter messages. This unified command center seeks to improve bed management, real-time tracking of vacant beds at hospitals. The Twitter handle is aimed at offering a platform for individuals to request beds for COVID-19 patients at private and government hospitals. All the private and government hospitals are linked together. They are managed efficiently for the patients who are seeking beds. The government has deployed staff members to monitor bed availability at private and government hospitals. Moving on to the future of healthcare. The future of healthcare delivery may look quite different than the hospital of today. Rapidly evolving technologies along with demographic and economic changes are expected to alter hospitals worldwide. We will be moving towards digital hospital. A growing number of inpatient healthcare services are already being pushed to home and outpatient ambulatory facilities. But still, very ill patients, definitely they'll need acute inpatient services. Aging infrastructure in some countries and increased demand for more beds in others, definitely the hospital executives and governments, they should consider how to optimize inpatient outpatient settings and integrate digital technologies into traditional hospital services to truly create a health system without walls. The benefits of the digital hospital, the future technology, redefine care delivery, centralized digital centers or the command centers to enable decision-making, continuous clinical monitoring, targeted treatments, and use of smaller portable devices help characterize acute care hospitals. Digital patient experience, where the AI technologies help enable on-demand interaction and seamless process to improve patient experience. AI doctors communicating or interacting with the patients. Enhanced talent development, robotic process automation, and AI can allow caregivers to spend more time. So the benefit of this AI involvement is the caregivers will have more time to spend at the bedside. The nurses will have more time to spend in the bedside. Operation efficiencies through technology, digital supply chains, automation, robotics, and next generation interoperability can drive operations management and back office efficiencies. Healing and well-being designs for the patients and staff members. This is put emphasis on the importance of environment and experience in healing. Definitely is important in future hospital designs. So what is required to build a digital hospital of the future? We need to create a culture for digital transformation. The management, the seniors in the management, the administrators, they need to understand the importance of the digital future and they need to support for its implementation at all organization levels. This is creating a culture for digital transformation. Consider technology that communicates. So digital implementation is complex. Connecting disparate application devices and technologies all are highly interdependent and they need to communicate with each other to take critical decisions for the successful digital implementation. Let's play a long game. Since digital technologies are ever evolving and will be evolving, flexibility and scalability during implementation is critical. The planning team should confirm that project scope includes adding, modifying, or replacing technology at lower cost. That is always prepared. We need to be prepared for any modifications, replacement at lower cost. Focus on data. While the requirements of data, interoperability, scalability, productivity, and flexibility definitely are important. They should be built upon a solid foundation of capturing, storing, securing, and analyzing data. So more focus to be given on securing the data, analyzing the data. Prepare for talent 2.0. As hospitals invest in exponential technologies, they should provide employees ample opportunities to develop corresponding digital strategies. So everybody in the hospital, they should be digitally provisional. They should excel in the digital technologies. Unless otherwise, this is not going to be practically possible. To prepare for talent 2.0, maintain cybersecurity. With the proliferation of digital technologies, cyber breaches can be a major threat to the hospitals of the future. So maintaining cybersecurity is of utmost importance. Executives should understand that cybersecurity is the other half of digital implementation, and allocate resources appropriately. Yes, India's healthcare industry is becoming more and more attractive for investors with technology-led innovations, helping penetrate second and third tier markets. With increased ease of use, acceptance by the people, and adaptation by service providers, digital health interventions can accelerate progress and improve population health outcomes. By establishing a comprehensive, nationwide integrated digital health ecosystem, command systems in hospitals is no more a dream in India, and the National Digital Health Mission will contribute significantly to achieve the goals of National Health Policy 2017 and the Sustainable Development Goals related to health. One more, got to adjust a minute.
Yes. Yes.
I just want to
Madam,
share.
Madam, you would like to share something, ma'am?
Yeah, I just want to share a video.
Yes, ma'am.
Command Center software helps caregivers orchestrate patient care for better outcomes and efficiency.
Audio is
The
available?
software starts by
Yes,
digitizing
ma'am.
the patient journey. By that, we mean the steps from complaint to diagnosis to treatments to discharge, continuing care, and so forth. Each patient's journey can involve different specialties, sites of care, lab, pharmacy, imaging, procedures, therapies, and all the rest. That mix of capabilities delivers miracles, but is also difficult to make efficient for every patient. That's where Command Center software makes a difference, by helping to optimize the patient journey for each patient and all patients. In the end, that means improved access, quality, and cost. Command Center apps are different from workflow software and dashboards because they're real-time, actionable, simple, easily personalized, predictive, and so smart. They connect teams across the enterprise. For example, which discharges are essential to allow the ICU to step down and unblock the ED? Which lab and imaging tests are critical to those discharges? Which drug combination is out of protocol? How to adjust staffing or recover telepacks to prevent a bottleneck this afternoon? Which laboring mothers are at risk of gestational hypertension? Tiles give caregivers this needed information now. Patient Manager helps charge nurses and case managers facilitate rounds, organize downgrades, plan disposition, prioritize barriers, and more. Imaging Expediter Tile helps techs spot readiness issues without digging through charts and work with units to sequence scans with the agreed upon prioritization. Health system leaders use summary views to monitor hotspots in real time across the enterprise. Ancillary service supervisors use Patient Manager to prioritize critical discharges and high-risk patients. Deterioration Tile helps the rapid response team keep an eye on the most critically ill patients. The surgery and procedural teams use tiles to ensure patient readiness, help drive volume, and expedite PACU flow. Staffing teams and nursing leaders use Staffing Forecast Tile to match staffing to predicted demand. Clinical expediters use tiles to spot and resolve issues in support of the frontline teams. The observation module helps teams ensure patients are properly classified and receiving care at the required tempo, and many more. Connecting all these great caregivers to an actionable digital thread enables next-level performance, and it makes their lives easier by saving time and reducing cognitive load. And there's so much more to do with and for caregivers and their patients.
Thank you. Thank you for the patient listening.
Thank you, ma'am.
It's very good, and it's a very last moment preparation. Even then, it is highly meaningful. So really, I congratulate Professor Vijayalakshmi, our Vice Principal. Yesterday only we have decided to not to change the topic, and I have given the title, and you have given the justice for this new title. So it should be ever ready. That concept you have fulfilled. And then coming to nursing where we are. So that is the very big question in front. So if you think high only, we can move to the highest level. So that's what the title it gives. The Command Center for Nursing Discipline also in future it is maybe expected. We need to have, during the COVID time, the medicine is taking up all advancement and other things, and we are adding along with the medicine. That's why the hospital focus is more, and we have to work hand in hand with the medical professionals. And there will be a day, the Command Center for Nursing. So that also it should be. And in the previous presentation by Sudha Reddy, a separate nursing university. So she has mentioned in that. And myself and Professor P.V. Ramachandran, chairman, in Ramachandra, he was there during that time. We also think about that we need to have a separate university for nursing. So that is the thinking of higher aim. As like the same way, the Command Center for Medical Hospitals, now it is running. Now, even the Command Center for Nursing in future, it has to be yet to come in the near future. It will be a challenge for all the youngsters. You too also can think about that. So this is the participants, and it is a future trend. So we are expecting challenges from the nursing side. So really, it's a very good presentation and vivid presentation. And within short time you prepared, I really thank Professor Vijay Lakshmi to stick on to the title, which it is given for you within the short spell. So it shows we need to keep ready of our mind at any time. We need to speak things on any aspect. Now the technology again. So only the technology is helping us in all the way. So to get content and to get prepared, even with a short note. So
thank you, ma'am. Thank you, ma'am, for your kind words of appreciation. Thank you.
I appreciate your acceptance things even in the critical situation. So thank you so much. And because the audience, whichever we have planned, we have sent to everyone. So due to some reason that given resource person, Dr. Manju Dandabani cannot able to extend the same title. So I allotted to our own colleague, our Professor Vijay Lakshmi, and she has taken the challenge and she proved herself also. I thank once again. And for the patient listening, patient listening of the participant, there is a change of the resource person. Due to this, some unavoidable reason only, we have changed that. The title is not changed. Only the resource person we have changed. So we want to adhere to the title. That was my thing, because all the title, main theme and titles we derived with a lot of difficulty to know about some new thing. So that is the thing. And I believe we have given justice for this. Thank you so much.
Thank you, ma'am.
Thank you so much. And then the audience as well for the patient listening. Thank you.
Thank you so much, ma'am. Thank you, ma'am.
Thank you, madam, for an informative and graceful presentation. We understood the necessity of advanced nursing technology by your presentation, madam. I take this opportunity to express my earnest gratitude for your effort and commitment in bringing out this session, very informative and technical. And moreover, ma'am, you have uplifted the presentation to the next level of advanced nursing technology. Thank you very much, ma'am.
Thank you, Dr. Kavita. Thank you.
Ma'am, we take this opportunity to share our moment of certificate to the Honorable Speaker, our Vice Principal, SRM College of Nursing.
Thank you.
Thank you once again, ma'am.
Thank you, ma'am.
Now we have come to the end of the morning session, and we are going to continue with the next plenary session, after which we will break for the lunch. The biggest part of our digital transformation is changing the way you think. Our digital future is about enabling better productivity and decision making to enjoy better quality of life. Now, I would like to invite Mrs. Angelin, Associate Professor, SRM College of Nursing, to introduce our distinguished speaker of this session. Over to you, madam.
It's my pride privilege to introduce Dr. Malarpudi, Assistant Professor, AIMS, Ritikesh Uttarakhand in this forum. Madam has completed her BSc Nursing in Sacred Heart College of Nursing under Dr. MGR Medical University, MSc Pediatric Nursing in Dr. Shamla Reddy College of Nursing, Bangalore, under Rajiv Gandhi University of Health Sciences, Karnataka, PGDSC Hospital Administration, Annamala University, Tamil Nadu. PhD in Nursing, All India Institute of Medical Science, Ritikesh. Madam has worked in various fields, pediatric and neonatal nursing. Madam has presented more papers in state, national, and international conferences. Madam has prepared manual for pediatric nursing. Madam has organized many national and international conferences. With this great introduce, I welcome you, ma'am. Now this time over to you, ma'am.
Good afternoon, all of you. Respected Dean Dr. Kanyammal, ma'am.
Good afternoon.
Thank you for the opportunity.
Good afternoon.
Nice to see you, ma'am. I have heard you about you, but first time I'm seeing you on the screen.
Even I too. We are welcoming you. Yeah.
Yes, ma'am.
Yes.
Thank you so much, ma'am. I apologize for the previous session. I could not able to connect. We have a very bad weather here.
Yeah, the same thing for the previous speaker. Also,
yes,
she got the Vasanta Kalyani also got the problem. I know.
Yeah.
That's why we had a hands of our own presentation is completed.
Yes, so much.
No
Thank you
problem,
so much for adjusting.
Yeah. Thank you.
Still, we are in a snowfall only. Just now,
Yeah.
I have off my heater too. So we are in a. I know in Chennai it is hot.
So nurses are always we can beat challenges. No,
yes,
anything
yes.
we will do it. We will come across and cross the barriers.
Yes, ma'am.
So,
so we are born like that.
Yeah,
and we are trained like that.
That is the spirit we have.
Yes, ma'am.
Yeah.
Yes,
Thank you.
Thank you for understanding.
Yeah, yes.
I think my screen is visible to you all.
Yes.
Yeah.
My job is very easy because in a inaugural session, Vice Chancellor sir and the previous speakers have touched so many things in nursing and the digital future, like what we are going through during this era, digital era. So in research, education, as well as the practice. So we had touched so many, all the speakers have touched. So my job made easy. So just I will have a brief introduction or brief session for the future, nursing in future. The flow of presentation will focus on the introduction, statistics, how far we use the digital era now, future digital status technologies and its benefits, how the nursing practice with the digital era, and how the technology influence our nursing education and nursing administration, as well as the research, and the challenges and the pros and cons of digital technology. As we know, we are in digital era. We are far in traditional as well as the digital technology we are using. We are mixed up with that, and we have lot of in COVID pandemic, we have a lot of technology we have used it nowadays. And this is one of the big example that we are virtually connecting. The word virtual, online, online classes, virtual, apps, tele, we have a lot of words we are using, come across nowadays. So with that, so I'll start my introduction. The digitalization of healthcare has enabled health services to more accessible and availability daily, especially during this pandemic. The effect of digital technology has been increasing in the nursing sector, and it is mainly helping us as well as making our nursing care more easy, available and accessible to all the population. Healthcare digitalization, including robotic system, artificial intelligence, the reliance of the internet, mobile and web application, social media has increased the dependence on telehealth and virtual health services. Furthermore, these challenges faced with technology and nursing care like COVID-19 has boosted up this particular response and dependency for more inclusive healthcare services. If we see the statistics, especially last 3 years, in 2 years, 91% of nurses could access electronic medical record, lab diagnostic results, that is 88% using mobile device for the healthcare services. A survey of 600 nurses shows that 82% believe that technology have highly impacted the patient care. Throughout the pandemic, remote monitoring, digital visit, and engagement tools have proved effective and have efficiency reduced feed traffic at clinicals and hospitals. Currently, 35% of patients' interactions are under digital. So with that, we can able to understand how far the digital have influenced the healthcare. And we feel that we are in a future digital care. It's not like that. Digital healthcare is not in future. It is here and now. And even we live in technology. So we feel that it is going to come. No, we are already in the midway of the digital era. So when you see the benefits, the nursing literature contains so many digital analysis used to support and extend our profession, including in practice, like health information system, electronic health records, monitoring system, decision support, and telehealth. When coming to the education, we have e-learning, virtual reality, health games, and rehabilitative and personalized digital care approaches, like assistive devices, sensors, ambient assisted living, all those things. Coming to administration level also, the technology help us a lot, like EMR, like electronic medical administration, patient and staff identification systems, a real-time location system for nurses. And in the research, in digital era, last 2 years, we have conducted. And ICMR tells that more than 30,340 researchers are conducted online, especially during these 2 years. Data handling also we can do digitally. Online data collections we can able to do. Online data management we can able to do. So this all, it helps under the digital research. So we'll come discuss about the nursing practice. So existing technology that are changing the nursing practice. So digital OPD, it's a new concept in our India. Digital IP, nursing module, wearable devices, electronic health records, telehealth and tele-apps, intelligent of things in healthcare, real-time locations, point care technology, smart TVs, automated equipment like IV pumps, robotics. So robotic is very much influenced nowadays, robotic and delivery robots, virtual ICU, portable monitors, smart beds, and smart stethoscopes. There are a lot of technology have came into the existence of nursing practice. We'll discuss about the digital OPD. So digital OPD nowadays is very easy to approach the patient. It is giving accessibility to all the patients, whichever is not able to reach out. Like we can check for appointment, calendar features will allow see the appointment, details of previous OPD visit, integration with IPD records, previous lab reports, radiology finding, medication orders, discharge summary can be accessed whenever it is needed. Risk scores can be calculated based on the assessment data, and like especially the cardiac risk, time trends of lab reports, can set up the favorite test, copy and paste the information from previous visit. It will save the times. Interfaced investigation that will request for billing, voice typing, this prescription digitally connected to the pharmacy, reduces the medication errors, and give the alert and send the alert to the follow-up for the patients. So digital OPD have made the patient very easily to come up with all positive things to have availability and access the healthcare. Digital IP model, especially the module for the patient emergency module, nursing module, medication prescription module, lab services modules, health services module like billing and storing, telehealth module, patient module, home care modules. There are so many modules have prepared digitally. We can have there all the records inside the apps, and we can open and we can see each and every patient will have a digital ID. With the ID, we'll able to see the patient details that only individual patient care we can able to provide. Coming to digital module, we can have only nursing care module. Here we can able to see what are the nursing care decisions we have given and what medication going on, what are the reports of patients, how we can, who's managing the patient, whether the patient is transferred from one unit to other unit. Next, who was this handing over nursing officers or nurses, and who is taking care of now, and what are the previous care provided to this particular patients, all can be seen in one nursing module. So that will improve the clinical communication as well as the patient satisfaction. Wireless communication is a trend now. Wireless badges like headsets integrated with what are the ones, multiple communication can be done, such as phone, badges, and to the one seamless technology will reduce the response time. So when we see this wireless technology, like we can have nowadays, we have even in smart watches, wearable technology like rings, watches, and even in hearing aid, all those things we have wireless technology, which will give our vital signs monitoring like pulse, respiratory rate, SpO2, all those things, such that will give alarm to the patient that no, I am on danger, I should reach out the patient healthcare. How we can, the wireless technology is transferring healthcare, like we can even manage the workflow in the hospital, staff management workflow, and tracking medical equipment, automated environmental monitoring hand hygiene compliance, analyzing operational data, increasing the security. So we can track where the patient is transferring from one area to another area. When it is coming to security, the infant, the newborn can able to locate where the child is. Parents can able to see where the child is, in which bed, which NICU the child is administered, all those things, when they cannot able to access to the virtual ICU. Internet of Things in healthcare. It is a combination of hardware and software technology that produces trillion of data through connecting multiple devices and sensors with cloud and making sense of data in intelligent tools like closed loop insulin delivery, connected inhalers. So that will give a patient correct dose and medications. Point of care technology also is a new digital technology which set up a technology used to locate the patient care, helping improves healthcare outcomes. Like nowadays, we can just on the spot, we can able to see the glucose, urine analysis, fecal occult blood, rapid streptococcus test, urine test for pregnancy, coagulation testing, cholesterol, lipid, and rapid hemoglobin test. So we can able to test on the point, and we can able to just identify where the patient is lacking, and that is helping nurses very, very much. Electronic health records, nowadays 90% of healthcare hospitals are using this electronic health records, which will have the patient complete details like patient personal information, examination record, hospital visit, personal health visits. So wherever the nurses are sitting can access about the patient. That will help for the family physician as well as the insurance. Then health electronic follows the nursing experts, and there is a separate page for nurses also in electronic health records. So we can have that page, and we can able to access the nursing care and which have nursing care have provided to the patient and when have it provided and by whom it is provided. Smart TV technology now can provide the information on upcoming treatment and deliver instruction. Especially this this smart TV is used. You can appreciate in the picture. We can use to deliver the instructions about the medication, discharge care, discharge education to the patients about their disease conditions. So we can use to educate the patients and the family. Automated IV pumps. All the pumps nowadays on this on practice. So we in some of the hospitals it is under practice. So here it will give the amount, how much amount of medication, when has to be delivered, and with the barcode. So it will help the nurses to administer the correct medication, correct dose. All 5 rights can be followed. That will prevent the dangerous mistakes. Portable monitors like vital signs, ECG, respiratory rate, and oxygen saturation, while transmitting the information back to the central monitors. So we can able to easily carry and do all the vital sign, whichever is very important. That will even give the alarm if there is any emergency. Smart bed technology give the nurses for consistent monitor in the room that facilitates with regular update and communication on the patient activity. And nurses also spend less time coming in and adjusting supplies, giving medications, adjusting medical equipments and all those things. As the future bed becomes increasingly sophisticated, it will become even more critical components with the digital services, infrastructure that helps professionals run more cost-effective operation without sacrificing the comfort of the patients.
Ma'am, you're not audible, ma'am. Sorry, ma'am. You're not audible.
I'm not audible?
Now we can hear you, ma'am.
Okay. Slides are visible, ma'am?
Yes, it's visible. Yes, ma'am, it's visible.
Yeah. So wearable technology, there are even in goggles, in wearable badges, watch, bands, there are lots of healthcare benefits that can give major vital signs that will prevent the dangerous. It will give alarm to the dangerous signs. We can able to prevent the patient from the danger. So telehealth and app, and previous speaker, Dr. Vasantha Kalyani, have clearly told you about how the telehealth and apps will help us to reach out the patients. Virtual ICU, VICU during this COVID pandemic, even we have seen the patient through virtual. So we can see there is a camera because of restriction. We could not able to see the patients. So here few nurses are allowed to enter. So even the doctors, other healthcare, allied nurses, allied doctors, specialty doctors could see the patient through virtual visit by the doctors and other persons, and able to provide a better healthcare. So the virtual ICU was the new concept. They had a tour virtually and visit the patients. Robotics made us more efficient and cost-effective method, and high-quality patients have provided operation efficiency, safe work environment. Like in healthcare, mainly we use for cleaning and disinfection, whichever we could not able to reach out, like some of the disinfectant areas. So the robotic can able to do it. Surgery, robotic surgeries nowadays is, even we have in MCC case, we have 3 robotics that do the robotic surgeries. And rehabilitation services also, we have a center in rehabilitation. These are all the equipments, rehabilitative robots we have here. So this also help the patients to provide the rehabilitative services. When see here, this minimal invasive robotic that will help in minimal invasive robotic surgery, rehabilitation robots with help for rehabilitation, telepresence robot that it will give a tele communications, helping all information providers, all those things it provides, and logistic robots. It will give all logistics and care support robots. It will give a care by carrying the patient from transferring patient from one area to the other areas. And here we can see this partially autonomous fixed installation is needed in a controlled environment. We have to use our hands to control the robot. Here, when coming to this end, it is fully autonomous and no installation is needed, and uncontrolled environment also can be worked out. Coming to the delivery robots, it's helped us during this pandemic also. So a research by the American Nurse Today, so more than 53% of nurses' time spent on tasks completely unrelated to the patient care, such as managing supplies, looking for the supplies, filling out the reports, handling the patient check-ins, bills, all those things. But this delivery robots can be programmed to fetch some medicines from the pharmacy, packing of drugs, bringing a clean linen to the patient's room, deliver the meals, take the specimen to the lab, and perform other tasks and keep the nurses from spending less time for unrelated to the patient's care. So only we can spend on the patients. So this robots are helping a lot for those tasks. And other digital advanced Stethi, so it is a smart stethoscope. It is easily portable. You can see here that is when it is paired with Bluetooth as well as the headphone, and we can able to hear the high quality audio of your heart, lung, and other body sounds. So this is the first and only device we can even listen the heart directly, which our the exact sounds and high quality audio we can able to see here. And if you're connected, you can be connected to your mobiles and your smartphones, Bluetooth, all those things, and apps can be opened with this app. This can be this all records can be documented. We can able to see later. So this is a smart stethoscope can be used. It is in the digital era. It is going to come in futures. Is already on the market. Another one is Minity Smart Stethoscope. In this smart stethoscope is specialized for auxiliary devices intended to medical diagnostic use for mainly the respiratory, such as mainly the pediatric aspect, pediatric pneumonia, child asthma, and for the elderly bronchitis also can be used. And it is as a small device, Minity, and this also will read all respiratory as well as the heart parameters. Artificial intelligence, it refers to the simulation of human intelligence in machines that are programmed to think like humans. It mimic their accents, and especially we can the role of AI in healthcare are early detection of elements. It will improve the decision making. It will help in treatment and expand the access to the medical devices. It will help in associated care, collaborative care, giving a superior experience. It is very easy to use, checking health through wearable devices, and even it will provide the end of life care. It is all about the nursing practice. So we in nursing practice, digital technology is having a lot of benefits to us. Coming to educations, in education also, nowadays we are transferring our education system from traditional to the digital. And chalkboards have transmitted into smart boards, and reading textbooks are nowadays is reduced. And paper pencil technique, it is changed into digital, even digital assignments, online classes, online apps are using for evaluation. There are almost things. You can see this cartoon that, "Hi sweetie, how was your school today?" This girl is telling that you can read all about my vlog, that. So this is a smart learning activities going on nowadays. Even in nursing, through this pandemic, we had a very difficult task to teach our nursing students skill, especially the skills. Even the theory can be taught through this apps and Google platforms, but skills we had a lot of tough. And we are very smart because we also have find out some of the solutions. All nursing colleges have done some of the solutions to make them skill. So we will discuss about that. So we have to bring gap, means bridge the gap between the education and technology. So we have to use our technology. Some of the technology are to improve our nursing students and teacher-student interaction as well as. So technology in nursing education, if nowadays for this, this is a recent statistics tells that 80% of us or classes are going on through online, like video conferencing. 75% of distance learning are doing it. 65% of used virtual simulation. 64% of have adopted online testing, and 60% of people are using electronic health that we have discussed earlier. 49% of having integrated digital connections, and 41% of people are using mobile app for their learning, and 37% of using the social media for their learning. Without in digital tool, how we can use for our nursing education. When coming to theory, in few of things we are already started using it, like we are now using Zoom platform, G Suite. I think G Suite, all our nursing faculty knows, students also knows. We can able to have a classroom, G Suite classroom. We can put the PPTs on there. Suite, whenever there is time, the students can read the PPTs and come for the other next classes. Google Meet, WebEx, and all those things have helped us to connect with our student. And computer assisted learning, we virtual classroom. So we only the teachers on the classroom, other students can join through the online, and teachers teach as if the students are listening in the classroom. Virtual conferences that we are doing now, and digital learning softwares, a lot of softwares, apps have came up. The modules also, we can teach our nursing students through module. We have for our pediatric, we have newborn module also to teach them. It contains videos, PDF documents with the material, and we can even train them with those modules. E-library, which is already there, and even digital library with the password and ID, we can able to access all the thesis books inside whatever there in our library. 3D printing and anatomical models, we can see here, like there are 3D printing and anatomical models. Wearable technology also we can use to teach, and social media also we can able to teach. And this is a virtual reality, how we can able to teach the students like anatomy and physiology, all those. Coming to the skills was the biggest task for us. So we can use the simulated environment. Like we can see here, we had an examination, we used to teach. This is our student of BSc Nursing 4th year. We have made this sees as a patient, like standardized patient, the same documents of patient's document we have kept, and our MSc students have learned with this patients, and she was trained to act as a patients. So simulated environment can be created, and human patient simulators. So same standardized patient, task trainer, each and one task trainer we can keep, like giving of IM injections, IV injection, we can fill the blood solution. So we can give IV injection, how to train the patient, child, students. And standardized patient, virtual reality, you can see this virtual reality. So patients, students can wear this virtual reality cameras, then we can, students can able to feel that they are in the simulated environment, virtual simulated environment. And virtual patients also we can able to make them that patients videos, we can show this to the students, and they can assess the patients through videos and 3D videos. And we can do here, they are doing surgeries here, so we can even live surgeries can be shown in the videos. here nowadays, even for examination, like evaluation also can be done through digital, like FEXA Lite exam softwares, Google Forms. We mostly use simulated environment. Here you can appreciate here, there is a virtual simulated environment. We can take the examinations. So we wear this goggles and we virtuality goggles, and we can see this. They can see that patient is sitting there. And Wheelbox safe examiners browsers are there. Virtual simulation exams can be done. Even if you see here, they can even write on the digital pen. With a pen, they can even write as a paper pencil examination. Pro and cons for technology in nursing education. Pros, it will improve the patient safety and patient care. Before going to the clinicals, they can just learn, and thus will increase the patient safety, time saving for nurses, cost effective investment for healthcare facility. It establishes the best practices, evidence-based nursing, enable on and on-site skills building, and increasing the proficiency of skill, response to nursing shortage. Coming to con, it is dehumanize the patient care. So though they are able to practice this, but still the humanity and empathy, sympathy can be reduced and not viewed as time saving by all nurses. Generation gap in learning and learning style. It may be perceived as a replacing critical thinking, like problem solving skill. We can just perceive like how they will do the problem solving and critical thinking. Maybe they will lack in their exact presentation of the skills. Potential for breaches in confidentiality too. Coming to nursing administration, our digital technology, how it is help our nursing profession. Clinical nurses leaders are expected to handle a number of other responsibilities, and this nursing healthcare professional should not have added a stress on tracking down needed equipment and consistently worrying about patient safety while trying to perform other job to the best of their abilities. So thankfully, the advancement of technology in nursing practice has improved how nurses perform their daily routines. In fact, more connection between nurses and nursing and technology help nurses to spend less time in menial tasks and more time with the patient. It is the implementation of these technology by nursing that helps to increase the efficiency of nurses in their units. So other than managing the manpower patients, so we spend more time for the other tasks. So real-time location system for nurses, that is RTLS, will help us, the nurse administrators, to locate all healthcare facilities, like where things are available, where our assets are available, where the nursing personnel has to be posted, which person working where, and where is my material available. So putting on online demand, getting inventory, all those things, and dispatch management we can do, patient wayfinding we can do, and all this will be possible by this real-time location system for hospital. A report shows that 95% of organizations that put RLTS into effect, so this operational efficiency have gained. Wireless patient monitoring also. The hospital environment, we can see that in hospital location system through Wi-Fi or to routers. So where the patients are, doctor are with the mobile devices and with the medical devices. So where the patients, all hospital environment even able to control in one areas. Patient and staff allocation system, identification system. So barcode, wristbands, and radio frequency identification all will work to track and identify the patient, non-effect and reduce error. That will reduce the error while also keeping the hospital population safe. Hospital are implementing the EVA-Sys Steady Sitter. It is a video observation system to improve the patient safety and lower the staffing cost. Last speaker was speaking about the centralized command centers. Yes, this also helping our administrators, nursing administrator, that they can able to command in one center, so that this can be more patients and more nurses can be managed in at a time, one area. coming to nursing technology in nursing education, yes, nowadays we have a lot of online researchers, online data collection we used to do it, and data handling can be done through online, and digital data management can be done. We can collect all digital data and put it on the digital line, and we can have together data, and big data can be managed through online, and virtual clinical trials like a VCT. Clinical trials also nowadays is possible, though researchers do the clinical trials through virtual. Online research also will help in other methods like online content analysis. So nowadays, all teachers, before we used to go for teacher on site and get the content analysis of our research topics or our questionnaires. Nowadays, we get through online and we give the patient corrections to online comments and suggestion on online only. Online focus interviews also is possible. So we can have through video conferencing, we can have selfie technique, data collection, focus interview, in-depth interview, all those things. And big data can be managed, social network analysis will be done, and web-based experiment also is possible through the online research method. These are all some online research tools that will help us for a referencing tool, plagiarism check, online missing data, all those things like Todoist and EndNote, Mentally, EduKit Club, GTRO, and Refox, Data Elixir, Paperfile, Plagiarism Checkers. This all will some of the app, some of the tool that we can use for the referencing. We can use for the plagiarism checker, grammar checkup, all those things. What are the advantages for the online research? We can access access the data across the globe. It's a cost effectiveness, easy to use for participant. Participant can sit on the space and use as well as for the researcher. Data analysis and reporting is very easy, and anytime, anywhere can be done. The research and candid response we will get it. A large sample size can be covered. Disadvantages, there are online limitations. We cannot access whoever is not having a network, and whoever is, so we can miss the samples. So if the online is not available to the persons, we can miss the sample. Close-ended questions can be the limitations. So only we can have optional questions. Non-response bias. So some of the people will not respond easily and will not get exact samples or the participants for our research. Sometimes we will miss some of the responses in between. So there's all the disadvantages for the online researchers. So together, we have seen about the digital technology, how it is helping a nursing practice, education, administration, and the research. So there are some benefits that you would have seen that, like we can increase the patient safety, it will improve the scheduling, it will decrease the human error, will reduce the test and procedure redundancy, and efficient care coordination can be done, and faster lab result we will be getting, increased patient information accessibility is there, and enhanced performance analysis can be seen. We can streamline the records and administration. It will reduce the hospital stay and will reduce the operational cost. Though there are some benefits, still we have challenges with us with the technology. So what are the challenges that faced with technology in nursing care? The first one is cybersecurity risk, the risk related to the breach of protected health information, risk related to the alteration of data that may be used to make wrong healthcare decisions, risk related to alteration of device, like functionality of the device that will result in adverse event, and impersonal patient interaction, patient and doctor interactions are reduced, patient isolation also. In that, we can see the patient interact with technology instead of live care provider. So lack of empathy are developed, lack of therapeutic bonds and communication, interpersonal relationship are lacking here, and risk for of miscommunication. And the mainly other thing is frustration with poor implementation. So clinician will spend more time struggling with technology rather than the patient care. Getting up the ready, learning the technology and coping up with technology. So we spend some of more time in struggling with technology than the patient. Too much reliance on technology. So we relies on technology. Traditional method maybe slowly it is paved off. So especially on poor in artificial intelligence implementation that do not produce a good outcome. Slow progress and lacking in leadership and the investment. So these are the challenges. So when we see this 5 stages of digital transformation, like first whenever it coming to the new technique, we deny. When we get anger, what is this? And we bargaining, which can be followed with for us, which cannot follow with us. We always see that this is okay, we can follow. This is not okay, we should not follow like this. And we'll never to be able to change. So we'll come to the frustration and we'll be changing some of, after studying, after giving a benefit, then we will see that we accept it. So nowadays, without, you can see here my grandpa weird, he was a phone without a camera and camera without a phone. So we need everything in one system and everything will be easy. We need instant and easy and comfortable. So take home messages. Nowadays, there is, though we have technology in our nursing profession, we have lots of benefits with technology. Still, there are some challenges. So we have to be very smart to access. We have to be very smart which technology can be taken off with the caution. Like we can see the old crow and modern crow. Old crow take more effort to bring the water out, but the modern is just have one tool to take the water out. So this all saves a lot of an extra time. So we have to be very much smart, which without a patient compromising of patient comfort and satisfaction and care, we can use our technology effectively. The only consistent feature is in the world is change. While all change may not lead to progress, there can be no progress without the change. So changes are consistently will change. So we have to adapt and we need to have get ready for the digital transformation. Thank you. Thank you for all for your patient listen.
Thank you, ma'am.
Yeah, thank you. It's a very good elaborative presentation on digital era. So here already we are living, as very rightly we are living with the digital era, but only it is all the time it is keep moving and keep changing. And what it makes the title means the future, maybe a little more changes may happen, and many of that whatever having it now. It maybe within this second, the following second, there are new innovations, new changes. It is keep on changing. So according to the change, we have to keep on with the change movement, and everything is a new one we need to face for. So that is the one. And in nursing specifically, we were focusing on only we are revolving around the medical field, and we were just touching everything. We are spinning around the medical domain, and then we are just following and or assisting or like that. So yeah, exclusively for nursing. So as like the separate university, Madam's vision, the Sudha Reddy also quoted about, and maybe entrepreneurship, Dr. Lata Venkatesh quoted a very lot, many new things, arenas, how individually the nurse can develop new theories. A lot, many things are there. The old one only we are following, old crow and modern crow use. So that is very, very touching. So that the technology, the small, that bird also it is using the newer innovations, and then how to make the things in a easy way, to get things in easy way. And simultaneously in an innovative way. So these are some of the new concept we are learning even from the bird. So that is the way we need to think about how to develop a new innovation particularly for our nursing, and how we can able to implement it and evaluate it. We are depending with some other discipline, maybe the technological engineering technology, and then the people are doing on their own, developing on their own, and they are getting grant and the patent and lot many things. But we are in lack. So we need to use our brain. So maybe the new syllabus or a curriculum, still more our Indian Nursing Council that we are going to implement the following year. And we all have to be oriented, all the teaching faculty and administrator to be oriented with, and we can go nook and corner. When I thought, when the syllabus of BSc Nursing long ago, when I was there in Ramachandra, when I just have gone through the syllabus revision by that time to implement for the Ramachandra University, so that editing and everything I have gone through. So by the time I felt, so the syllabus is too wide and it is almost having all the aspects, even including in master level, it is there. But whatever may be there, it is there. How much the graduates are taking benefit out of that, that is the one. I thought those time, I just felt like that. But the students are not taking to the only for exam. And one negative aspect of that thing I told, what I believe, I am telling, I'm not critiquing, but my perception I can share to the group, because of the annual pattern of exam. The students are not at all studying till the end.
Yes.
Till the end, only they used to sit for 1 week or 2 weeks. But they depends on the only the study holidays. If you give, they will go and sit and read. 99% of the students, now they are not reading every day, and every day keeping up their updating knowledge, and that and all the unit tests they fail. And only the assignment will be pulling their internals to come. So these are some of the negative drawback, even though the technology or the digital, any involvement in the healthcare field domain, it comes. Only thing, how far we are utilizing it effectively. So this is what I'm telling you. Either the syllabus or maybe the technology, and how far we are, anything is new, we need to have a curiosity to learn. As like the child, maybe in the pre-school time and all, they will be very curious. The children are very curious in learning new things. But after coming in, nowadays, the graduates, after coming into the nursing, okay, we came and without studying itself, without touching itself, the patient, we will get a degree and we will fly off immediately. So many agencies are there to getting them to put into the track to go for to fly off abroad. So this is the concept the people are having now. Not for serving to the society or learning things more and implementing things more. So these are the things where we are in lack. We need to know either in technology and we need to adhere everything, not only the only touching care. So we need supplement with the technological care as well, because no one can escape from the technology. We all have to adhere the technology, and the simultaneously the touching care also it is needed. Yesterday, Sir, Pro Vice Chancellor Medical and Health Science rightly told, so that no one can replace the human touch. So that was the thing. Even medical dean also emphasized that thing, and medical health, because they know, they are the medical people, how far the touching effect of by the nursing professional. Why the nurse, even though many healthcare professionals are there, the nursings who take care of the patient. So those patients will have the frontliners or nurses to touching the care during that time, and they didn't even, they put their life into risk a lot. Many, there are various few nurses might have handled in that way. And there are exceptions in that also. Some survival of the COVID patients, they used to tell, even the nurses are also, they used to talk with a little bit language unethically. So,
Yes.
so unethical during that, if the patient expired, they used to say unethical words also. That also they are representing. After the survivor, they used to tell. One of my relative itself, they told about nursing. The bad side of the nursing also, it is there. We have to accept that. Because even words, it hurts the patient.
Really?
Not touch alone. Even the words which we are speaking in front of them. So that is unethical practice. We should not do it. Why I am telling, as being a nurse, the technologies are there, touching is there, feeling is there, lot many things are there. Only thing with humanity you handle the patients. So that is the one request we need to follow. All of us, while providing care, utilize the digital service, technology, you have to update, and touching care also you need to know.
Yes.
Even by putting a word of concern also, it is very important how much you are portraying their the respect which you are going to provide for the patient, even in the critical time. We should not talk about unethically.
Yes,
People
we have to go.
Yeah,
we have to go with digital with humanity.
Yeah, that's what I'm telling you. Digital along with
humanity.
technology, and then humanity is much more essential when dealing with patient in any stage of their illness. So that is very important.
Nowadays,
yeah,
being a faculty means we feel that what type of education and skill we are teaching through last 2 years only, we means all teachers might have felt that it is lacking. The empathy and sympathy, the humanity we teach our students are lacking.
Yeah, students are lacking, hand skill is lacking, humanity and everything without studying and online exams and other thing with manipulation getting past. The technology, the other side, it helps the students how to manipulate the technology in a negative perspective. Only the people are
the misused.
Misused of the technology. So many of the online exams, how they perform. So
that was a challenge for us, really.
It is a challenge for the teachers as well.
Yes, that's what. It is a challenge for teachers.
Yeah, that's what. So here also we are in lack. So we need to we are going to bridge with it. So it is a very big challenge in front of all of us, for the student and for the faculty. Otherwise, it's a very nice, very good presentation to engulf all the technology of how it is used, and in the future also. We are in the technological era only, as we are.
Yes, ma'am. We are on technological era,
and we need to improve with keep updation or pass.
Yes.
So that is only it makes us to keep the title like this.
Sure.
So otherwise, I thank on behalf of SRM College of Nursing. You have given your own justice for your title. Thank you so much, Ma. In future also, we will keep in. Thank you. Thank you.
Thank you, ma'am. Thank you so
much. Thank you.
Thank you, madam, for an elegant and interesting presentation on digital future in nursing profession. We do understand the technological advancement, which is not equal to learning outcome, but you have rightly mentioned it is a tool that will enable us to achieve the learning outcome. And our Honorable Dean, as I rightly identified, it is being misused. So it happens so that technological advancement and humanity has to be two sides of a coin, which cannot be separated, but it has to be handled together.
Yes.
Based on the situations.
Yes.
Thank you, ma'am. Thank you once again for this wonderful session, ma'am. We take this opportunity to share our memento of certificate to the honorable speaker. Thank you once again, ma'am.
Thank you. Thank you for this opportunity. Thank you, ma'am. And thank you all the organizers.
You're most welcome.
Our pleasure, ma'am. Our pleasure. Dear delegates, we have come to the end of the morning session. Now I take this opportunity to emphasize on the feedback link and post-test link that is being shared into your email ID. Please do take your time. We re-emphasize again to complete the post-test link and the feedback link as and when immediately, because it has been taken in account for the conference certificates. So kindly take your time to fill up the post-test link and
Kavita?
feedback link. Yes, ma'am.
Kavita, what about Jiva? Her time is given 1:16 to 2.
Yes, ma'am. We have informed you, madam. We have informed, ma'am. We have informed, ma'am.
When she is coming for the session again?
Madam, will have to come. Actually, we thought we informed at 1:15, ma'am. But now again, after 30 minutes, we'll have to inform her to come by 1:30, ma'am.
No, I am asking you.
Yes,
You are
ma'am.
also asking question to me. It is
No,
not
ma'am. No,
to- I am
ma'am.
asking what is the arrangement? It is been done.
Now the arrangement is that we will be requesting madam to come by 1:30 p.m.
1:30. Then
Yes,
the
ma'am.
audience also join.
We will
by
be
1:30.
informing now,
Okay.
ma'am. Now we
So
will
that
be
is the
informing.
answer. That's all.
Yes, ma'am. Thank you,
Okay,
ma'am.
thank you.
We request the delegates to break up for the lunch by 1 p.m. now, and you'll have to come back and resume the session by 1:30 p.m. for the next plenary session. And now we take this time to project the breakout rooms for the afternoon scientific research paper presentation. We have 2 breakout rooms for you to present the paper, and namely room number 1, Nightingale room, room number 2 as Dorothy room. We would like to project the list of the students for the breakout rooms now. Kindly take a view of it. Kindly take a view of it, the timing and the rooms. And if you have any queries, kindly contact the number that is being projected, that is being shared in the chat box. Please contact the number that is shared in the chat box for any queries related to scientific research paper presentation. I repeat again, we do have 2 breakout rooms. Room number 1, Nightingale room, that is being highlighted in yellow color. Room number 2 is Dorothy room. Kindly look into your list of names and timing for the breakout rooms. Now the room number 2, Dorothy room, is being projected here. Please look into your timing and the schedule. For any queries, kindly contact into the contact number that is being shared into the chat box. Thank you all. We'll meet up after 1:30 p.m. By 1:30 p.m., we request you to join for the session. Thank you one and all. Please take your time to fill up the post-test link and the feedback form. Thank you.
I found that nothing in life is worthwhile unless you take risks. Nothing. Nelson Mandela said, "There is no passion to be found playing small and settling for a life that's less than the one you're capable of living." Now, I'm sure in your experiences in school and applying to college and picking your major and deciding what you want to do with life, I'm sure people have told you to make sure you have something to fall back on. Make sure you got something to fall back on, honey. But I never understood that concept, having something to fall back on. If I'm going to fall, I don't want to fall back on anything. I want to fall forward. I figure at least this way I'll see what I'm going to hit. Without consistency, you'll never finish. So do what you feel passionate about. Take chances. Don't be afraid to fail. There's an old IQ test, was 9 dots. And you had to draw 5 lines with a pencil within these 9 dots without lifting the pencil. The only way to do it was to go outside the box. Don't be afraid to think outside the box. Don't be afraid to fail big, to dream big. But remember, dreams without goals are just dreams. Reggie Jackson struck out 2,600 times in his career, the most in the history of baseball. But you don't hear about the strikeouts. People remember the home runs. Fall forward. Thomas Edison conducted 1,000 failed experiments. Did you know that? I didn't know that. Because the 1,001st was the light bulb. Fall forward. Every failed experiment is one step closer to success. You've got to take risks, and I'm sure you've probably heard that before, but I want to talk to you about why that's so important. You will fail at some point in your life. Accept it. You will lose. You will embarrass yourself. you will suck at something. There's no doubt about it. And I know that's probably not a traditional message for a graduation ceremony, but hey, I'm telling you, embrace it because it's inevitable. In the acting business, you fail all the time. Early on in my career, I auditioned for a part in a Broadway musical. Perfect role for me, I thought, except for the fact that I can't sing. I didn't get the job. But here's the thing. I didn't quit. I didn't fall back. I walked out of there to prepare for the next audition, and the next audition, and the next audition. I prayed. I prayed, and I prayed. But I continued to fail, and fail, and fail. But it didn't matter, because you know what? There's an old saying, you hang around the barbershop long enough, sooner or later you're gonna get a haircut. So you will catch a break, and I did catch a break. Last year, I did a play called Fences on Broadway. But here's the kicker. It was at the Court Theater. It was at the same theater that I failed that first audition 30 years prior. The point is, every graduate here today has the training and the talent to succeed. But do you have the guts to fail? If you don't fail, you're not even trying. I'll say it again. If you don't fail, you're not even trying. To get something you never had, you have to do something you never did. So imagine you're on your deathbed, and standing around your deathbed are the ghosts representing your unfulfilled potential. The ghost of the ideas you never acted on. The ghost of the talents you didn't use. And they're standing around your bed, angry, disappointed, and upset. They say, we came to you because you could have brought us to life, they say. And now we have to go to the grave together. So I ask you today, how many ghosts are going to be around your bed when your time comes? Just got back from South Africa. It's a beautiful country, but there are places there with terrible poverty that need help.
Ma'am, Jiva ma'am, good afternoon ma'am. Ma'am, is my voice is audible?
Who is in the line, ma?
Ma'am, good afternoon, ma'am. Actually, Jiva ma'am needs a trial, it seems, ma'am. She's using it for the first time. She needs a trial. She requested for trial, ma'am.
Okay.
Okay.
Hello, good afternoon.
Yes, ma'am. Good afternoon, ma'am.
Is that okay if we just try?
Ma'am, your voice is not audible, ma'am. It is not clear.
You are able to hear it? Is that okay now?
Yes, ma'am. Yes.
Okay, thank you. Could you please share the slide so that I can see it once?
Yeah. Yeah, ma'am. Can you able to view the slide, ma'am?
Yes, yes, I'm able to see it.
So control will be from my side, ma'am. I will be changing the slide. You can
Once I finish, I will request you to change the slide so that time you can skip to the next slide.
Pardon, ma'am? Sorry, ma'am.
Once I finish the explanation part, I will
Okay.
request you to move on to the next slide.
Yeah. I'll do that, ma'am. I'll do that.
Okay, ma'am. Okay, thank you.
Okay.
Thanks a
Thank
lot.
you, ma'am. Thank you.
Africa is just the tip of the iceberg. The Middle East needs your help. Japan needs your help. Alabama needs your help. Tennessee needs your help. Louisiana needs your help. Philadelphia needs your help. The world needs a lot, and we need it from you. We really do. We need it from you young people. I mean, I'm not speaking for the rest of us up here, but I know I'm getting a little grayer. We need it from you, the young people, because remember this. You got to get out there. You got to give it everything you got, whether it's your time, your talent, your prayers, or your treasures. What are you going to do with what you have? I'm not talking about how much you have. Some of you are business majors, some of you are theologians, nurses, sociologists. Some of you have money, some of you have patience, some of you have kindness, some of you have love, some of you have the gift of long suffering. Whatever it is, whatever your gift is, what are you going to do with what you have? All right, now here's my last point about failure. Sometimes it's the best way to figure out where you're going. Your life will never be a straight path. I began at Fordham University as a pre-med student. I took a course called cardiac morphogenesis. I couldn't read it, I couldn't say it, I sure couldn't pass it. So then I decided to go into pre-law, then journalism. And with no academic focus, my grades took off in their own direction. I was a 1.8 GPA. And the university very politely suggested that it might be better to take some time off. I was 20 years old. I was at my lowest point. And then one day, and I remember the exact day, March 27th, 1975, I was helping my mother in her beauty shop. My mother owned a beauty shop up in Mount Vernon. And there was this older woman who was considered one of the elders in the town. And I didn't know her personally, but I was looking in the mirror, and every time I looked at the mirror, I could see her behind me, and she was staring at me. She just kept looking at me. Every time I looked at her, she kept giving me these strange looks. So she finally took the dryer off her head and she said something I'll never forget. She said, "Young boy, I have a prophecy, a spiritual prophecy." She said, "You are going to travel the world and speak to millions of people." And in the years that followed, just as that woman prophesied, I have traveled the world and I have spoken to millions of people through my movies. Millions who up till this day couldn't see me, who up till this day I couldn't see while I was talking to them, and they couldn't see me, they could only see the movie. They couldn't see the real me. But I see you today, and I'm encouraged by what I see. And I'm strengthened by what I see. Because taking risk is not just about going for a job. It's also about knowing what you know and what you don't know. It's about being open to people and to ideas. Chances you take, the people you meet, the people you love, the faith that you have, that's what's going to define you. Never be discouraged. Never hold back. Give everything you got. And when you fall throughout life, remember this: fall forward.
Ma'am, good afternoon, ma'am. Ma'am, good afternoon, ma'am.
Good afternoon, Dr. Kapil.
Yeah, yes, ma'am.
I think my video is not displayed. So,
Yes, ma'am, we are doing it, ma'am.
okay.
Ma'am, please wait, ma'am.
Okay, okay.
Ma'am, would like to kindly intimate to you, ma'am, the speaker, ma'am, your voice is getting echoed here.
Oh,
Could you please check? Yeah, ma'am.
Okay, 1 second.
Ma'am, can you check out your microphone, ma'am, to place it near to your...
I'm trying to.
Yes, ma'am. This is to avoid the echo only, ma'am.
Yes, ma'am. Yes, I understand.
Thank you. Respected Dean, ma'am. Jiva, ma'am, we are in the queue, ma'am. We are in our stand. We will intimate to you, ma'am.
Yes, ma'am. Yes.
Thank you. Ma'am, Jiva ma'am, can you hear me, ma'am? Ma'am, are you there, ma'am? Jiva ma'am?
Yes, I'm able to hear you, ma'am. It's clear.
Yes, yes, ma'am. I'll start now, ma'am.
Yes, ma'am, I'm ready. Shall we?
Wait, ma'am. I'll just introduce, ma'am.
Okay.
We have come to the good afternoon to one and all. We have come to the afternoon session. Transcultural nursing key issues and concern. We realize the growing concern on the cultural healthcare needs of varied ethnic groups. Now, I extend my invitation to Mrs. Priyadarshini, Assistant Professor, SRM College of Nursing, to introduce our distinguished speaker of this afternoon session. Mrs. Priya, over to you.
Thank you, ma'am. Good afternoon, ma'am. I'm so honored to introduce our last keynote speaker of this conference, Mrs. Jiva, Lecturer, College of Nursing, National Institute of Mental Health and Neuroscience, Bangalore, Karnataka. Madam has completed a BSc Nursing in Adipara Shakti of College of Nursing in the year 2003. Madam also pursued Masters in Nursing at University of Delhi, New Delhi, and also awarded PhD in Nursing in the year 2020. Winning an award is always a special moment. Madam is awarded with Save Ratna Dr. R. Venkataselu Gold Medal for the meritorious achievement in BSc Nursing, and also awarded the President of India Gold Medal for meritorious achievement in Master of Nursing. Madam has undertaken many research projects, including funder research projects. Madam has been resource person for various international, national, and state conferences. Madam also published articles in high impact factor journals. With this brief introduction, I would like to invite Mrs. Jiva for the presentation. Over to you, ma'am.
Thank you, Mrs. Priyadarshini, for the kind welcome. I deem it a great honor and privilege to be a part of this 8th national conference, virtual conference on the theme Resilience and Reinvention in Nursing Education, Practice and Research Towards Excellence, which is conducted by SRM College of Nursing in association with Society for Nursing Practice. The theme chosen for this particular conference is very apt because this is a time of resilience. Because the current situation, we are facing a lot of challenges, newer challenges which are upcoming, as well as we already have some existing challenges which we are facing to overcome. So I extend my warm thanks to the organizers of this conference for inviting me to be a part of this conference as a resource person. So with this note, I begin the topic. The topic that has been given to me is transcultural nursing, issues and concerns. Speaking about transcultural nursing, the master students might be very familiar about this particular aspect of transcultural nursing because it is there in their syllabus. From the name, we understand that we can see this aspect at 2 levels. One is at micro level and other is at the macro level. What is micro and what is macro? I can say our own country, India, is rich in diverse cultures. We have different groups of people following different varieties of beliefs, practices, cultures, customs. So I consider India to be at a micro level. And then next, moving on to the global population, the world level, we have different countries, we have different groups of people, minorities as well as the other ethnic groups. They have their own practices, they have their own customs. At the same time, we are all faced with common challenges of health and disease. So when the population becomes more diverse like this, India is very rich in culture, as I say, both within the nation as well as outside the nation. And we need different group of healthcare providers with different skill set to handle those diversified problems related to health that takes the ample demand, and it wants a different group of healthcare providers with a different skill set. And when we see at both the levels, both micro and macro, the needs of the patients are diverse. Even the people suffering with the same disease may have two different needs. You can't quantify it. You can't give the same aspect of care to both the patients just because they are suffering from same disease. They have different opinions. They have different viewpoints about their disease, and how they perceive the disease. They have different preferences in the choice of treatment. They have different preferences in the choice of treatment. One may opt for surgery, one may opt for chemotherapy, one may say that it's okay, let me continue live with the disease like this. And these differences culminate to influence virtually every aspect of care. So, because of all these needs, we have transcultural nursing has become a very important component of healthcare. And it has become a basic requirement in today's practicing nursing because there is a soaring in multicultural phenomena occurring in our global population. We can see one more thing is, I would like to add here, there is a great demand for skilled workforce, especially nurses, at the global level as well as at the national level. I will not say that we are nationally self-sufficient and our Indian nurses are going abroad. The reasons they go abroad are various reasons. But India is considered to be the largest exporter of nurses to the global world, to the world and the other countries to serve the population of the world. Next India, we have Philippines. Then we have the other countries which do the same, but India being the leader. And the nurses who are educated in India are going to take care of the people or patients who are accustomed to different culture. They are very different from what they have seen in India. So naturally, the need for transcultural nursing comes in. We need to understand that we are going to serve a very different group of people than our very own people, what we have seen. So our nurses have to be prepared to serve the population both within the country as well as outside the country. Although I said that our nurses have to be prepared to deal the reasons for whatever I have explained just now, we have quite a group of challenges and issues what they will be facing, which we will be discussing in the subsequent slide. I would like to request to go back to the previous slide. Yes, thank you. I would like to emphasize here the definition which has been given by Madeleine Leninger. She is the forerunner, or I should say that she is the founder of transcultural nursing. We also will be seeing about her a little bit in the consequent slides. So according to her, she considers this transcultural nursing is a formal area. It's not something which came out of a blue. She wants it to be very professional. So she says that it's a formal area of study and practice, which is focused on comparative holistic cultural care. So what she understands, she wants to make sure that the person who gives care and the person who receives care are two different people exposed to two different sets of culture. But what we want them to do, the health and the illness patterns of the people who belong to the different cultures, we have to compare and contrast. We have to see what differences they have and what way they are similar, and then provide care to those clients, in which we have to consider the culture, the values, the beliefs, and the way they live, with the goal to provide culturally congruent, competent, and compassionate care. That's the main goal. We want to give a congruent care. That means what? We want to provide them a standardized care. We want to mix the differences and compare and contrast the differences and similarities and come to an idea and provide a competent care, which is the basis of nursing. And compassion is a thing which is always there in the humanistic approach. So such kind of care only she expected the transcultural nurses to be to give to their clients. Next slide, please. So I want to summarize the reasons. Although I have explained to you why there is a need for transcultural nursing, I just want to summarize it in 3 points. The reason one is diversity is critical to future healthcare. What was the care and the system and the diseases which we faced 50 years ago is not the same what we are facing now. The same thing will not continue for the next 50 years. So the healthcare system, the healthcare services, even the diseases are going to be very new for us in the coming future. So hence we need to be prepared to provide customized, culturally sensitive and safe care to our clients. And we should be able to provide and accommodate and cater the health needs of different minority groups. Again, we are assuring that people also will not be same. There may be a new group of people who are coming, maybe a new ethnic race coming out, maybe a new groups of people or high risk population which is emerging. So we need to address this. Next slide, please. And second thing is, although we think about future, we also have to think about the present day, the today of healthcare. So transcultural nursing is also an essential aspect of healthcare in today's world. What is happening in today's world? In today's world, I very clearly explained that we need a skilled workflows. We need the people to scatter to different kind of population. But when we are catering to the needs, healthcare needs of different kind of population, we are faced with significant challenges. Facing those significant challenges, we are supposed to provide individualized and holistic care to the clients whom we serve. So this transcultural healthcare satisfied the need so that nurses are traveling, they are crossing the language barriers, they are fulfilling the rights of the human rights in whichever group and populations which they serve. They fulfill the expectations, they overcome the cultural conflicts, violence, and also lawsuits. So this is the second reason why we need to understand transcultural nursing. And the last reason, next slide please, is the demand which the society is placing on the nurses as well as the healthcare delivery in general. We need to understand the client, family, and a large group of community from social and cultural perspective. Because more than disease, there is some more than the disease and the health, the way in which the people live, the customs, the beliefs, which frames their background of their life, plays a very important role in how they handle or how they view the health and the disease. When we go to community, especially in the community health nursing field, we do a survey, especially the beginning of the thing is we do the survey before when we go to a village or to an urban area, wherever it is. We want to understand what is their context, what are their preferences, and based on which we need to build our care. So the similar thing exists here. We need to implement culturally acceptable strategies to provide nursing care and identify and use resources which are acceptable to the client. The greatest success of Pulse Polio program, you can remember that also. All of us are familiar with this National Pulse Polio program. How it became a huge success? It is because it was acceptable to the people whom it is being delivered. So today's demands of the people, whether it is an individual person, whether it is the family or the community where that particular person resides, take into consideration the social and the cultural context also. So these three reasons summarizes why do we need transcultural nursing and why we need to prepare transcultural nurses. Next slide, please. So I think we can move on. Next slide. So we summarize the goals of transcultural nursing as our main aim or our main goal is to provide culturally congruent nursing care, that is culturally acceptable nursing care, and we want to provide care in a culture specific and universal nursing care practices. Just because I'm going to give care to a specific group of people doesn't mean that I have to sacrifice my nursing principles. I need to provide culture specific care. Along with that, I need to uphold the universal nursing care practices for the health and well-being of the people. By doing this, I'm trying to help the nurses as well as the human beings who are in an adverse human condition. That means those people who are sick, those people who are ill, or those people who are facing death because of the suffering of a disease in a culturally meaningful ways. So in simple terms, I'm trying to make them comfortable. So this is the goal of transcultural nursing. Next slide, please. So in the beginning, I said when I was speaking about definition, I was speaking about a person who was the founder of transcultural nursing. So we are just going to see a brief note on that and then move to the issues and challenges. Oh, next slide. Next. Yes. So she is Dr. Madeline M. Leninger. She is the founder of transcultural nursing. If you ask me, is this a new field of nursing or new branch of nursing? You can see it from the slide very well. This particular field of nursing emerged long back, very, very long back in 1950s. And she is the first professional nurse who finished a doctorate degree in anthropology. And she was teaching on transcultural nursing course at University of Colorado in 1966. And she later became the editor of Journal of Transcultural Nursing till 1985. She was the editor. So this particular person has brought nursing and anthropology together. So she thought that health and illness and the culture are all interrelated. So she coined the term transcultural nursing and made it as a formal area of study and practice. Just like we do BSc nursing, they also have a course on transcultural nursing, which prepares nurses. Now this transcultural nursing course is available in variety of universities across the world. So, but during the beginning time, in the University of Colorado, she is the first person who started this particular transcultural nursing course. And when she was developing this particular course, she also developed a theory. So her theory is called as culture care diversity and universality theory. This was one among the earliest theories, and till today, this is the only theory focused specifically on transcultural nursing with culture care focus. So we have only one theory from the beginning till today, but changes are there that we will be seeing it in the upcoming slides. So she understood very well that the contribution of anthropology to nursing is very, very important when we are going to deal with health and illness states, and the health and illness of the people are going to be influenced by the culture in which they are brought up. Okay, so this was her strong belief, and based on which this transcultural nursing has stemmed up. Next slide, please. So I think we have already spoken about this theory, and this theory has made little changes and refined in the year 1975, and she has brought a more refined way by using a model. That model is called a sunrise model, and then later it was expanded from 1975 and 1983 during this particular period, where she did a lot of research work and teaching. It has given a wider perspective for her, which helped her to refine this particular theory, which she has started in the beginning. Next slide. So this theory is called as Madeline Leninger theory, transcultural nursing theory. And we all know very well, every theory has a theoretical framework. This theoretical framework is this one. It is appearing like a sunrise, okay, a half semicircle. So it helps us to discover the culture care in the sunrise model. I'm going to discuss the aspects and the concepts which are discussed in the this particular model in the next slides. Next slide, please. Thank you. So here we are going to discuss in this particular slide the three concepts. The first concept is called as world view. World view is what? No, the model looks like a sunrise, and the world view encompasses everything that makes the people who they are. So what is a worldly view about what they think about something? And then the next one is we have cultural and the social structural dimension, which are the next large areas that nurses need to understand. And how do they learn or understand? They need to talk to people, they need to interview, they need to live among the people who belong to different culture, so that they will have an idea about the culture and the social structure. And then the third one is diverse health systems. Below this particular individuals, family, group and communities and the institutions, we have diverse health systems. What is this diverse health systems? These are nothing but healthcare delivery system. The healthcare delivery system in India is very different from what is there in the Western countries. The healthcare delivery system in India is different from what you see in the European countries, Middle East and the other countries of the world. So we are going to learn about this diverse health systems. Next slide. Okay. Then we also should not forget about learning the generic or the forensic system. Just because we have a generic system, we are not supposed to forget the traditional system of medicine, what we have. If I have to put you in a clear way, in India is rich in tradition again. We have ancient culture, we have medicinal practices like Siddha, Unani, Ayurveda. Okay, these are all based in, they are folk systems, or we call it as Indian system of medicine. Okay, so like that, around the world, they also have their own generic or folk systems, which every day they use it as a remedies for individual, family or group, so that they promote the wellness and healing. What are the examples? Some people prefer having chicken soup, some people have chamomile tea or other herbal teas, some people sacrifice birds and animals to the spirit, because their philosophy is disease is caused due to invasion of spirit or to sanctify some gods. Some people believe in prayer. So these are all also adversely affect the health and illness towards how they deal their health problems. So nurse has to understand and assess all these areas and provide safe and effective care to the people whom they are serving. And I think already said about this professional system. Professional systems are the healthcare professionals and the systems in which they work in to provide care. Let it be a government, if I have to compare it with the government India scenario, I will say it as a government health sector. That is like we have PSC sub-centers, we have government hospitals, then we have medical college, tertiary healthcare hospitals, then we have private insurance, then we have central government health schemes. So, and some we have some NGOs which are helping the people. So all these things comes under professional systems. So nursing, it is important, or it becomes imperative for the nursing people to collaborate with this healthcare delivery system and thereby provide care which is culturally competent, safe and effective. So these are the concepts which are discussed in that particular sunrise model of theory of transcultural nursing. Next slide. So at the end of this discussion of this concept, Leninger suggests 3 approaches. She says that we have to follow 3 approaches if we want to, she says that we have to follow 3 approaches if we have to implement this culturally congruent care. So the first approach is called as cultural care preservation or maintenance, where we look at what nurses can do to preserve and maintain the cultural practices of the individual and the family, so that they receive safe and holistic care because of the health system. And the second approach is called as cultural care accommodation and negotiation. So here what do? We try to negotiate, where we look at what we are as nurses can do to accommodate the patient's needs and negotiate with the patient in the healthcare environment so that we are able to provide cultural congruent care. And the third one is cultural care refactoring, or we call it as restructuring the cultural care, where we look at what we nurses need to do with family and the patients to restructure their life ways in order to promote healing and wellness. And we also have to be understanding of the cultural influences. Then only we can make this restructuring. Of course, it's very difficult, but if we try through evidence-based methods, it's possible. But we are not trying to, wherever it is necessary, we have to restructure it. Otherwise, we have to modify our approach. So we understood that. We understood that we need both cultural competence and we need both cultural congruence, because one without the other will survive. So what are we supposed to do now? We are supposed to deal both. We need competence as well as we need congruence. So what is cultural competence? I think competence is a word which summarizes three important aspects. One is knowledge, second is skill, and the attitude. Okay. So cultural competence means demonstrating knowledge and understanding of the client's culture and developing an awareness of one's own existence, sensation, thought, and environment without letting it to have undue influence on the other or those from other backgrounds. Accepting and respecting cultural differences and adapting care to be congruent with the client's culture. So this summarizes the cultural competence. And when we speak about cultural competence, we have 4 levels. Next. And next. Yes. We have 4 levels of cultural competence. You can see it. We have unconscious incompetence. We have conscious incompetence. We have conscious competence. And we have unconscious competence. These are the 4 levels of cultural competence. Unconscious incompetence is at unconscious level itself. Even though we are as healthcare providers, nurses, we are not being aware that one is lacking knowledge about other person's culture. At unconscious level, we have this problem. Number 2 is conscious incompetence. That is being aware that one is lacking knowledge about other culture. That is, we know that we are not knowing about the cultural aspects of the persons whom we are serving. The third one is conscious competence. This is learning about the client's culture, verifying the generalizations about client's culture, and providing culturally specific interventions. This is the need actually. And the last one is unconscious competence. Once we are used to provide conscious competence again and again to a wide variety of people or exposed to a different culture, it becomes a part of it. It becomes a part of us automatically to provide culturally congruent care to the clients of diverse culture. So cultural competence develops in these stages. And with this very important stages, the third stage is a very important stage where we have conscious competence. At this level, a nurse takes deliberate attempts to understand the other person's point of view. And then slowly, with the virtue of practice and experience, she develops the skill and the ability to implement or to serve a different group of population. Next slide, please. How to develop cultural competence in nursing? And we have a framework for delivering the culturally competent nursing service. So we have Campina, Backwoods and Munoz in 2001. They proposed a 5 model for developing cultural competence. The first model is cultural awareness. The first concept of the model is cultural awareness. That means we need to analyze, we need to do a introspection, self-examination, or the in-depth exploration of one's own cultural and professional background. So this is the first aspect. The next aspect, next slide please. Cultural knowledge. We need to involve ourselves in seeking and obtaining information on different cultural and ethnic groups whom we are going to serve. So how do we know? In the beginning itself we said we can know it by living among the people, we will know, by speaking to them or by having an interview we will know, but there are other sources also. Like you can learn it from the journals. See, if I'm going to work in America, doesn't mean that I will go and live in America and come back. It's quite expensive now. So what do? I try to understand what happened to the people, what kind of healthcare people problems are there, what kind of practices they have, what kind of lifestyle they do. So all those things, I have variety of resources now available, virtue of internet and other sources. We have journal articles, we have seminars, we have textbooks, we have internet resources, we have workshop presentations, and we have university courses. We have so many. So through this, a nurse can gain cultural knowledge. And knowledge always have to transfer as skill. So once you gain knowledge, you need to implement the acquired knowledge into practice. So the cultured skill involves nurses' ability to collect relevant data regarding the patient's present problem and accurately performing a cultural specific assessment. So we have a lot of models to understand this, how to collect, how to do a cultural skill. Next slide. And then cultural encounter. We use the word, in simple terms I should say, we use the word cultural shock. People belonging to different kind of cultures, when they face each other or when they expose them to a different new culture, they usually use this word as cultural shock. Here we are using a polished term, cultural encounter. So it is defined as a process that encourages the nurses to directly engage in cross-cultural interactions with the patients from culturally diverse backgrounds. It is not going to be a shock for the nurse because the nurse is already preparing herself to serve a different group of population. So she has acquired knowledge already, she has acquired skill, now she is putting it into practice by exposing herself into a healthcare environment, by dealing or by providing care to people belonging to different diverse backgrounds. So developing cultural competence can be mastered with virtue of experience. And finally, cultural desire. This is an innate nature. I should say that this cultural desire is an innate nature. It's the quality of an individual and the willingness to be open to others, to accept and respect the cultural differences, as well as to be willing to learn from others. So all these things summarizes, or if we do all this, practice all these concepts, we will be able to develop cultural competence in our nurses. Next slide. So who are these nurses? All are nurses. We have various specialty nurses, oncology nurse, pediatric nurse, then we have cardiac nurses, then we have variety of nurses working in different school health nurse who works in the school. So like that, this particular nurses are going to crisscross across the world and they are going to serve a wider population, a global population, and they are referred to as transcultural nurses. They belong to a different culture from originally what they are to serve a different population who is having a different subset of cultural practices. So transcultural nurses are the nurses. They can be a specialist, they can be a generalist, or they can work as a consultant. But what do? They study the interrelationship between culture and how it influences the health of the individual from the nursing point of view. And these nurses are always knowledgeable, competent, and they are able to provide care to diverse cultures both to themselves as well as to others. Next slide, please. So what is the main role which they perform? They determine the client's cultural heritage and language skills. They also determine if any of his health beliefs related to cause of illness or problem. They collect information that any home remedies or person is taking to treat the symptoms. They evaluate their own attitudes towards ethnic nursing care. See, sometimes what is okay in India is not okay in America. What is not okay in America, what is not okay here may be okay there. So even sometimes we need to evaluate our own feelings, our own attitudes in relation to the other ethnic nursing people background. So this self-evaluation helps the nurse to become more comfortable when she provides care to the clients from diverse background, because it helps us to gain more acceptance. Okay, it is not necessary hard and fast rule that somebody has to be like this only. So we are going to meet a different group of people from different variety of culture. So a generalized acceptance has to set in. So for that, she needs to understand this background phenomena. Next slide. So once she collects all this data, next slide please. So she will be able to better understand how the culture, race and ethnicity helps or shapes the social emotional relationship, the child rearing practices and attitude towards health. For example, if I take in Japan, I'm just going to give you an example of child rearing practices. In Japanese culture, if you, from the age of 5 years, the children go to the school on their own, either by walk. They are not dependent on their parents, just like we wait here in India. We wait here, we put the children in the bus, then we wait in the evening to collect them back, or we go and leave the children to the school, then we go and then bring them back. This is in Japanese culture, they make the child independent from very, very young age. Whereas it is a quite contrast in US culture. In US culture, if you leave the child unattended, even to cross the road, you can be penalized by law that you are not taking adequate care of the child. So in case if the child falls sick or something happens to the child because of your negligence, if any health issue arises, then also you will be penalized by the court of law. So the culture, the race, the ethnicity is going to bring a new dimension how we are going to approach health. And the other thing which is very important is the religion, the religious practices of the family and their influence on the health promotion beliefs in the families. The religion is the other thing which shapes the beliefs of the people. People have different opinions about different gods, and some people believe that God will solve their problems. Some people believe that they have to take care. God is not going to do everything. But all these things are going to play a very important role in how they take care of their health aspects. And when the nurse is going to formulate a nursing diagnosis, she needs to understand all these interactions. She just should not see only the patient as only a physical body or a physiological system. She needs to consider all these dimensions and then formulate a nursing diagnosis. And then she needs to plan and implement nursing intervention based on the client's cultural background. Next slide. Next slide, please. Okay. So now we are into our main area of the topic. We are going to really address here about certain issues. It can apply, I'm not going to use the word India, global, it applies to both. So we are going to see about how this transcultural nursing, what are the issues which are there at all levels, even it is applicable to our Indian scenario. So we are going to try to understand that particular part a little bit. So we know very well when a patient is getting admitted to your hospital, the behavior of the patient is influenced in part by his cultural background, how he responds to the healthcare, to the disease, and to the services what he receives. Based on that, the culture plays a very, very important role. And we also have to understand people belonging to the same culture may not behave same way. Everybody is unique. For example, people belonging to Asian race. Do you think that we Indians behave the same way? North Indians behave in a different way. South Indians behave in a different way. The China people behave in a different way. So we cannot categorize. People belonging to same culture will behave same way. That is, I want to use this word stereotyping. That means generalization. We should not label saying that people belonging to this particular aspect will behave in this way only. It applies to healthcare behaviors also. So when we are caring for a patient from a culture different from our own culture, we need to be aware and respect his or her cultural preferences, beliefs, and we also should consider, otherwise what will happen? That particular person has brought up in a different culture. That person may think we as nurses are very insensitive. We are very indifferent. Maybe even she thinks that we are very incompetent. So we don't want to, because our cultural system is very, very different from their system. So we need to beware that all members of one culture act and behave in the same way. We should not assume that in that particular manner. In other ways, we should not stereotype people. So how to avoid this? Even people belonging to a same culture, we need to view the patient as patient or as individual. And then we need to provide individualized nursing care or the unique nursing care based on the needs and the problems of the patient, considering the cultural background of that particular person. And how do you understand the culture? Because the patient has just come in. He has been shifted to the OT or to the OR room or to the emergency. So what you can do in abroad and all, in Indian situation, we don't have this particular practice. But in abroad, they have a cultural assessment tool. They have a questionnaire through which they will be collecting all the information, and it will be available to the other members of the healthcare team to see it. I think in India also we have that, but not in a very formal way. If you see a lot of corporate hospitals, I cannot say government hospitals, lot of corporate hospitals, they have this cultural competent care. They give a lot of importance to the background and the place from which the people come in, and they respect their time, space, and the other things. So we do have, but not in a very formal way. Next slide, please. So now I am going to discuss about certain aspects where we are facing challenges. And what are we supposed to do to overcome these issues and the challenges which we are facing because we are from different cultures. So number one, next slide, please. The first one is space and distance. We have something called as interpersonal space. People generally, as people, the space immediately which is around us, we feel that it is an extension of ourselves. Some people, the amount of space they prefer between themselves and the others to feel comfortably is a cultural determined phenomenon. In some cultures, what do they do is they feel that they need to maintain social distancing. Maybe if it is the same gender or even if it is the opposite gender, they need to maintain a decent distance. In some gender, they say that they feel very close or comfortable only when they are physically close to each other. So the next slide. Here we are giving you an example. Most people, but we generally as people, we are not very conscious of our own personal space requirements. It is as nurses, we may be unaware about what people from another cultural context expect. One person from or one patient from one culture may think that when you are sitting next to him or when you are going to interview him, by sitting next to him, the person belonging to one culture, he may think that, okay, the nurse is caring, the nurse is showing warmth. But other person may, from a different culture, may feel that you are invading his personal space by coming close and sitting very close to him. So we need to understand the cultural perspective in relation to space, especially the physical space, and appropriately restructure our behavior to make the patient comfortable. That is much, our clients are our, what to say, our clients are very important for us, and they are already stressed by their own illnesses, and they have come to a city or town or even to a country. Medical tourism, you can see so many people from Bangladesh, from Malaysia, from Singapore, from United UAE countries. They all come to India in need of treatment. So we need to understand that physical space is very, very important, and respect that. That's very important aspect. That's one of the challenge. Next slide. Eye contact. We are all taught in our nursing schools. I think even when I was a nursing student, I have been taught that whenever we are supposed to maintain eye contact with the patient. That's the thing what we have been taught. When we are speaking to the patients, some people from different cultural backgrounds may prefer that you don't. You may ask me, madam, is there somebody who doesn't want to maintain eye contact? Because we always say with our students, when we take lectures, we want them to maintain eye contact. When we provide care to the patient, we say that we have to provide undivided attention to the clients, so that they feel that our attention is being given to them, or he receives the whole care to him. But as I say, it is not accepted in certain cultures. I am using this word, your. When I use this word, your, it means nurses, we. Okay, we all are nurses. So our strong gaze may be interpreted as a sign of disrespect, especially among Asian, American Indian, Indo-Chinese, Arab, and Appalachian patients who feel that direct eye contact is impolite or it is very aggressive. So they feel very uncomfortable when you are going to make eye contact. Next slide. Next slide, please. So what do? We have already seen that they are not very comfortable in maintaining eye contact. So why are they not feeling comfortable? Because these patients may avert their eyes when talking with you and others. They feel that if you are maintaining eye contact, you are having authority over them. They want to avoid that. So they don't like that. So hence they don't want to maintain an eye contact. One example here I am giving is an American Indian patient may stare at the floor during the conversation because he believes that not maintaining the eye contact or having the field of vision towards the floor conveys a respectable behavior to a person who is providing care to him. And he also says that he is paying close attention to you. So we have to understand the cultural perspective behind it, and being aware that whether a person makes eye contact or this may help us to reflect his cultural background, and it helps the nurses to avoid misunderstanding and make him feel more comfortable with you. What we may think as nurses, I am saying something, you are looking into the floor, but that is not the action side of the story. He, according to his culture and custom, that is the way he listens to you, and that is the way he pays respect to you. So the third aspect which I am going to discuss as a challenge is time and punctuality. I really don't know what we have to say about it. Time and punctuality definitely varies from one culture to other culture. For example, if you take an American population, just like in India, when we are sick, what do? We walk into hospital. We go to any hospital. We just want to get cured. And if we are not satisfied from one hospital, we jump to other hospital also. Without any announcement, without even a referral thing, sometimes we move. But it is not so in case of countries like America, where if you want to meet a healthcare professional, you have to fix up an appointment, and that will not be available immediately. Maybe only in an emergency situation you can walk in, but other situations you are expected to wait minimum a period of 1 week for your health examinations or for your illness. Of course, they will attend you telephonically, but they will give you a time, an appointment to discuss about your health and illness. In American scenario, as I said, what is happening is they wanted to be very proper. They wanted to, on your fixed appointment, you need to be there. On your fixed schedule, you need to finish your treatment and then you need to walk off. Not being punctual is not acceptable in terms of them. But in some people, other culture, time is a relative phenomena. They think that it is very little attention they give to exact hour or minute. In other situation, the American situation, what I described you, they value their time as well as other people's time. But in the other culture, what the next example I'm going to give, that people are not going to value the time of the other person. Next slide, please. For that, the other person, they may feel that maybe there is an emergency family issue. So he skips the appointment and then he attends to the family matter. Okay, because for that particular person, family is more important than his health. So that is the way that culture has brought him. So when such patient reports to us, what are we supposed to do is, we are supposed to not scold or acting annoyed. The reason is, when a patient, when you are going to scold or act annoyed when the patient is going to be late, he may feel he may feel undermined about his confidence in the healthcare system. And maybe he also will mix the appointment. Maybe he is not comfortable to come back to you later. Okay. So by maintaining the effective nurse-patient relationship, we will be able to solve this issue. The next slide. So the next is touch, physical touch. Again, the meaning people associate with touching is culturally determined to a great degree. In Hispanic culture as well as in Arab cultures, male healthcare providers may be prohibited from touching or examining certain parts of female body. Similarly, females may be prohibited from caring for the male counterparts. So the definition of touch in different culture is very, very different. Next slide. So what are we supposed to do? There is one few more to it. In Asian Americans, touching a person's head may be impolite because that's where they believe the spirit resides. Spirit is, we have something called soul which resides. So when we are going to deal with such, assess or request a permission, clearly explain why you are doing that and what is the need for doing it. Always consider a patient's culturally defined sense of modesty when giving the nursing care. One more, the modesty example here is the people, women belonging to Jewish and Islamic women, they usually cover their head by scarves, arms and legs with the clothing. So we have to respect their tradition and help them to remain covered while you are providing the care also. Next slide. So the next issue which we are facing globally, not only a particular ethnic or racial background, communication is a universal problem. So in some aspects of care, the perspectives of healthcare providers, the patients and the families may be in conflict. According to nursing philosophy, we may be very correct. But from the family point of view, it is not acceptable. Now we are in a conflicting situation. So what to do? One example here is giving is informed consent and the right of full disclosure. According to nursing philosophy, what are we taught? We are taught that we always have to provide adequate information to the patient and take consent before you provide any kind of intervention to the patient, and you have to provide full disclosure about his health and illness. that is being taught to us. Because we feel that every patient has the right to full disclosure about his health, prognosis, disease, so that he is informed about his health. But what the family feels here? The family thinks that already he is sick. Why to inform everything and make it more complicated? That is from the family's point of view. But what you are saying is from your principles or philosophy of your professional point of view. So when such situation comes, again here we have to bring in the aspect of cultural competence. So similar dilemmas arise in our nursing practice. Some patients may refuse pain medication. Some persons may say they don't want treatment for the disease which they are suffering from because their cultural and the religious beliefs are against that particular thing. Especially you can see this among cancer patients. A patient diagnosed with cancer, some people you can see, they don't take any kind of medication. They think that the divine intervention will work. They believe in faith healing. But we don't know whether it worked because of his own immune system or divine intervention or taking care of treatment. You cannot do anything at these situations or such dilematic areas. So we have to respect the right and the decision taken by the patient and the family members. So next slide. So thinking about the beliefs and recognizing the cultural bias, the world view, all these things we have to keep in your mind as nurses so that we are able to understand the differences and we are able to resolve the cultural and ethical conflicts which we may face during the process of giving care. So whenever we are facing these ethical dilemmas, we are expected to promote an open dialogue with the client, with the families, as well as with the healthcare providers, so that we are reaching a culturally appropriate solution where all the three partners are satisfied with the decision which we have arrived. Next slide. And then diet. This is also universal, both within our country as well as abroad. Cultural meanings are associated with the food vary widely. If I say the Indian belief, sometimes for some festivals, some group of people they are like pure vegetarian. Some people they think that for feasting they prepare all non-vegetarian foods. In Muslim community, sharing food or eating from the same plate is considered as a universal sign of brotherhood. So like this, so many examples we can give. So diet has a lot of meanings, culturally meanings which is being accepted to, attached to it. So we are going to see it in the next slides. Next slide, please. So it also, culture also determines which foods are served when, the number, the frequency of meals, who will eat with which person, and who gets how much amount of food. All these things is also decided by the culture. You can see in the Indian population, the women eat the poorest. First, the men in the house eat, then followed by the children, and finally the women eat. Nowadays, the situation scenario is very different. Okay, but this is the thing which is being practiced in majority of the people in most of the parts of the country. The frequency of meals. The standard meal is 3 times a day. If you take the northeastern India, they eat only 2 times during the sunrise and the sunset. Who eats with whom? Whether children eats with the husband or children eats with the wife or children eat with the grandfather or the head of the family eats alone. So all these things are determined based on culture. Culture also determines how foods are prepared and served and how they are eaten. Whether they use chopsticks or they use the bare hands and fingers or whether they use forks and in which shop they buy the food also. Okay, so all these things are based on the culture. And then religious practices also comes in diet. During certain religious days, fasting is practiced. Some people don't eat some kind of food. They avoid certain medications, especially for example, if insulin is prepared from pork, pig, Muslims are forbidden from eating pork. So they will not be very comfortable in taking insulin, which is derived from pork. Of course, they may not be knowing about it, but in a culturally sensitive environment, if they really want to know about it from where the insulin is prepared, if they know that insulin is coming from this, we have various sources. I'm not saying only from the pig it is coming. We prepare insulin from various sources. So we understand that the dietary practices may include the ritualistic use of food as well as beverages. Beverages include consumption of alcohol. And then if you see about the Western culture, European population, they may tend to eat in groups. They feel very happy to celebrate. They tend to feast, often with the family and friends on selected holidays. Especially during Christmas, they have Christmas dinners. They have during Easter, again, they have a big dinner. They have family get-togethers. During that time, they consume high-calorie, high-fat foods, pastries, candies, so which all will have an impact on the health aspect, especially if they are patients of diabetes, hypertension, GI system. So where dietary modification is very, very important. Next slide. These are the few based on religious background I have put. Hinduism, all kind of meat, especially among vegetarian, all meats are avoided. Animal shortenings are avoided. As I said, Islam, they are prevented or prohibited from eating pork, alcoholic products and beverages, animal shortenings, and gelatin, which is made of pork and all those. In Judaism also, pork, predatory fowl, shellfish, all these things are avoided. Still a wide list is there. I just want to show you very few. So I have brought this. Next slide. Holidays. These are very favorite for all of us. Whether we are sick or well, if it is a holiday, we don't want to spoil that holiday by going to a hospital when we are sick. So as a healthcare provider, we need to be very familiar with the holidays for the cultural group, the hospital in which we are working in. You cannot schedule a surgery or an appointment for your client on a festive day. You cannot, so you need to be very, very clear about the various celebrations. Maybe, for example, marriage anniversary is there, birthday is there. On birthday or marriage anniversary, if you are going to put them in the OT table, they may not be very comfortable. So we need to be understanding about the holidays, their preferences, both at the civil level as well as the religious level. And then we have to avoid health appointments, diagnostic tests or surgery or other major procedures should be avoided. Next. Biological variations. As I said, no two individuals are same. Although we are having 2 legs, 2 hands and 1 head and little brain into it, biologically, physiologically, we appear to be same, but every individual is very different. So we have a psychosocial adaptation also along with that, the physiological component. That is the reason you say that some kind of cancers are prevalent in some people. For example, if you take Kaposi sarcoma, it is more prevalent among the African population than the Asian race. If you take sickle cell anemia, it is very common among Mediterranean people when compared to the other races. So the biological variations always exist based on the culture or based on the ethnicity, and how we react to that illnesses also vary. For example, pain medications adherence to treatment. It was found very, very well. Americans, they adhere to the treatment very well. Pakka, they follow it dot to dot. Okay, whereas the other cultures doesn't show that they are very competent or they adhere to the treatment in a very particular manner. So biological variations also differs. Next. So here I think here one more example is there about anaphylactic reaction. For one patient, a normal dose of medication may cause allergic reaction, but for other patient, it may not show any reaction at all, because he may belong to a different culture, his body resistance is there, his genes is there, his immune systems are very different, maybe the diet, maybe the genetic makeup, everything is very different. So these are the examples where our physiological behaviors varies. Next slide. Environmental variations is a place where we live and the people whom we meet. So we have wide range of beliefs about man's relationship with the environment. Some people think that when they are sick, they want to go to a hospital, they need to take the help of healthcare providers, get well, and have control over their health status. Some people believe that when they are sick, everything they will surrender to something, let it happen, whatever happens, let it happen. So they don't have the control over the environment or the factors which cause the disease in them. So such kind of variations also exist. I cannot say that this is right and that is wrong. Both are right from their own perspective. So you as a nurse have to understand these differences exist in people and we have to accommodate this and then we have to provide nursing care to these people. Next slide. Next slide. So these are, I think, around 9 challenges or 9 issues we have discussed. In what ways the cultural aspects are very, very different among the people, both at national level and global level. Even we can add more, the cause of the disease. So we have so many things to discuss. So those things can be described, but I think most of the things we are familiar with. So I brought at the global level. At the end of this today's session, I would like to conclude by saying that because we may have a doubt in India, I spoke so many about abroad and other things. Do we have transcultural nursing care in India? To prove that, I brought a study which has been published in Journal of Transcultural Nursing, which was published in the year 2021. So this is a qualitative study. This study was done by Risa Lauren et al. And she has studied about interpersonal communication in transcultural nursing care in India. So the results of this particular study says that Indian nurses or the nurses who are going to be educated in India, they need to develop communication skill as well as language expertise. Then they will be able to provide not only culturally competent care, but they also will be able to deliver culturally congruent care. And they also will be mastering the knowledge, language, and the communication skill together. So we understood that there were a few more studies on the experience of the nurses who have migrated to abroad countries. Okay, so like this, thousands of studies are there. So I have taken only the communication aspect. The reason is that is a major problem in our country, both within the country as well as outside the country. Language and communication plays a very important role. So even if you cross half of our country, the North Indians speak mostly, majority is done by Hindi speaking population we have, and below the Maharashtra and Madhya Pradesh, we have the people speaking Kannada, Malayalam, Tamil, Telugu, and Marathi. Still we have, even if you take Kannada, Karnataka, we have Tulu, one language additional is there. So we have wide variety of languages. So we need to master all those things and we need to improve our communication skill. So out of all the skills which is there, I feel that communication skill is very, very important. So I have added a few tips of how to address this communication issues that may arise for a nurse. Next slide, please. So to solve the problem of communication issues, always we have to greet the patient using his last name or his complete name. Avoid being too casual or familiar. Point to yourself, say your name and smile. We train to introduce ourselves. In Indian scenario, what do? We just, from the uniform what we wear, the person understands that you are a nurse. And then we just don't bother about introducing ourselves to the patient. We just walk in and we start to dictate. Okay, so we are not supposed to do that. If you are going to become a culturally competent nurse, it is your duty to introduce yourself with your name and try to know about the patient name. This is also one of the problems which we have is we call the patient by bed number or by disease. Okay, so that also should be avoided. And then we are always busy. Proceed in an unhurried manner. So we are always busy. We should avoid that. We should give time. Pay attention to any effort of the patient or his family makes to communicate. When they have some clarifications to make, please give them time and then explain them in a clear, concrete way. And the voice and the tone of the nurses also matters a lot. We as nurses should use moderate voice. In a low tone, avoid talking loudly. I would like to remember or remind one of the phrase in which one of my teacher during my undergraduate days has said, he said that nurses should be seen, not heard. What is the meaning of this phrase is, we are all loudspeakers. When we are there in the ward, we speak loudly. We shout from one corner to the other corner. Of course, we understand workload, other things are there. But nurses, our activities, our actions should speak, not our mouth. So avoid talking loudly. Remember that we all have the tendency to raise the volume and pitch of our voice when a listener appears not understanding. But what he may think that sister is angry and hence she is shouting at you. So nurses should be seen, not heard. And then organize your thoughts. Repeat and summarize frequently. Use audiovisual aids whenever it is possible to make the person understand. If you want to say something to the client, if you feel that the client is not understanding it, think what can you do better to make him understand. And if he may not be very comfortable with medical jargon, idioms, slangs, so he may not know anything. So use short, simple sentences and speak in active voice. Use words which is understandable to him, just like using the word pain instead of using the word discomfort. Avoid using the word contractions like don't do this, you can't do this, you won't do this. Such kind of contraction should be avoided. Instead, you have to use nouns instead of pronouns. For example, ask your patient parent, does Juan take the medicine? You have to address it by the name of the person. Instead of asking, did he or she take the medicine? When you ask by name, the patient and as well as the patient party feels comfortable. They think that you are concerned about his care. Next slide, please. Next slide. Okay. Discuss one topic at a time. Please go back. Discuss one topic at a time and avoid giving too much of information in a single conversation. I always see nursing students, when they are writing health education, they want to cover everything together in a single topic. Everything they want to finish it in this thing. So we have to focus only one idea at a time. Instead of asking, are you in cold and pain? Separate your questions and ask them, are you having cold? Do you have pain? Did you understand this? Today I'll be teaching you only about food care. Tomorrow I will teach you about insulin administration. So handle the things in separate parts so that the patient feels comfortable and he also will be able to comprehend them. Validate whether the patient understands by having him repeat instruction, demonstrate the procedure you taught him, or act out the meaning. Show him. Sometimes he doesn't understand by hearing from you. So you have to repeat number of times. Even after repeating number of times, if your client is not understanding, if you show, he will better understand. And use any appropriate words you know in person's language. When you use the person's native language, he feels very comfortable. He respects. So he feels more comfortable to address these issues with you. And try to learn another language, a common language, so that bridges the problem of language and communication. So these are few tips to handle the problem of communication issues. So with this, we are coming to the conclusion of today's topic, where we have learned about how transcultural nursing has influenced the way in which we provide care to our clients, and how as transcultural nurses, we need to be sensitive to the cultural differences of the individual patients, their needs and their preferences. And we also need to respect their culture by asking about it, their beliefs, their related healthcare practices, so that the patient is also actively involved in the recovery process. So I hope that all of us will understand the importance of transcultural nursing, not only for the people who are having idea to go abroad, even for our own people whom we are serving at the local level. Not all people are same. They are from different cultural background, different place, rural, urban. We have variety of divides. So all these things, what we learned, we need to apply it in the practice. So with this note, I come to the end of the session.
Thank you, madam.
Thank you, ma'am.
Very elaborate. Okay, thank you. Very elaborate and too lengthy presentation. So she has taken a lot of effort and to bring a lot of cultural models, and then including the importance of communications, everything almost she covered. It is very vital for all the nurses, even though the time is expended, but it is very useful information, and she doesn't leave. And even though if you give a time alert and everything, but anyhow, it's a good presentation. You have covered in elaborate way. All it is very much useful for the nursing fraternity to deal with patients, various kind of patients within country, with other country as well. The extra language learning, everything is very vital for us. Otherwise, we couldn't able to take care of the patients effectively. So it is very important as being the nurse. So that's what, okay, anyhow. So it is a very good presentation. Congratulations. Yes, thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you, madam.
Thank you.
Proud privilege for me to be a part of the session.
Thank you. You're almost
Our
welcome, ma. Almost
Our
welcome.
pleasure, ma'am.
Thank you.
Thank you.
Thank you.
Thank you, madam, for your informative and discerning presentation. We really understand the importance of cultural competency, and that is very much required for the nurses. And how this cultural competency ensures patient satisfaction, patient outcome was very well elaborately explained to us, ma'am. We take this opportunity to thank you very much for the effective presentation. And now we take this opportunity to share our memento of certificate to the distinguished speaker. Ma'am, can you please unmute, ma'am?
Thank you, ma'am. Thanks a lot. It means a lot to me. It was a good experience for me to interact with a wider audience. So once again, I thank from my end to the organizers of this conference.
Thank you.
Thank you.
It's our pleasure, ma'am. Now, I request all the delegates and the participants to just join the session to have a glimpse of photo as a screenshot. Can I request to join and switch on your video? We will take glimpse of photo. Please. Let us join with a smile, please. That's so beautiful. Let us say cheese also.
இந்த முடிய போது எல்லாரும் ஒரே ஸ்மைலிங்ல விட்டு ஓடலாங்கிற மாதிரி உட்கார்ந்துருக்கீங்க. ஓடலாம் முடியாது. இது இன்னும் இருக்கு. இன்னும் 3 பிரேக் அவுட் ரூமா? 1 or 2, 3? How many?
2, ma'am. 2 breakout sessions.
3 பார்த்த மாதிரி இருந்துச்சு. அதான் திடீர்னு மாத்திட்டீங்களா என்னன்னு.
No, ma'am. 2 breakout rooms.
சரி,
As
okay,
we said,
okay.
Thank you.
So that
the photo session done. Ma'am, we are still in the process of
அதுக்கு தான் எல்லாரும் வந்துட்டீங்களா?
Yes, ma'am. Yes, ma'am.
நான் எல்லாரும் ஒரே சிரிப்பா இருக்கே அப்படின்னு பார்த்தேன் நானு. என்னன்னு ஒண்ணும் புரியலையே. என்ன எல்லாரும் சிரிக்கிறாங்களே எனக்கு.
We need your same smiling face, ma'am.
Okay, இது இவங்க வரலையே. அது இவங்க காணோம். அது அவங்க இல்ல மார்னிங் பிரசன்டரா? மேடம் வந்திருக்காங்க.
ஆமா ஆமா. Yes, ma'am.
பிரசதா.
பிரசதா ma'am.
Sister.
Sister Prasada.
Sister, she is not there. It is blocked. Video. அது ஒண்ணு மட்டும் பிளாக்கா இருக்கு. Okay.
Are we done? Photographer is busy taking few shots, ma'am. Done, ma'am. Thank you very much for all of your.
கீழெல்லாம் குடிஞ்சிட்டு இருந்தேன், எடுத்தாங்களா தெரியல. இப்ப கீழே குடிஞ்சுக்கிட்டேன். குடிஞ்சு இருக்க போற ஒழுங்கா செக் பண்ணிட்டு சொல்லு. தெரியல, அவர் எடுக்கிற மாதிரி எனக்கு தெரியல. நான் கீழே ஏதோ குடிஞ்சிட்டு இருந்தேன்.
One minute,
நினைக்கிறேன். பழி வாங்கிருப்பாரு நினைக்கிறேன். பழி வாங்கிட்டாங்க போல. யார் எடுத்தது?
Priyadashini is on the process.
பிரியதர்ஷினியா? ஆப்பிள் போட வச்சுக்கிட்டு விளையாண்டுட்டு இருந்தது. சரி, பாரு, செக் பண்ணிட்டு சொல்லுங்க.
Yes ma'am, sure ma'am. Ma'am, no ma'am, you are beautiful ma'am. You are with smiling face ma'am.
Sure, okay.
And now, dear presenters, we have opened the breakout rooms. Can I request all the presenters to join your respective breakout rooms?
இல்ல, அதுல 1 2 3 ன்னு 3 நம்பர்ஸ் இருக்கு, அதனால தான் கேட்டேன்.
That is the step ma'am, process to enter into breakout room.
Okay.
Yes ma'am. I once again repeat, all the presenters, please join to your respective breakout rooms. Participants, please hold on. We will be allocating you to the breakout rooms. Please click the link join. You will be entering into the breakout room. Presenters, please click the icon that is with join. You will be entering into the breakout rooms. Participants, please wait. We will be giving you information about the allocation into the breakout rooms. We request you to wait patiently. I repeat again, we have 2 breakout rooms. Room 1, Nightingale. Room 2, Dorothy. Please enter into your respective breakout rooms.
என்ன கலெக்ஷன்?
Dear participants, those participants in section A will go into Nightingale room, and participants under section B will go to Dorothy room. I repeat, we have 2 breakout rooms. Room 1, Nightingale. Room 2, Dorothy. I request participants under section A enter into Nightingale room and participants under section B enter into Dorothy room. Yeah.
My participants who are in main room kindly join into the respective rooms. Participants, kindly join into your respective rooms.
Good evening. All are ready, ready for the valediction? Kavita?
Ma'am, 2 more minutes, ma'am.
Yeah. Only, where are they? Only 25 participants are there. Where are all the other people, ma?
Breakout rooms, ma'am. They are joining, ma'am.
Ma'am, they are in breakout group, ma'am. Second.
Sure. சீக்கிரம் வந்தா சீக்கிரம் முடிக்கலாம் இல்லனா அப்புறம் நேத்து மாதிரி லேட் ஆயிடுது கமெண்ட் அடிச்சிட்டு ஓடாது.
Almost over, ma'am.
Ask them to come join first.
Yes, ma'am. Sure.
Still any presentation is going on? Is it over?
Sir, it's over, ma'am. Now it's over, ma'am. They're joining in main group, ma'am. One by one, they're coming.
Okay.
Ma'am, can I start, ma'am? Can I start, ma'am?
Ma'am will be joining now.
Yes, ma'am. We'll wait, ma'am. Thank you.
Hello.
Yes, ma'am.
Oh, all have joined. Yes.
Yes.
Hmm.
Good evening, ma'am.
Good evening.
Valedictory is not the end, only a different beginning. I take this opportunity to solemnly welcome Professor R. Vijayalakshmi, Vice Principal, SRM College of Nursing, to deliver the welcome address.
Thank you, Kavita. A pleasant good evening to all, respected Dean Ma'am, dear organizing team, delegates and SRM College of Nursing students. I welcome you all for the valedictory session of the 8th National Nursing Virtual Conference on the theme Resilience and Reinvention in Nursing Education, Practice, Research Towards Excellence. We are at the closing end of the 2 days conference. All the keynote speakers did an exemplary presentation glorifying the conference proceedings. We express our heartfelt gratitude to all of them. The scientific paper presentations were resourceful. My deep sense of appreciation for the presenters, for their participation, and the session chairs for their contributions. I close my note. Once again, I welcome you all for the valedictory session.
Thank you, ma'am. The most successful event is the one that achieves your goals and exceeds your expectations. Let's look into the report of the conference to know our extent of success. I request our Honorable Dean, SRM College of Nursing, to read out the conference. Madam, over to you, ma'am.
Yes, good evening to one and all gathered here for the valedictory session. So it is my pleasure privilege to present the report of 2 days National Virtual Conference. The theme of resilience and reinvention in nursing education and practice and research towards excellence for 10th and 11th of February 2022. So the 8th National Nursing Virtual Conference on the theme has been organized by SRM College of Nursing in association with the Society for Nursing Practice. The registration, the total registration, so it has been carried out through Google form till up to 9/2/2022. So the total number of delegates registered 663, out of which based on the designation, so the students, 426 students, nursing students, and staff nurses 70, and faculty 167. The delegates from Tamil Nadu, by region wise, Tamil Nadu 570, and delegate from other state, it is 91, and delegate from other country 2. So based on the institution and the organization, so SRM IST and SRM Hospital together 355, and all other institutions 308. So the day 1, 10/2/2022, the inauguration was started at 10:30 a.m. and the invocation, with the invocation and lighting of Kuthuvilakku, the dean, myself, welcomed the gathering, the dignitaries and the participants, followed by the Honorable Vice Chancellor, Professor Muthamil Chelvan, SRM IST, delivered the presidential address. Dr. Lieutenant Colonel A. Ravikumar, Pro VC, Medical and Health Sciences of SRM IST, delivered the inaugural address. Dr. Bimla Kapoor, the professor and former director, School of Health Sciences, Nursing Program Coordinator, Indira Gandhi National Open University, delivered the chief guest address. The chief guest released the souvenir virtually, and it was received by Professor Muthamil Chelvan, Vice Chancellor of SRM IST, and Dr. Lieutenant Colonel A. Ravikumar, Pro Vice Chancellor of Medical and Health Sciences, SRM IST. Dr. A. Sundaram, Dean Medical of SRM Hospital, felicitated the gathering, followed by Mr. Rudra Banu Sadapti, CEO of the Society for Nursing Practice, Bioleagues, delivered the special address. Professor Vijay Lakshmi, Vice Principal of SRM College of Nursing, proposed vote of thanks. The day one plenary session started by 8:30 a.m. Dr. Asha Shetty, Principal AIMS Bhubaneswar, highlighted on partnership and innovation, the future of nursing education. Followed by the session 2, commenced by 9:30 a.m. Dr. L. Gopi Chandran, Associate Professor from AIMS Delhi, discussed about mixed method of research, a cornerstone of evidence-based practice. And then the third session started by, after the inauguration, Dr. Jasmine, Professor, College of Nursing, Mother Teresa Postgraduate and Research Institute, Pondicherry, the title on Health Informatics and Future of Nursing Education. So the fourth session, deliberated by Dr. Lada Venkatesan, Professor and Principal, AIMS College of Nursing, Delhi, the theme on transforming nurses' role. So that is entrepreneurship in nursing. And the session 5 is handled by Dr. S. Madhavi, Professor, Principal, Faculty of Nursing in KMCH, Coimbatore, Tamil Nadu, discussed, it presented a title on Interdisciplinary Research, Collaboration, a Roadmap to Nursing Excellence. Then the session 6, it is handled by Dr. C. Kanyamal, Professor, Dean, SRM College of Nursing. So dealt on the academic nursing leadership, shaping the future of nursing education. The scientific, followed by the scientific paper presentations, was held between 3:50 p.m. to 5:30 p.m. on 10 to 22. About 7 scientific papers have been presented. Then the day one ends with that scientific paper presentation. Followed by the second day, the plenary session of it is started by 9 a.m. Dr. Alfonsa, Vice Principal of St. John's College of Nursing, Bangalore, Karnataka, presented on the title of Translational Research, Aligning Knowledge to Practice. Then the second session, followed by Professor Dr. Sudha Reddy, Principal, Heger Institute of Nursing, Belagavi, Karnataka. She highlighted the topic on current and future educational challenges of nurse educator. And then followed by the telehealth, nursing technology meets human care. So it is presented by Vasanta Kalyani. Vasanta Kalyani, Principal, AIMS, Diohar, Jargat. And then the fourth session, Professor Vijay Lakshmi, Vice Principal, SRM College of Nursing, SRM IST, deliberated the title on Centralized Command Centers, Advanced Nursing Technology Transforming. Then the fifth session, it is started by following that, the plenary session titled on Nursing Profession and the Digital Future, handled by Mrs. Malarkodi, Assistant Professor, AIMS Rishikesh, Uttarakhand. The afternoon session 6, it has been started by Jiva, Assistant Professor of NIMANS, Bangalore. So she highlighted the topic on transcultural nursing, key issues and concern. Followed by the plenary sessions, about it is 23 papers, scientific paper presentation has been presented by the participant, the presenter, between 2:30 to 4:30 p.m. Total number of scientific presentation for 2 days, it's 30, and 60 presentation from students of SRM College of Nursing, SRM IST, so and 12 from faculty side of other institution, and 2 from faculty from SRM College of Nursing, SRM IST. I congratulate all the 30 members to share their scientific reviews to keep pace with the recent trends and other research contribution towards it is the way we have to improve. So I congratulate all the presenter of the scientific sessions. And then now we are in the closing phase. So that now with the feedback, now I hand over this thing to Kavita to present about the feedback.
Thank you, ma'am. The key to learning is feedback. It is nearly impossible to learn anything without feedback. Dear delegates, your opinion is important to us. I would like to share the feedback of the delegates virtually. Here we have a slide showing on the feedback of overall presentation of the conference, wherein we found almost for the 5 criteria we have assessed, and under the presentation we found 90% of them felt satisfactory and they felt good about the presentation. And with regards to content of the topics that was delivered, 92% of them felt very, very good. And with regards to audiovisual aids, 95% of them felt it was very good. And new learning was learned and it was appreciated by 90% of the public, participants. And time management, again, 96% of them felt good time management.
Okay. So there
Thank you, ma'am.
Any
now,
yes, is expected from the delegates?
Yes, ma'am. We have got virtual presentation of feedback that was subjectively given by the delegates, ma'am. The conference was well organized and the thought-provoking and innovative sessions were organized and selection of topics were very appropriate and good. And all the topics were very sequentially arranged and punctual and clear content was delivered. The speakers that was arranged for 2 days were eminent. Presentation content and attractive slides were good. And newer topics, excellent resource persons were present in the 2 days conference. Time management was good and talented, and the team has organized the present conferences very well. This is the feedback that is given by the participants, and the suggestions that was given by them where the conference can be conducted in offline. They felt that offline would have been better for them and conference timing should be limited, and this is a suggestion given by them. And some of the participants have felt overwhelming of session in a day and it was difficult for them to grasp the content that was shared in 2 days.
Okay, so thanks for very nice critics and suggestions from the participant. So it shows they are most involved in all the session. That's what true critics, it has been elicited from the participant, and we will take everything into a future event. So actually we thought of conducting this conference through offline only. But due to various reasons, we couldn't able to plan it offline this time. And probably, so everything is for the betterment. So for example, if you take, we could not able to mobilize all the resource persons, various the corner of a place within India. We have called them within very short time because we're waiting for the nursing council the credit points, and finally we could not able to do that if possible, and then we moved to virtual. Even after that also we have applied for, and the last final day, within one day or 2 days prior to the conference, we got a message from council, you can apply for offline only from the month of February, but we couldn't able to switch from virtual mode to offline immediately. So it was impossible for us. So we couldn't able to make it possible. Kindly bear with us. So, but anyhow, you take the good points. You can any event. We may have good and some negative comments as well. So we will take it into an account, and we are also interested. We have a very good auditorium and accommodations, and everything is possible within our university. Only thing, due to some reasons, we couldn't able to make it possible this time. So maybe probably for the following conferences, when we are arranging, we will do, we will do, try to fulfill your expectation of the audience. So that is the one from our side. And then the time limit also, all the presenters, resource persons are very well into their content, and they too also have, they want to take up time and explain things. So it shows the interest. So I kindly request all the participants. So when we are getting some new knowledge, we should not count for time. So that is the thing we need to keep in mind. But anyhow, so we make it possible. At least we have to timely lunch with time, and the other thing we have given for all the participants who are in the campus, our students and other people are also some inconvenience. Kindly excuse us, and we will try to remove all these obstacles or any of your difficulties in later on in the forthcoming events. We assure that. And time grasping content. So it is only eye-opening. All we cannot memorize any of the event. So just you take home messages from each of the presentations and have some good initiative ideas in your mind. Based on that, you can build as like a building block. So it is only for eye-opening with the key points. So the participants try to recall and reinvent, and you enhance your knowledge, skill, and attitude, and everything you can improve. So because it will be, if you recall, so automatically everything will be coming into, because it is sometimes our brain is maybe overloaded with of informations. So by the time recalling little bit difficulty, you can get the help from your faculties as a student, and faculty you can from the peer, you can very well have interaction, any of the doubts and other thing we can share within ourselves to improve to enhance our knowledge, all of us. So this is what my perception. So kindly bear with some kind of difficulties if it occur for the last 2 days. Thank you so much for critiquing effectively and given a very good comment about we have to analyze the negative aspect also whenever we are doing. That only it will make us to correct our mistakes or any suggestions to be improved, we will take into future. Thank you so much.
Thank you, ma'am. Gratitude is a quality. Gratitude is a quality similar to electricity. It must be produced and discharged and used in order to exist at all. Now, I cordially invite Mrs. Meghala, Assistant Professor, SRM College of Nursing, to deliver the vote of thanks.
Thank you, Kavita ma'am. Gratitude makes a sense of your past, brings peace for today, and creates a vision for tomorrow. Thank you is such a prayer that cannot be seen or touched. It must be felt by heart. I feel honored and privileged to get the opportunity to propose a vote of thanks on this special occasion. I, on behalf of organizing committee, convey my hearty thanks to the management in obtaining the necessary administrative approval for organizing the event. They supported in all possible manner to organize the conference. I would like to convey my deep regards to hearty thanks to our eminent Vice Chancellor, SRM Institute of Science and Technology, for his vibrant speech on presidential note. I extend our heartfelt thanks to our Honorable Pro Vice Chancellor, Medical and Health Sciences, SRM Institute of Science and Technology, for his inspirational thoughts. I express my heartfelt gratitude to our Honorable Chief Guest, Dr. Bimla Kapoor, Professor and former Director, School of Health Sciences, who honored this event with her inspirational thoughts. I extend my sincere thanks to our Dean Medical, SRM College Hospital and Research Center. Sir, your thoughts have enlightened our minds. I extend my sincere gratitude to our CEO, Society for Nursing Practice, Bioleagues. We are all inspired by your great words. I extend my heartfelt thanks to our admirable Dean ma'am for her directions for the constant guidance and support for completing this 8th National Nursing Virtual Conference, a grand success. We are all inspired by your great words, ma'am. I also wish to express my gratitude to our respected Vice Principal, ma'am, for her minute-to-minute guidance and support and providing encouragement at every point of time of this great event. I would like to thank all the honorable plenary speakers and delegates for their enthusiastic participation in this conference. At this juncture, I would like to thank our organizing committee for their excellent support. I take this opportunity to thank all the reviewers and technical committee members for providing their valuable support and comments in time and help towards the improvement of quality of papers presented in the conference. A special mention to Professor Kalavali ma'am, Mrs. Usha Priya ma'am, Mrs. Priyadashini ma'am, Ms. Deepika ma'am, and Mrs. Selvi ma'am for your constant support during this event. I also very much thankful to all program committee members. We are not enough to thank their constant guidance and support to shape the conference. I am very much thankful to all our formal faculty colleagues and non-teaching staff members who always stand by us and motivate us. I feel proud and thank you for making this event a successful one. I cannot thank everyone enough for the involvement they have shown and the willingness they have expressed to take on the completion of tasks beyond their comfort zones. Once again, our heartfelt gratitude to all who made significant contributions for the event a grand success. And I also thank Mr. Gopinath sir for your support. Once again, our heartfelt gratitude to all who made significant contribution for the event a grand success. Thank you all.
Yeah. On behalf of the SFNP, Gopinath and the team, the CEO have extended a lot of good effort. Instead of he is not suffering with illness, but he has attended, he has delivered the validity that inaugural session, and as well the Gopinath all the time used to extend the help from the society. So really it is a welcomed note. So we are just having the feeling of we, and we used to take memorandum of understanding, and furthermore we used to extend your cooperations in all the way. So we are on behalf of SRM College of Nursing and our university, we are also thanking Priyadashini to coordinate with that Gopinath all the time. So everyone's contribution is essential to run the show. So this is what from our side, those who are left unnoticed also, please once again we are thanking each and every one of you. So for your kind cooperation, we expect the same cooperation in near future as well. So this is what, and some of the participants, they asked for the result published for the best paper. So I think the results are not yet been analyzed, I think. Yes, Kavita, who is the scientific committee. So
Yes,
is it ready, ma? They are asking for the result on that.
Malarmati, are you there, ma?
If it is ready, means you can very well present that one.
Malarmati.
Yeah, very much eager.
Yes, ma'am.
Eager to find out the result of the paper presentation.
No, Malarmati will be coming.
Yeah. Is it ready?
Is she ready? 1 minute. Ma'am, they are not ready with the results, it seems.
Okay. Then
and it will be
tell. Yeah.
They're not ready with the results, and I would like to inform to all the participants that the results are in the process of analysis, and it will be shared. It will be shared later in the email.
Okay, it is suspense.
Yes.
We keep suspense at the end, and then you just keep remember, and then everyone is a good winning. The first, second is not the matter. So I congratulate all are the winners. So for all the presenters, definitely you will get goodness of some kind of yeah. So and for the purpose of encouraging motivation only this one. So I believe all the 30 members who are presented are the winners from my side. Some token of love we may give you, so for to encourage. So irrespective of the first, second, whoever it might be, all the 30 members you will be given some token of love. Thank you so much for sharing your research knowledge in this forum. I congratulate all the 30 members. I believe all are the winners. Thank you so much.
Thank you, ma'am. Thank you, ma'am. We have come to the end of the day and end of the 2 days 8th National Nursing Virtual Conference. I thank each and everyone for gracing this occasion by your presence. And you have made this day a memorable one to mark in our diary by your presence. Thank you one and all. Thank you, ma'am.
So then end with the national anthem.
Yes, ma'am.
So the validity sessions, you are not taking photo. Priyadashini?
Ma'am?
Yes, ma'am.
After that or prior to national anthem?
Can we get one more glimpse from the team, from the participants? Can you please switch on the video?
Yeah,
yes,
the participants 95 till. Yes.
PPT change.
Hi, Malarvili. Hi. So she is from USA. She is attending the conference. We are very happy. Malarvili, somewhere I saw her. She hid herself.
Madam Malarvili.
All of you, please
switch on the video.
Switch on the video.
I request all the participants to switch on the video.
Oh no, she could not able to unmute, Thomas. Just make us a co-host.
Oh yeah. Malarvili, can you?
Yes, Kavita.
Yes, ma'am.
PCC.
Yeah.
Yeah. Hi, ma'am. Good evening to everyone.
Yeah,
so it was very enjoyable session for 2 days. I didn't sleep the whole night like yesterday and today.
So nice of you. So
yeah,
nice
thank
of
you, ma'am.
you.
Yeah, thank you, ma'am. You can see
Thank
my
you.
eyes. I didn't sleep
So
for
this
2
is
days. So
night time. That's what I'm just wondering now. Okay,
yeah,
thank you. Yeah.
it's like morning 8 o'clock for me now. From night like
So
like
make
night
you,
10
so
o'clock I
afterwards
connected.
you can have a sleep nicely.
Yeah,
Yeah.
sure, ma'am. Thank you.
Yeah.
Thank you so much
Thank
for the
you so
wonderful
much
conference,
for
ma'am.
taking good
Thank you.
effort in attending our
Yeah.
2 days conference. Really, it
Yeah,
shows
thank you.
your thirst of knowledge.
Yeah, thank
Definitely.
you, ma'am.
May God
Yeah,
bless you.
I
Yes.
thoroughly enjoyed all the presentations, ma'am. It was very excellent. Thank you so much, ma'am.
Thank you,
Yeah,
ma. Thank
I'll
you.
talk to you later, ma'am.
Yes,
Thank
ma.
you, ma'am.
Thank you, ma.
Yeah,
Thank
bye.
you. Thank
Yeah.
you. Be there in the picture.
Yeah, sure, ma'am.
They
Yeah, sure, ma'am.
taking a still now. Yeah. பிரியதர்ஷினி எங்க போச்சு? எடுத்துச்சா எடுக்கலையா பிரியதர்ஷினி?
Yes, ma'am. Yes, ma'am.
எடுத்துட்டுன்னா சொல்லு, எல்லாரும் சிரிச்சுக்கிட்டே உட்கார்ந்துருக்கோம். Is over?
Yes, ma'am, we have done, ma'am. We have done, and it has come out well.
Then you have to announce that. Yes. Thank you.
Thank you. Thank you, ma'am.
Thank you.
Let us complete the session by national anthem.
Yeah. Yes.
Thank you.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा। विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा। तव शुभ नामे जागे तव शुभ आशीष मांगे। गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे।
Thank you, one and all.
Thank you, ma'am. Thank you all.
Ma'am, can we wind up the
Yeah. Thank you all. Take rest for the 2 days struggle. Maybe within, I thank each and every one of you for your good cooperation. And within a short time, we have arranged. So we make it possible with all your cooperations. So we expect the same, some refinement, some corrections in some angle. It is there. We will critically analyze during the post meeting, and we need to correct if any error in future. Otherwise, it is going on well. It went on very well. So I thank each and every one of you, and you just keep all the knowledge which it can be reproduced into your practice in future, recall, and then you do implement the research and do a lot of laurels to nursing. So this is the request, and this is the aim of the conference. We need to gain knowledge from various sources, that too particularly the research knowledge, and that is the need of the hour. Kindly make use of it. So this is my request. So kindly follow it in your practice. So this is what the expectation of the conference. Thank you all. Thank you all, the faculty, students, and make use of the conference in an effective way, and you do well, and you enhance your research skill and improvement at the bedside. So that is the need of the hour. Please learn the technology and don't get fear on the technology. So a day will come, we too also win in all the way. So that should be the positive scope we need to have. Thank you all.
Thank you, ma'am. Thank you, ma'am.